values around 2, beyond which you would start anticoagulation, or 3 in women. And the choice of anticoagulation obviously would depend upon the various factors, depending on the underlying clinical situation. Now, there are a lot of other developments that are happening, because CHA2DS2-VASc score is not very accurate in identifying some of those so-called low-risk patients with CHA2DS2-VASc score of 0 to 2. And but this is work in progress, and I'm sure there are some new markers, including the ABC score, which might come up in the upcoming years as a better risk marker for patients with a low CHA2DS2-VASc score. But still, in addition to assessing the risk for stroke, it's imperative that we assess the bleeding risk also, because that also makes a huge difference in management of patients with atrial fibrillation. And if a risk score is 3 or more, that clearly identifies a person with an increased risk for bleeding due to anticoagulation or co-prescription. Between the two drugs, a DOAC or a vitamin K antagonist, the choice is pretty clear as of today. DOACs do work better. There is no doubt about that. They're effective, more effective than warfarin in preventing strokes in non-valvular atrial fibrillation. But remember, this is also dose dependent, because some of these are all non-inferiority trials, and some of these drugs have not been shown to be superior to warfarin. And this is one clinic condition where warfarin is a clear indication for anticoagulation. That is, patients with valvular heart disease, as defined as patients with moderate or more mitral stenosis, and patients with a mechanical prosthetic valve. And in patients who have got other valvular heart diseases, like mitral regurgitation, or who are mitral valve repair, aortic stenosis, and other valve associated diseases, these patients can, as of today, be managed with DOACs also. But remember that it's in a person who's maintaining good INR, on a vitamin K antagonist, and one of the ways to assess is using the same TTR score. It has been shown that when you compare the 3 drugs, dabigatran, rivaroxaban, and apixaban, in patients who are maintaining good INR values, there has been when it comes to stroke prevention, all these 3 drugs worked as well as compared to warfarin if the time in therapeutic range was more than 70%. However, remember that bleeding events were still lower in apixaban and dabigatran, but not in rivaroxaban. So we should be cautious when we prescribe drugs. We should be, when we are prescribing one of these DOACs, we should keep these evidence in the back of our mind. Now, whenever we are switching from a vitamin K antagonist to a DOAC, because for some reason that we feel that would be a better choice, it is important that this transition is done correctly. We have to keep the INR in mind before we make the switch. And the same applies when you're doing reverse, when we're shifting a patient who's on a DOAC to a vitamin K antagonist for whatever reason. Again, you need to be careful that you monitor your INR before you make that change. Now, whenever you have to choose a DOAC, I think so Rama is going to speak about this later, we should understand that not all DOACs are not equal. And for example, dabigatran is a prodrug which is heavily dependent on renal excretion. Bioavailability of rivaroxaban is quite affected by food. There are differences in the CYP cytochrome metabolism. Apixaban and rivaroxaban and are quite affected by it. And in Asians, dabigatran is supposed to have a more higher therapeutic levels. So this becomes an issue when you're co-prescribing drugs, such as with drugs like amiodarone and verapamil, which are quite commonly co-prescribed. Remember that all the 4 drugs, dabigatran, apixaban, edoxaban, and rivaroxaban, are resecreted into the gut, and this resecretion can be affected by drugs like amiodarone and verapamil, and the same thing applies to CYP inhibition as well, which can increase the levels. And therefore, if you're co-prescribing verapamil and amiodarone to a patient of dabigatran, you should be a little cautious, because you can cause over effect of dapigatran. The same applies to other drugs as well, especially anti-epileptic drugs like carbamazepine, levetiracetam, phenytoin, and valproate, all of which are strong CYP or a P glycoprotein inducers, and therefore, they can cause significant variations in drug levels. And also, this applies strongly to rifampicin. So, if a person is on ETT, you should definitely not using any of the four uh, DOAC drugs for their anticoagulation-related treatment. Dexamethasone is also an important drug that has a strong interaction, and this is especially relevant because in COVID times, this can be something that can be co-prescribed to these patients. Now, the second group of patients that I thought I would dwell upon is in patients with CKD whom we see quite often in our practice, and we know that we should know that AF is common in these patients. The prevalence of AF increases with increasing levels of renal dysfunction, and it is associated with an increased incidence of stroke, death, and progression to end-stage heart disease. And therefore, it's important that these patients do get anticoagulation prescription correctly. Now, these patients are also at risk for both thrombosis as well as bleeding complications because of the interaction of the disease with various other hemostatic, vascular and endothelial factors. And we should recognize that the current guidelines, the current evidence, it does support the use and has been shown to be effective in reducing stroke or embolism as well as major bleeding in these patients. However, remember that in all these four trials, the patients who had got creatinine clearance less than 30 were practically not there. And most of the patients had creatinine clearance between 30 to around 50 ml per minute, which is like mild to moderate kidney disease. And all of them use some sort of renal modification on the doses of when they were co-prescribed in these patients. So the current guidelines say that if the creatinine clearance is between 30 to 59 ml per minute, you should be using rivaroxaban in a reduced dose. Dabigatran and apixaban can be continued in the usual dosages. When you're using in patients with creatinine clearance between 15 to 30 ml per minute, endoxaban is clearly not recommended. Rivaroxaban and dabigatran have to be used in reduced dosages. But when it comes below 15 ml per minute, then none of these three drugs can be used. And the only DOAC, if you would like to prescribe, is apixaban. But remember, this is not borne out strongly from current scientific evidence. Warfarin remains the drug of choice, although there is concerns about the use of warfarin because warfarin has been associated with increased vascular calcification as well as glomerular hemorrhage in these patients, and therefore can lead to accelerated loss of renal function as well. Now, the same applies to patients who are having who are at risk for GI bleeding, because there may be some of our patients who have an increased risk due to co-prescription of drugs or other reasons. Remember that dabigatran, a dose of 150 milligram, or rivaroxaban in a dose of 20 milligram, is associated with slightly increased risk of GI bleeding as compared to warfarin, and therefore apixaban may be a better choice if that is the drug to be used in these patients. Edoxaban similarly should be avoided because that is also something that has been associated with increased risk of GI bleed. Now, there are many other situations, I'm sure, where you may prefer one drug to the other, and I guess Rama will be speaking about that later. Now, when we are using, the last group that I wanted to speak about was antiplatelets and antithrombotics in patients with AF and ACS or who are planned for PCI. Remember that current recommendations state that DOACs should be used continuously. If a patient is on DOAC, the DOAC can be used continuously, and clopidogrel would be a preferred second antiarrhythmic, second antiplatelet drug, preferably to be used for a period of about 6 months. And aspirin co-prescription can be given for about a month or so. And in patients who are in stable angina, it is pretty much similar. That what we should understand is that all these trials, there were 6 trials that analyzed the use of these drugs. they have shown that there is significant reduction in risk of major bleeding when you are using a DOAC with an antiplatelet, especially in reduction in intracranial hemorrhage. The risk of strokes is similar, but remember the risk of MI and stent thrombosis was actually higher when you use two drug regime, that is a DOAC with a single antiplatelet versus three antiplatelets. In fact, this is one of the recent letters that were published in JACC in which they analyzed the patients who had got a DOAC with with the two antiplatelets versus one antiplatelet, and it showed that patients who were on a single antiplatelet had an increased risk of stent thrombosis, a 60% increase in risk of definite or probable stent thrombosis. Therefore, there has to be, we have to understand that there'll be a trade-off, in which the risk benefit has to be weighed against the versus the risk of bleeding. And this is one of the recent publications that looked at this data a little closely. So when you're using a DOAC with a triple antiplatelet therapy, the advantages of aspirin continue in the first month, but they wane away after the first month of therapy, as you can see. So when you're using aspirin with the DOAC, use it at least for a month, because that decreases the risk of stent thrombosis and cardiovascular death in these patients. So my take-home message is that stroke prevention is essential, and that will depend upon our assessment of stroke risk. We should understand what is the DOAC that we're using. We should understand those pharmacokinetics and pharmacodynamics. Both an over-enthusiastic and an over-cautious approach is detrimental for patient care, because you should realize the Garfield AF registry recently showed that people, when they were underdosed or overdosed, they had worse cardiovascular outcomes. Antiplatelets alone have very limited utility in preventing strokes. And when you're using these patients with coronary artery disease, you have to exercise and balance the risk versus the efficacy carefully. Thank you for a patient learning.
Thank you, Nitish. That was a comprehensive coverage of your topic. And you brought very nicely out how one has to be careful and have a balanced view and approach in overlapping situations, especially CKD and post-PCI situations. I think we just got a message that we are not keeping to time. So I would request the next panelist to invite the next speaker, please.
Can I just ask one question to Dr. Naik, please, if you permit, quickly?
Yes, okay.
Yeah, so for the sake of audience, I would want you to talk about AF and hypertrophic cardiomyopathy, because I think that really comes, do we use the CHA2DS2-VASc score? We don't use the CHA2DS2-VASc score. Can you please spend a moment on that?
Yeah, so the AF in HCM is one of the indications where the benefit of anticoagulation using DOACs is not clearly established. Current guidelines also, say that we have to use them cautiously, because DOACs are associated with an increase. The data is not very clear on whether we should be using it. But there are ample number of people who have been included in these trials where DOACs can be used, and they have been shown to be safe. There are more studies in the pipeline which are going to establish the role of DOAC in this patient subset. But as of now, both warfarin and DOACs can be used in patients with HCM and AF.
Thank you very much. And also, I just wanted to highlight in HCM, we don't use the CHA2DS2-VASc scoring system.
Yeah, that goes without saying. Yeah, that's true.
That's a good point, Aparna. Thank you for sharing. Over to the next panelist, please.
Good morning, everyone. I would like to invite Professor S. Ramakrishnan, sir. He's Professor of Cardiology at AIIMS, New Delhi, for the next lecture on NOACs, choices, preferences, and cautions. Rama, sir, please, for the next lecture.
Yeah, thank you. Thank you for the introduction. And I think I would like to thank Mohit and Girish and the whole of Delhi CSA at putting this program possible. I think I'm going to briefly tell about the choices, preferences, and caution. And generally, when it comes to cardiology and CTVS, what are the areas where we look for anticoagulation? It's predominantly venous thromboembolism, where I think generally we can say safely that warfarin is gone, and almost now we have replaced with DOACs now. When it comes to stroke prevention in atrial fibrillation, except for select situations, I think mostly now it is DOACs. I will tell why. And even it is getting a role in things that are not considered an indication for DOACs, like coronary thrombosis, where antiplatelets and in acute settings anticoagulations were used. But now we have in different doses, DOACs have been tried with various success. And as Nitish pointed out, like in valve disease also, the role of DOACs is expanding. Like a bioprosthetic valve, now it is an indication, except the contraindications to DOACs compared to warfarin are limited now to rheumatic mitral stenosis and mechanical processes only. So I think now mostly everybody will agree that these are all DOACs is a better terminology, where we have dabigatran, which is a direct thrombin inhibitor, and an anti-10A inhibitors like rivaroxaban, apixaban, and edoxaban are the ones that are there. Discuss it now. Like every drug, like we get roughly around once in a decade we get a drug which is a blockbuster, and this was possibly 3 decades back. We got DOACs, and next we got ARNI, and next decade we got SGLT2 inhibitors, and this goes on in cardiology. And this is a drug, this wonderful drug. I think it has come to a stage now we really understand where it is actually the best use of this molecule is. I will try to give an overview of this, how best to use it. Like I will answer it a few questions. Like number one, are DOACs superior to warfarin, and will they replace in non-valvular AF and VT and thromboembolism? So clearly, I think over time we have understood the efficacy of these drugs in non-valvular AF, and clearly over time the event rates have come down, or compared to various agents, compared to initially antiplatelets, then dual antiplatelet, then came warfarin, then now we have the DOACs. I think generally they produce 1 less stroke than VKA for every 10 preventable strokes. But there are some issues initially concerned, like whether in a low therapeutic range, Asian patients and valve disease were the 3 major concerns. So hence almost all the recommendation, as Nitish pointed out, almost all the recommendation give a class 1 recommendation for DOACs. Another important question is, are DOACs safer than warfarin? So clearly, this is a meta-analysis of all the studies, like all-cause mortality was lesser, fatal bleedings were lesser. However, there is a slight increase in gastrointestinal bleeding. Myocardial infarction, though initially slightly higher with dabigatran, but then overall, all the studies put together, it is not higher. I think discontinuation due to side effects is there. But overall, major bleeding and fatal bleedings are actually lower or are same. So another important question, that is the safety and efficacy of in Asians, was put to question. And this is a very large, like 80,000 patients were there in this post-hoc study. It is not a randomized control trial, but it was 80,000 patients, Asian patients, clearly suggested that both ischemic stroke, the acute myocardial infarction, mortality, intracranial hemorrhage were all, and major bleeding were all significantly in favor of DOACs, even in Asians. So that one concern that we had, that Asians may not benefit from DOACs, is gone. So clearly Asians also. So hence the important question is, should we forget warfarin for all the venous thromboembolism as non-valvular AF? So one side argument is there is a stable antithrombotic efficacy. There are better stroke prevention in AF and prevention and treatment in VTE, and less major and fatal intracranial bleeding associated with equal or less resource utilization. So it's a strong evidence that possibly DOAC should and will replace VKA in both these indications. So another important question is, considering the cost, should we prefer DOACs in India? So how are we doing when it comes to anticoagulation? Most of us know that. How do we do? So this is in randomized control trials, which I think is a very good control setting. We are actually the fifth from the bottom. So I think we are terribly bad. I think in real life it will be worse than this when it comes to the target INR. And then important thing that we need to consider is that the time spent in therapeutic range has significant effect on efficacy as well as safety. So the more time you spend, the less time you spend in a good therapeutic range, your chances of stroke as well as hemorrhage increases. So I think this indication alone, this reason alone, we should be doing it. Another important question that comes is, should I put a patient on mechanical heart valves and DOACs? I think we all know this, the Realign trial surprisingly showed more thrombosis as well as more bleeding. I think mechanical valve is a clear no-no. But comes to bioprosthetic valve, this is a recent, the reverse study that is published in New England Journal last month in November, this month. So that has shown that clearly, I think in a bioprosthetic valve, rivaroxaban was non-inferior to warfarin with respect to composite primary outcome, with major events being lesser. So another important study that is looking at all the other forms of rheumatic valvular heart disease, Invictus study, is being initiated by one of my colleagues, Dr. Karthikeyan. So I think the results will be few more years to go. Coming to the choice of anticoagulation, so for most of the patients, the common garden patient who has blood score of 3 less than 3, all the 3 drugs are available. All the 3 are possible and available, and the low cost, greater efficacy, and possibly dabigatran is superior. Now with the other agents becoming off patent, I think the cost will also come down. But patients who have has blood which is more or high bleeding risk, we need to choose an agent which has the lowest bleeding, that is apixaban or dabigatran in reduced dose. This is for the overall consideration. I think CRF, Nitish dealt with very well. So special subgroups, patients who have GA bleed, we need to take an agent which produces lowest GA bleed, which is apixaban or dabigatran 110 mg. Serious dyspepsia, we should avoid dabigatran and use apixaban and rivaroxaban. Ischemic stroke, I think the agent that is shown to have greater superiority, if the stroke happens on warfarin, that is dabigatran 150. The patient has hemorrhagic stroke, better to switch over to a VKA or a LA occlusion, maybe a better choice. In a patient who has a previous stroke, that means for secondary prevention of stroke, I think the best evidence is with rivaroxaban and apixaban. So previous MI, possibly we may avoid dabigatran, and since the positive effect on ACS is shown, possibly rivaroxaban may be preferred in this subgroup. So these are the various choices in special subgroup. But in effect, like if an average standard patient, I think any of them are possible. I think cost becomes a major consideration in choosing the agent. So when an emergency surgery can safely be performed after stopping dabigatran, I think idarucizumab for dabigatran, adizaxantin 10A inhibitors are there. So what are the laboratory testings ever required for dabigatran therapy or DOACs? I think there are diluted thrombin time and ecariant clotting time both are available right now in Delhi, and anti-10A assays are also possible, may be done in select situations where you need to monitor the DOACs levels. So ultimately, with considering everything, are the DOACs worth the extra money that we pay? So I think clearly, as I told you, like we maintain a therapeutic INR of less than 49 in a trial situation, and in real life it could be roughly around 25 to 30%. So anywhere whenever the TTR is less than 50, clearly there is superiority of DOACs is in terms of cost, in terms of everything is very well proven. So this is a rough calculation of the previous prior DOAC cost. Still it was cost effective in Indian rupees. But with a one important caution is that warfarin is still superior in situations like pregnancy, valvular AF, especially rheumatic metal stenosis, mechanical valve, possibly GFR less than 15. If a patient is on 4-drug ATT and there is a bleeding with DOACs, and patients with LV clot, it may not be well proven. Arterial thrombosis, it may not be proven, and you can choose to continue on warfarin, as Nitish told, depending on the scope. And in Apla syndrome, I think still warfarin is the gold standard, and affordability, maybe affordability will become, DOACs are becoming more affordable with rivaroxaban and dabigatran becoming off patent. So lesson from history, possibly these were the kind of slides we were having, unfractionated versus low molecular heparin comparison. So in the earlier era, I think maybe these will be the few last presentations where we are comparing DOACs to warfarin in routine valvular AF and non-valvular AF and VT pulmonary embolism, because DOACs are almost likely to replace warfarin. But with the important caution is that we should use when clearly indicated, and we should not be using it in immediate post-MI. And a lot of off-label prescriptions are there, like in COVID situations and immediate post-MI. All those things we should avoid. We should stick to what are the recommended indications. Then DOACs are they're worth the money. Thank you. Thank you for patient listening.
Good morning, sir. This is Raghav, sir. I just wanted to ask a quick question, sir. So recently we had a trial published which regarding use of DOACs in LV clot, and the trial was around for 2,000 patients, which randomized patients to DOAC and vitamin K antagonist. So should we start using DOACs for LV clots after post-MI situation or even in dilated cardiomyopathies? So mechanistically, it should be plausible that we are able to use that drug, but somehow the data available is very less.
Yeah, I think with that trial, I think LV clot can become an indication. There are various trials that are emerging in the indications are expanding. I think real contraindications for warfarin or real contraindication for DOACs still only, I think, rheumatic mitral stenosis and mechanical heart valves. Rest of them are where the data is limited. That's all. Like even renal dysfunction less than 15, the data is limited. It's not that it's not effective.
So another thing, so can we put a patient at the rheumatic MR and AF and who had a stroke on NOAC? Or should we still
I think
continue to use
again the
warfarin?
data is limited. As per the current recommendation, you may put him on a NOAC if it is not an acute stroke. In the acute setting, still maybe because of the it may be preferable. Like it could. That's a big challenge. Like in immediate embolic stroke, when should we start anticoagulation? That's a separate topic in itself. So, but if you decide to start, I think in a chronic situation post stroke, maybe some time has elapsed, then I think you can potentially start NOAC. Even though limited evidence is limited.
So shall we move on to the next talk? Okay. I would like to invite Professor Rakesh Yadav. He's a very vibrant and master teacher. And this is an excellent morning session, and we would like to end up the session in an excellent manner with Professor Yadav's talk.
So please unmute, sir.
Yadav sir, please unmute yourself, sir.
So please unmute, sir.
Now, my job is to give a glimpse of sudden cardiac arrest, what is in approaches and modalities available. It's a huge topic. I'm trying to I will try to give a glimpse of what is sudden cardiac death, what is the magnitude of problem, and the most important thing, what modalities we have to prevent sudden cardiac death, and last in what is an Indian data in sudden cardiac death. And we all know the definition of sudden cardiac death varies from time to time. The actually WHO defined that death which occurs from cardiac pathology within 1 to 2 hours after the onset of acute illness. But we all believe that unexpected natural death from a cardiac cause is occurring within a short period of time. It is very difficult sometimes to determine the hours, but if it's a short time without any prior condition, that would appear fatal. We all know that sudden cardiac death has a huge public health problem, and approximately 5 million cases of sudden cardiac death is occurring globally, and the annual incidence is 5 to 100 per 1 lakh in Western countries, though it is believed that it is lower in Asian countries, and that is because we don't report and the data is limited, but I don't think it is less in Asian country. 10% of sudden cardiac death occur in structurally normal heart. That is very, very important. And if you have a sudden cardiac death outside the hospital, 2 to 50% reaches the hospital. But I think if you calculate the data from a developing country, it is less than 1%. And those who reaches the hospital half die before discharge. And even in hospital sudden cardiac death, if a patient is admitted in the hospital, and if it is a sudden cardiac arrest, the chances that he may be discharged alive is less than 1/4. In India, there's a data from 22,000 population studies which says that 10% of total mortality is a sudden cardiac death. Now, what are the various causes of sudden cardiac death? I think ischemic heart disease prevail, number one. Non-ischemic heart disease, cardiomyopathies, valvular heart disease, congenital heart disease, ARVC, myocarditis. There are sudden cardiac death when there's no structural heart disease, and that comprises of group of channelopathy and the conduction blockage. And there's a lot of causes of non-cardiac causes of sudden cardiac death, like pulmonary embolism is number one, drug-induced, and intracranial hemorrhages. According to age group, the most common cause of sudden cardiac death in elderly is a coronary artery disease, which comprises approximately 70% of cases. But when you see a sudden cardiac death less than 35 years, I think unexplained nature prevail the most. It is 40%. You don't know what is the cause. And this coronary artery disease still comprises less than 35 years, but it is 1/4 of the cases. We all know that the majority of the patient who has a sudden death, the arrhythmia behind them is a ventricle tachyarrhythmia, more than 85% cases, and bradyarrhythmia is about 15% of cases. Now, these are various risk factors which has been elaborated in sudden cardiac death, which include age, means older age, more chances of coronary artery disease. So age, sex, you are a diabetic, you are a hypertensive, smoker, obesity, dyslipidemia, if you have a family history, some ethnicity has higher chances of sudden cardiac death. And if you have a survival of sudden cardiac death because of ventricle tachycardia, ventricle arrhythmias, if you have a previous myocardial infarction, you have a low ejection fraction, various cardiomyopathies, both with or without heart failure, if you have a family history of sudden cardiac death, if you have a ventricle hypertrophy, or any evidence of long QT, short QT, Brugada, which are known as channelopathy, they all are risk factor for sudden cardiac death. Now, if you go to a community, yes, we all know that overall incidence in adult populations, overall, it is much less. But total event in adult population without any disease is much higher. And if you go by high coronary risk group, any prior coronary event, EF less than 30%, out of cardiac arrest, or convalescent phase of VT-VF, I think the chances of having sudden cardiac death is much high, but over of total event is less because these number of patients are very less as compared to a general population. Now, how to evaluate a patient of sudden cardiac death survival, or a patient who is more who has more chance of having sudden cardiac death in future? And I think history is very, very important. Never forget to take a proper history, which includes symptoms related to underlying heart disease, any precipitating factor of that syncope or sudden cardiac arrest like emotion or exercise. If patient is a known case, various other risk factors which I have enumerated, and what medication patient is on. Then past medical history is very, very important. History of thyroid, CRF, stroke, lung disease, alcohol intake, and explain more motor vehicle crashes. Then the most important thing, that family history. If you have a family history, take a proper family history of sudden cardiac death and various other heart diseases. And then examination is also important. Properly physical exam is mandatory when you are evaluating these patients who are a survival of sudden cardiac death. ECG markers. What ECG markers can predict that this patient may have a sudden cardiac death? So this is a very common thing, that by seeing the ECG, a physician can refer this patient to a higher evaluation center, that this patient might be having a higher chances of sudden cardiac death. And these are various ECGs manifestation which can indirectly suggest which required a further evaluation of these patients, like Q waves. If you have a QT interval prolongation or shortness, your QRS duration is broad, you have a left ventricle hypertrophy, you have a fragmented QRS complex, you have a early repolarization symptoms, your PR interval is prolonged, you have a bundle branch block, you have an AV block, and there is some calculation like T peak to TN interval, QRS to T angle, and other specific changes which can tell you that this patient might have high chances of sudden cardiac death. Now, what are various ECG's manifestation in these patients? Now, if you see a long QT interval, these patients are a higher chances of sudden cardiac death. Even if you see a short QT interval, and what do you mean by a short QT interval? If your QT interval is less than 300, in asymptomatic patient 320, and if we have a patient who has a history of syncope or the survival of sudden cardiac arrest, your QT interval less than 360 make them a short QT syndrome. Then you can have a Brugada-like pattern. And what is a Brugada-like pattern? When you have a ST elevation, you have a curved ST elevation in lead V1 with an incomplete RBB morphology and T wave changes from V1 to V3. You should always look for Brugada syndrome. These patients have higher chances of sudden cardiac death. If you have a QR broadening, Suppose you see this ECG, and this ECG is typical of QRS LBB morphology. Even with an LBB morphology, it has been seen if the patient is a known case of any structural heart disease, these patients are having higher chances of sudden cardiac death. Even their LV function is normal if it is a known case of post-MI or coronary artery disease. Now, when you see a WPW syndrome, now it is very clear a subset of WPW syndrome can lead to sudden cardiac death. That's why even now it is recommended if a patient is symptomatic WPW, he required ablation to prevent sudden cardiac death. And invariably, WPW with atrial fibrillation has a higher chances of ventricular tachyarrhythmia. So these, if you see these type of ECGs, there are higher chances of sudden cardiac death. Then ARVC, if on ECG you see an epsilon wave, a T wave abnormalities from V1 to V3, you should always look thoroughly this patient and evaluate this patient, that this patient has higher chance of sudden cardiac death. Same thing when you see a deep T wave inversion, a deep broad narrow Q waves, which indirectly suggests that this patient may be harboring hypertrophic cardiomyopathy, so they are higher chance of sudden cardiac death. On early repolarization syndrome, don't ignore early repolarization syndrome. Type 3 early repolarization syndrome or some variety of early repolarization syndrome has higher chances of sudden cardiac death. And left ventricular hypertrophy, if your ECG suggests left ventricular hypertrophy, investigate these patients to know what is the cause of this, because these patients are having higher sudden cardiac death. On ECG, if you see are very rapid VPCs, multifocal with short Q RNT, then these patients are in higher chances of sudden cardiac death. If even you have a left ventricular hypertrophy, no, if you have a right evidence of right ventricular hypertrophy, you should further investigate these patients so that because they have a higher chances of sudden cardiac death. When you have looked the ECG, always subject these patients to echocardiogram to know three important things: the LV function status. It may be a systolic function and diastolic function. Now there is evidence if you have a diastolic dysfunction, you have a higher chances of sudden cardiac death. And any evidence of any structural heart disease, and sometimes you can see coronary anomalies in these patients. So echo is a very important tool for investigating these patients. And there's a specific supportive tests like ambulatory electrocardiographic monitoring like Holter and loop recorders, stress test, coronary angiogram, EPS, heart and genetic studying. Depending upon the patients, you can subject these patients to these various investigations. Now, this is very important. 68 years old male with history of one episode of syncope while walking in summer hot day. You have evaluated everything, echo normal, TMT normal. He has a normal angiogram also, but when you subject this to Holter, he was diagnosed as ventricular fibrillation and given and advised ICD. However, you should be very cautious in seeing Holter artifact. This is a Holter artifact. This is not a ventricular fibrillation. So when you are subjecting these patients to this, you should always look for Holter artifact. Otherwise, you may have some misdiagnosed and advised the wrong thing, which is not needed in the patient. So sudden cardiac death management depend upon acute management and long-term management. And acute management, these guidelines is really clear. You have to do CPR. If there's hemodynamic and unstable ventricular arrhythmia, then intravenous amiodarone to be given. Patient should, if it is because of acute ischemic situation, then you have to subject these patients to urgent angiography or revascularization. So these are the guidelines which has been given in the literature, but these are which when you should not do anything. Like a patient with cardiac arrest, don't give very high dose of epinephrine. Patient with refractory VF not related to tarset, IV magnesium is not going to benefit, but something is going to harm. Never give verapamil and diltiazem in patient with broad QRS tachycardia. It can potentially harm. And patient with suspected MI, prophylactic administration with lignocaine or high dose amiodarone should not be given in this patient. And long-term management, or known as secondary prevention, depend upon the etiology. You have to investigate this patient thoroughly, and then these are the various modalities like drug, ICD, ablation, surgery, or hybrid procedure, which you have to advise to this patient. The ICD trials, I think in secondary prevention prophylaxis, there's ample data, and now we don't require any more study to show that ICD is beneficial in these patients. So this is an algorithm for secondary prevention in patient with ISD. If he has sudden cardiac arrest survival, then and it is suspected spontaneous monomorphic VT. If it is ischemia, then revasculate them. If there's no, then give an ICD. And if it is LV ejection fraction is less than 35%, straight away ICD. But if LV ejection fraction is more than 35%, I think you can go for EP study and then decide accordingly. One myth is there that patient is having stable VT. And stable VT usually do not generate to unstable VT, but it is a myth. And there's ample studies which say the ventricular tachycardia, which is stable at the time, next time it can be unstable. And the second important thing, the confusion that antiarrhythmic drugs are quite effective. No, with antiarrhythmic drugs, the recurrence rate of the ventricular arrhythmia in these patients is more than 50%. So only antiarrhythmic drug is not affecting in a secondary prevention in these patients. As far as primary prevention is concerned, I think there's an ample studies which says that primary prevention helps by giving ICD, and it improves the mortality in these patients. And why it is important? Because we know that if patient has a sudden cardiac arrest, less than 8% in an international literature, but if you go developing country, less than 1% reaches hospital. So primary prevention is very important, that patients should not have a sudden cardiac arrest. And there's ample data which shows that the ICD, the primary prevention based population study, if you treat them, they benefit a lot. About if post MI low ejection fraction, over 2 years, there are the chances of about 15% going for sudden cardiac arrest. And there is ample more than 30% reduction in arrhythmia when you give ICDs to these patients. And this is an algorithm of primary prevention. Your EF is less than 40, MI is less than 40 days, and or revascularization less than 90 days. If it's no NYHA class less, then ICD to be given. NYHA class 2 or 3, then again ICD to be given. So this is an algorithm which is being mentioned how to advise ICD or other therapy in cases of primary prevention. Now the benefit of ICD in post-MI patient in low ejection fraction is proven. However, the cost inhibit its regular use in developing country, and this is a data less than 1% receives ICD who are needed in this situation. And it is also well-known fact that attitudinal variation among population may influence the long-term outcome of CAD patients. So it is being presumed that in Asia and India, it may be possible the chance of sudden cardiac death is less in post-MI patients. And there's a data in Japanese, they also say the data in China, and there is which also suggests that the chances of sudden cardiac death are is less in their post-MI patient. So we have conducted a study in our setup. This study is published in Indian Heart Journal, 145 eligible patients who qualify the MEDIT2 criteria. And these patients were subjected for 2 years follow-up. And these subjects are, the presence of NSVT in Holter were about 20%, PVC more than 10 were about 21%. And all the patients are optimally treated. More than 95% patients receive beta blocker, ACE inhibitor, statins, and aspirin. So they are optimally treated patients. The follow-up is about 20 months, and we all see that 18 patients died due to sudden cardiac death in 2 years follow-up out of 145, and there's total 26 patients who died. And Kaplan-Meier curve shows that 3 important things: no use of beta blocker, history of revascularization is protective, and if patient creatinine is more, it is harmful. So, and we compare this patients with MEDIT2 conventional therapy. Though if you see, we are less hypertensive, we are less diabetic, we are less smoker, we are optimal treated. Our risk factor is less, and we are optimal treated. But the sudden cardiac death is even more than the Western population, and overall death is equal to the Western population. So we concluded that our population has higher SCD when compared to MEDIT2 conventional therapy arm, and this study has concluded that our population may be benefited in a similar way as the MEDIT2 with prophylactic implantation of ICD. Coming to last 3 slides, coming to the non-ischemic cardiomyopathy, I think there is some controversies which has emerged recently, but everybody believes that controversy is not sustaining more. Even in non-ischemic cardiomyopathy, the ICD is going to benefit in these patients, as though it may be slightly less than ischemic cardiomyopathy, but it is also effective in non-ischemic cardiomyopathy. We all, in the end, I can say the knowledge is the process of piling of facts, but wisdom lies in its simplifications. Thank you very much.
Good. So thank you all the speakers for such an excellent talk today. And I will request attendees, if they have any questions, they can type in Q&A box. Currently, I am not able to see any Q&A.
Hello? Hello? Hello?
If there are no more questions, we move on to the next session on the lipids. And I request that all the chairpersons and speakers, if they really wish, will benefit from their wisdom, they can stay along with the next session also. And the next session is the lipid saga, the journey so far. We have the chairs as Dr. Tarun Kumar, Dr. Harshvardhan, Dr. Rajiv Bajaj, Dr. Rakesh Sood, and Dr. Samir Kubba. Our esteemed speakers, Dr. Sani, Dr. Puri, Dr. Vimal Mehta, and Dr. Anil Dhal have already joined. And I request the chairpersons to please start the next sessions. Time is of essence, so if we stick to the time, we will have good for discussion. Please.
Hello,
Good morning, everybody.
You can please start, please.
Good morning, friends. This important session.
First speaker is Dr.
On the session of important the lipid saga, we have the first speaker, Dr. JPS Sani, who will be speaking on familial hypercholesterolemias, the journey so far, and how it is important for in Indian context. Everybody knows Dr. JPS Sani. He is director and head of the department at Param Hospital. And there's a lot of work in epidemiology and prevention of coronary artery disease. May I request Dr. Sani to please share his screen and start his talk.
Yeah. That's right. Thank you, Dr. Harshvardhan. Thank you, Dr. Mohit, and Csi Delhi branch for giving me this opportunity to give a talk on familial hypercholesterolemia, once thought to be a rare disease, but now we know that is not that rare. So today, with the help of 2 studies which we did in the country, I would like to discuss with you how to diagnose and manage this clinical entity. We all know that various risk factors, they contribute to the atherogenesis, and most important risk factor is lipid disorder. And we know that LDL synthesis is mainly from the liver, and which is largely genetically determined. And the familial hypercholesterolemia is the most common genetic disorder of metabolic origin, which has a autosomal dominant inheritance. It's not rare. We probably don't look for it. And this is true not for our country, but even for the developed nation like USA, Australia, Japan, the pickup rate is less than 1%. But some of the countries like Netherlands, Scandinavian countries, UK and Switzerland, where their pickup rate is approximately 40 to 70% from the community because of good healthcare system. We are also aware of the fact that there are 2 varieties. Fortunately, homozygous is rare, 1 in 1 million, which has these patients generally have LDL above 500 milligram, and they come with early atherosclerosis, stroke, and heart attacks in first and second decade. In last year, we had 3 children in homozygous group having similar type of problem. The more common variety is the heterozygous familial hypercholesterolemia, which is now the prevalence of incidence is 1 in 200, 250. Again, they have very high cholesterol levels because of receptor defect on the hepatocyte. And they generally come with premature cardiovascular disease in 4th or 5th decade. And we are also aware of the fact that Dr. Brown and Goldstein got the Nobel Prize in '85 about this discovering this condition. Now, in spite of 35 years old story, we are still under diagnosis, under treating this clinical entity in clinical practice. This is a recent paper published in European Heart Journal, where they look into the frequency of with frequencies 1 in 250, looking into the prevalence of this disease globally. And there is a rough estimate based on the LDL cholesterol registries, and the genetic testing shows approximately 45 million population in the world is suffering from this disease. And where we live, South Asia, Southeast Asia, China, we have the highest concentration of FH population, 17 million population. It is now rough estimated that approximately 5 million people are suffering from FH in our country. So we know that the gold standard is the genetic testing looking to this fact, but in the absence of genetics testing available in the country, the clinical diagnosis is very important. And for that, the EAS and ESC guidelines has given a very simple scoring system based on which we can diagnose clinically the FH in practice. So this is based on the score system. The score is between 6 and 8, then it is probable, and above 8 is definite, and 3 to 5 is possible. So above 6 has been now validated with the genetic testing and found to be very good correlation between the two. So this is a very simple scoring system. If a young patient comes to you with coronary artery disease, that means less than 55 men, less than 60 women, then you get 2 points. And if you look into the detailed family history and similar age group, looking at any vascular disease, let it be MI or stroke or peripheral vascular disease, you get 1 point. And then we look into the LDL level. If the LDL is above 150 to 190, you get 1 point, above 193 points, and above 250, it is 5 points. So if you have very high level of LDL cholesterol, certainly we are dealing with this group of population. Then we have to look into the physical examination, and we found tendinopathy is not very common in heterozygous group, but it is always seen in homozygous group of FH. But arcus cornealis in younger group population, less than 45-50, has found to be good. In our experience, we found this is a very good marker. This is a grayish deposit, semicircular deposit on the edge of the cornea, more commonly seen in the upper part of the cornea. For that, you have to lift the eyelid to identify this physical finding. And if it is there in young person, then it gives you 4 points. So that becomes a clear-cut clinical diagnosis that this is a patient of FH. So young MI, family history, high cholesterol, and if you get an ARCUS, that means nothing but FH. And other group where ARCUS is not there, we can say that this is probably may not be FH. But the problem is around 20% of the patient, those who come to us in clinical practice, they are already on statin. So this scoring system, the LDL is on statin naive patient. Now, how to diagnose that? That we have the Dutch Lipid Clinical Criteria Network has given us a adjustment factor for various statins for various doses now, which is available, which gives you roughly untreated LDL levels. For example, I had a patient who had who was on atorvastatin 20 milligram and came with acute coronary syndrome. We did the lipid and found the LDL was 110. For 20 milligram of atorvastatin, the adjustment factor is 1.8. So that comes to around 198. Above 190, we know the score is 3. So with this, we can calculate this simple method of that. But although the DNA analysis of mutation of the LDLR, ApoB, and PCSK9 are the gold standard, but in the absence of that, this is a very good method, an easy method to diagnose FH clinically. And the guidelines of ESC have recently said that every patient of young MI with high cholesterol, one should look for FH. And if we found the levels that we have clinically diagnosed, put them on high doses of statin or HTMI along with that to bring the LDL to less than 55. And if it is not achieved, then we can add PCSK9 inhibitors. So this is one part of the story. The treatment is not complete unless and until we have done a family cascade screening. What is family cascade screening? If you have diagnosed an index case, look into the family members, siblings, and the children above the age of 8 years, do a non-fasting lipid profile. And if the level is LDL is more than 150 for a child and more than 160 for adult, that means he is a patient who is a carrier of FH in this index patient who scored more than 6. Now for that, the treatment guidelines are now there for children is available. We should keep the LDL to less than 135 in this patient. And we have seen with our experience that small doses, moderate doses of statin are enough for these children to reduce the level to this goal. But since the lifelong treatment is there, then generally it is desired that one should do a genetic testing and confirm this population. So what we have learned that by diagnosing a case of FH, we do not identify a case, but a family at risk. So that is very important message if you want to continue. So algorithm is very clear that if you are potential FH, treat them with a high dose of statin, do a cascade screening. If you find a carrier, then start them in small and moderate doses of statin. This is how we should treat this population. So now I will share with you a couple of the studies which were done in our country, only one at the moment available. So we look into the premature CAD population, and which was published in an Indian journal last year. And what we look into the young coronary artery patients, so about all the patients we found in our hospital, 45% patients are young. And we look into the risk factors, tobacco, diabetes, hypertension, and dyslipidemia. And from dyslipidemia patient, we started looking into the FH population. And we were surprised to know that the potential FH, that means those who have got probable FH or definite FH, 17% of the patient were having FH in our trial. This is this data now is almost 1,200 patient young MI, which is a very, very big number. And when another important finding which we found that in young coronary artery disease patient, we look into the risk factors and comparing the FH group versus the non-FH group in younger population, we found generally FH group, particularly with definite and probable, they have associated risk factors were less, like diabetes, smoking, and hypertension was less with them, whereas non-FH group or possible FH group have slightly higher risk factors. And other way around, we found that generally this definite group or probable group have higher cholesterol levels, and this non-FH have little less cholesterol levels. So what we have learned now, another important finding, that one should suspect FH in young CAD, those who have got high cholesterol but do not have associated risk factor like smoking or diabetes. One should always look for that and try to exercise the use of the Dutch lipid clinical criteria to diagnose this condition clinically, so that we can save few more patients. Similar paper was published last year in JACC from Boston group from Harvard Medical School, and they look into 2,000 patients against our 1,200, and they found 10% incidence in young coronary artery disease. And another paper came from Australia, Sydney. Their incidence in young MI was 14.3%. So the other study which we did, which in fact has given me confidence to do studies and research in this area, was the genetic study which we did along with Professor I.C. Verma from the genetic department. And we looked into the genetically confirmed patient of FH and did the cascade screening of them. So what we did, we took 100 patients and after excluding the secondary causes, did the mutation analysis of the LDL receptor, LDLR receptor, ApoB, and PCSK9. And those who came positive, then we looked into their family members and did the lipid and genetic testing. And what we found that out of this patient, that 47 patients came out to be the genetically positive, and majority of them are LDL receptor. As we know in literature, also 90% of them, those who have got genetic mutation, that is in LDL receptors, and 5% each in PCSK9 and ApoB, they are rare. And when we did the cascade screening of this, out of the 43 cases of LDL receptor mutation, we took 134 family member of this patient and looked into the lipid, did the genetic testing of these the family members. And we were surprised to know that out of 134, 95 were having positive genetic testing. That gave me a great confidence that this disease is existing in our country and we are not looking for that. And out of that 95 members, 16 were less than 18 years of age, and they are already on statin now. So coming to the management of this disease, and we know that the young MI gets disease at 55 and heterozygous will get in fourth decade. But the timing of the starting of statin is also very important. If you start statin early at the age of 8 to 10 years, then we will push the disease by 2 decades, definitely. If you start late around 2025, we will definitely push it, but not to the same extent. So very important is that in young population, in children, we should start statin in this population, those who have been diagnosed to be a carrier of FH, so that we can prevent a premature CAD in that family or in the society. So for one patient, of index patient, we can save 2 or 3 more lives. So that is the importance of diagnosing FH in clinical practice. This is the data which has been now published in New England Journal of Medicine, looking into 20-year follow-up of statin in children. And they found now that this drug is very effective in lowering the LDL without producing any side effect or any growth problem or sex hormones in these children. And when they compared this using of this statin in them and compared with their parents, those who are also suffering from this disease, and they found the starting earlier in them have resulted in reduction in cardiovascular event and cardiovascular death. So that shows that this is
a very, very important slide, Dr. Sani. The time is up. Can we go to
just a minute? So this is a study going on at the moment, which is the registry which is going on, and we look into this, and we are participating in this registry and Dutch lipid donor. So the PCSK9 inhibitor will be discussed by Dr. Anil Hall. We know this drug, which is very effective in reducing the LDL cholesterol significantly, and this is the drug not only reduces LDL. Is a strong association which we have seen in our population. So before concluding my talk, dear friend, I just want to share with you that even Da Vinci, when making a portrait of Mona Lisa on Lisa Gerhardini, he picked up the finding of genital asthma and tendinopathy at this point. And we believe that Mona Lisa also had a mature disease. So in conclusion, dear friends, the FH is most common metabolic disorder, despite health risk. It is inadequately diagnosed and managed in our country and everywhere in the world. Is not rare. We miss it because we don't look for it. Dutch lipid clinical criteria, which is now considered to be gold standard, is a very simple way to diagnose this clinically for every premature CAD. For our country, I say even LDL above 161 should be very careful in diagnosing this condition. Cascade screening is a part of the treatment. Unless until we do that, we pick up the asymptomatic carrier of that, and we can prevent premature CAD by starting statin in this group. In our study, we found 17% of the patient with premature CAD as FH, and high dose of statin with or without HMI is required in most of the patient, but still this group of patients, they need PCSK9 inhibitor. Thank you very much for your kind listening.
Thank you, Dr. Sane. It was a wonderful presentation, and I'm sure we'll have some more discussion at the end of the session when some questions will be forthcoming. May I request my co-chairperson, Dr. Ajib Bajaj, to introduce the next speaker and go ahead with the next talk.
Thank you. So we'll take the questions in the end, and I don't have the program in front of me. So can you please introduce the next topic?
Next topic is setting the right lipid targets, and to give this talk, we have Dr. Raman Puri, who is doing a wonderful work with the Lipid Association of India and has done a very good review of the lipid level and set new targets for lowering the LDL cholesterol levels, particularly for the Indian population. May I request Dr. Raman Puri to give his talk on setting the right lipid targets, particularly for the Indian population. Dr. Raman Puri, please.
Thank you, please unmute yourself, Dr. Raman Puri, please.
Am I audible or not?
Yeah, now our voice is a little low, but you can be a little louder.
Okay. Thank you, Dr. Harshvardhan, for your kind words. And for the first, I would like to thank Dr. Mohit to give me an opportunity to talk on this topic. And this is a very important slide because based upon this slide, this high intensive statin versus moderate intensive statin trials, in which high intensive statin, the mean LDL cholesterol achieved was 75 milligram. 2004 update recommended LDL cholesterol less than 70 milligram with CSD or CSD equivalent. And it had a strong impact internationally because once this guidelines was released, there was a significant decline in CVD mortality in United States. Not only in United States, even European countries also had about 50% reduction in cardiovascular mortality. The Indian statistics, there is increase in CVD mortality to an extent of 41% from 1990 to 2015. There are a number of reasons, explanations given for it. And before we go for the explanation, remember that approximately 25% of those dying of coronary artery disease are less than 40 years. We develop heart disease 10 years earlier than other ethnic group, and we have more severe diffuse disease and higher mortality. Even ACC has now considered Asian ethnicity as a high risk ethnic group. One of the important reasons why we have higher, cardiovascular disease is that we have high prevalence of atherogenic dyslipidemia. We have normal or mildly raised LDL cholesterol and low HDL cholesterol. And there are other factors also, but there is an increased prevalence of other traditional risk factor, high prevalence of central abdominal adiposity, and we develop risk factors at much younger age, and we have low control on all these modifiable risk factors, and there is poor awareness also. Now, this is just to tell you that how we are prone to have heart disease. I have calculated 8 lifetime risk score in a 40-year-old Indian male who doesn't have any risk factors, and his cholesterol to HDL is 5. Means if LDL is total cholesterol is 150 and non-HDL is HDL cholesterol is 30, the ratio becomes 5. Not a hypertensive. His weight is BMI is normal. Remember, his lifetime risk of coronary artery disease is 37.4%, which according to earlier recommendation is moderate to severe. And if we put the same parameter in other ethnic group, same, cholesterol to HDL ratio, it is the lifetime risk is 25%. Remember, just at 40 years, we carry approximately 12.5% more risk as compared to Americans and European. That is what is the reason why we really needed our own recommendations, because these recommendations were based upon this life score. And this is much lower than what Indian suffers from. Now, if you look into some amazing trials, you can see that on all those amazing trials, if you look into the LDL and HDL ratio, in those in which the LDL to HDL ratio was low, as in reversal trial, Asteroid trial, Meteor trial, Saturn trial, and Yellow trial, there was a definite significant regression in percent atheroma volume, or there was at least no progression or very less progression was seen in this group of patients in which the LDL to HDL ratio was low. And even if you look into the inter-heart study, which shows that those high ApoB and high ApoB to ApoA ratio is a predictor for cardiovascular disease, especially acute MI. So, and this is an important slide which shows that if you look into the change in percent atheroma volume, somewhere around 70, it is approaching this unity line, and as it goes down, somewhere around 50, you can see that there is majority of patients are going to have regression in percent atheroma volume. So this is the level which we recommended in 2016, that this should be the target in our Indian population, taking in view that we have normal or only mildly raised LDL cholesterol and about 70% prevalence of low HDL cholesterol. And this is our recommendations of less than 50 milligram in very high risk group patients, which means patients with coronary artery disease, peripheral artery disease, or CVA. Of course, in 2019, European guidelines also, recommended a goal of less than 55 LDL cholesterol in patients with ASCVD. And of course, that endorsed what we said in 2016. But remember, in IMPROVE-IT trial, despite achieving LDL cholesterol of 53, about 32% of these patients had residual cardiovascular event. We published in March new recommendations in Journal of Clinical Lipidology. Another recommendation was published in JAPI in 1st November. And here we have created another group, which is an extreme group, which is further categorized into category A and category B. Category A is patients of coronary artery disease with one or more features of high risk group, and category B is patients of coronary artery disease with one or more features of very high risk group. And we have included 3 moderate non-conventional risk factors instead of metabolic syndrome. And the goal which we recommended is in category B, the goal is less than 30 milligram. And in extreme risk group, the goal is less than 50, but optional goal is less than 30. I would like to justify that why we came to a conclusion of less than 30 milligram LDL cholesterol in Indian population. This is based upon a strong scientific evidence that which is from the Fourier trial, 2 meta-analysis, 3 post-hoc analysis, and genetic studies. The Fourier trial, in which we can see that when LDL cholesterol was reduced from 93 to median of 30, there was significant reduction in primary endpoint, which was about 15%, and there was 20% reduction in CV death, myocardial infarction, and stroke. And in one of the very large meta-analysis, which we call CTT meta-analysis, those patients who had baseline LDL cholesterol of 70, when LDL was reduced by 40 milligram, there was 37% reduction in major cardiovascular event. Even in this was seen in non-statin trial, and also in an IMPROVE trial, there was 6% of patients who had LDL cholesterol achieved around less than 30 milligram had about 21% reduction in primary endpoint as compared to those patients with LDL cholesterol more than 70. In Odyssey trial, there were about 7% of patients who achieved LDL cholesterol less than 15 milligram, and which were subsequently grouped into a placebo because the dose was reduced and patient was put on placebo. When they were compared with 2,140 propensity matched patient, it was found that there was about 29% reduction in primary endpoint when the LDL cholesterol was brought down to 15 milligram per deciliter. This was seen in Fourier trial also, and we all know that full-term fetus have an LDL cholesterol of about 28 and neonate has 32. And even the genetic mutation, loss of function mutation of PCSK9 have shown that if you have ultra low value of LDL cholesterol, they have much less cardiovascular event, and despite they are intelligent, they are fertile, and there are no neurocognitive dysfunction in this group of patients. So coming to the justification why we created a new extreme risk category, we all know that depending upon number of these clinical variables or comorbidities, the risk increases in patients with coronary artery disease. Similarly, when we apply this TIMI risk score to patients with improved IT trial, those patients who falls into high risk group have more events, greater benefit with the treatment, and despite having a treatment and achieving LDL cholesterol of 53, they still have a much higher event as compared to intermediate risk group. And this was seen in Odyssey outcome trial also, where you can see those patients who has 3 vascular bed involvement, they had more events, greater benefit in reduction in events, but still this, despite of this, they still have more event as compared to those patients who are in the with the 2 vascular bed or 1 vascular bed. This means that the greatly benefited, there is a maximum benefit in those patients who have extreme, risk. As you can see, the NNT was 8 only with patients with 3 vascular bed. This was seen in Fourier trial also, in which we achieved mean LDL cholesterol of 30, that those patients in high risk groups still had even significant event as compared to those patients with intermediate or low risk group. This is very nice slide because it shows that as the comorbidity increases, this is from improved IT trial, there is increase in risk of cardiovascular event going up to 54% as from about 28%. Now, coming to our extreme risk assessment methodology, how we created this extreme risk group, this was based upon 10 years ASCVD risk. If it was 29%, these patients were classified as very high risk group. 30 to 39, it was category A, and more than 40, it was category B. See, there are so many comorbidities, it will not be possible for you to spend time on this. So we simplified it in saying that if a patient of coronary artery disease has 1 or more features of high risk group, classify this patient into category A, and those patients who have coronary artery disease with 1 or more features of very high risk group, that is classified as category B. And this is, I'm going to finally tell you the justification for our, Indian guidelines, expert consensus. Despite following ACC and European guidelines, the CVD mortality in India has gone up by 41% as compared to decline in United States and Europe countries. Europe had disease 10 years earlier than Americans. Approximately 25% of those dying of coronary artery disease are less than 40 years of age. We have more severe coronary artery disease, which carries a higher mortality. We have atherogenic hyperemia, as I already discussed before. And remember that we have high ApoB to ApoA ratio as per Interheart study. Even then we have, that is one of the explanation for coronary artery disease, high prevalence of coronary artery disease. And we have high prevalence of small, increased small dense LDL particles. And there is increased prevalence of other traditional risk factors, central abdominal adiposity, increased number of comorbidities and risk factors at a younger age group. LDL cholesterol in Indians is around 106, in Americans is around 106 as compared to 94 in Indians. This is based upon ICMR in DIAP study. And despite having a lower LDL cholesterol, we have higher cardiovascular event. Even now, European guidelines has come down to recommended LDL cholesterol less than 55 against R50, but they have recommended LDL cholesterol less than 40 in patients with recurrent ACES, which is 30 in our LDL group. From which this number 40 has come, we are not able to understand so far because there is no trial or strong meta-analysis which gives us any clue of less than 40, but we have a very strong evidence of less than 30 milligram for our recommendation. And of course, South Asian ethnicity is a risk enhancer in ACC 2000 guidelines, and lowering LDL cholesterol to 30 milligram will definitely reduce event, as I have already documented that in Fourier trial and post-hoc analysis of improve IT trial have shown these good results. And of course, we should also remember that the physiological level of LDL cholesterol is 25 milligram per deciliter as per Goldstein article. And most of the newborn baby have an LDL cholesterol in the range of 30 to 40 milligram per this thing. Regarding triglyceride and non-SDL, I think Dr. Vimal Mehta is going to talk about the non-LDL ASCVD risk beyond beyond LDL cholesterol. So with this, I thank you for your kind attention.
Sir, you are muted, please. Dr. Harshvardhan.
Yeah, it was a wonderful talk, Dr. Aman Puri. May I request now another co-chairperson, Dr. Samir Kubba, to introduce the next speaker, Dr. Vimal Mehta. Dr. Kubba, please.
Yeah, thank you very much. It's a pleasure for me to introduce Dr. Mehta. He has been my esteemed senior at Maulana Azad Medical College, and I have learned a lot from him. And we all know that we are talking so much about LDL, but our part of the planet probably has more of an issue from triglycerides and non-LDL cholesterol also. And we have seen that many of our patients may have normal LDL levels and still have MIs, and we have found that the triglycerides are quite high. So I think on that topic, Dr. Vimal is going to throw some light. For Dr. Vimal, please. Thank you.
Yeah, hello. Am I audible and visible? My slides are visible, sir?
Yes, sir.
Yes, sir. Perfect, sir.
Yeah. So at the outset, Dr. Samir, thanks so much for such kind introduction. I'm really overwhelmed. Now, this is ASCVD risk beyond LDL-C. I've been part of various multinational study, importantly Fourier study, and have personal vast experience with the new PCSK9 inhibitors. Now, multiple randomized trials have shown that statin reduce morbidity and mortality. And however, it is important to note over here, as exemplified in heart protection study, that there was 25% risk reduction over 5-year period. However, in non-diabetic subjects, 20% patients still suffered event over 5-year and 33 in diabetic subjects. So there is a huge residual risk. In fact, more than 2/3 of expected ASCVD events in statin-treated patients cannot be prevented. So at this point of time, what we can do, these, Americans gave guidelines of less than 70 in 2002, and 15 years down the line, only about less than 30% patients are achieving LDL goals. So this is a huge problem. And if we go by LAI guidelines of less than 50 in Indians, other guidelines have also followed. So the achieved LDL goals are only in 5%. So achieving LDL goals is a story of epic failure, and this is epic failure defined as complete and total failure when success should have been easy to obtain. So this certificate of failure is given to statin usage, and we know that for example, in this Fourier study slide, we know there is no J curve, and the lower we go, the more benefit we achieve. For example, vis-a-vis achieving 70 to 99 LDL levels. If one achieves less than 10, there is 10 times more risk reduction, 3 versus 31%. So, and we have published various, guidelines how to use it and all. So this huge residual risk is attributable to many factors. Non-lipid factors include smoking, obesity, uncontrolled diabetes, hypertension, etc. Lipid-related causes, the most important one, as Dr. Puri sir pointed out, is non-attainment of LDL goals and hypertriglyceridemia, atherogenic dyslipidemia, presence of small dense LDL particles, remnant cholesterol, and lipoprotein A. And of course, there is inflammatory risk. Now, the burning question, which Dr. Samir Kubba so nicely told in introduction, is that do triglycerides cause atherosclerosis? Think for a few seconds and think in your mind. The answer is yes or no. Now, the answer is that triglycerides are not directly responsible for atherosclerosis. However, triglycerides are considered to be surrogates for VLDL particles which are atherogenic, as LDL particles are, LDL mass is considered to be surrogate for cholesterol. So, indirectly they may be responsible. Further, high triglycerides are associated with atherogenic dyslipidemia. Fridward formula, which we often use, gives equation for VLDL as triglyceride by 5. And importantly, this ratio for calculation of VLDL is applicable only over a small range. When the TGs are high, then this is not applicable. Why this is so? Because VLDL particles are markedly, variable in size from small size to large size. Now, triglyceride derived from intestine or liver in the hepatocyte, triglycerides. In the triglycerides, ApoB is added in a multi-step process involving microsomal triglyceride transfer protein, and VLDL enters the circulation, and through the action of lipoprotein lipase, VLDL is exuded out of the this VLDL molecule. Free fatty acids are taken out to give energy to various tissues, and LDL ultimately is a it becomes a LDL which has more cholesterol and less of triglyceride. This is important because now we have drugs available which can decrease LDL, so that they will VLDL, so they will also decrease LDL. The important new concept is that it is the particle size, not the particle, which is important. Anything less than 70 nanometers will enter the arterial wall, and we see this VLDL is very much falls in the range. So VLDL is directly small. Triglycerides are degraded by most cells. However, it is the cholesterol content of the triglyceride-rich lipoproteins, predominantly VLDL and VLDL remnants, which gets into the arterial wall and behaves in a similar way and causes the inflammation and deposition of cholesterol in a similar way as it does the LDL. So VLDL basically contains triglyceride and cholesterol ester. Now, two things can happen to triglyceride. One, I mentioned that by the action of lipoprotein lipase, free fatty acids are generated, and we have VLDL remnant, which has more cholesterol, relatively less and less of triglyceride. Now, if we have hypertriglyceridemia, for example, in insulin-resistant state, what happens is has VLDL particles has more of triglyceride. Now, this triglyceride, because it is ballooning with the triglyceride, it gives triglycerides to LDL and HDL particles and takes back one molecule of cholesterol ester in exchange. And we have a VLDL remnant which has now more cholesterol ester. And this LDL particle has more of triglyceride. Through the action of hepatic TG lipase, the triglyceride is hydrolyzed, and we get a small dense LDL particle. So hypertriglyceridemia, so various states like obesity, metabolic syndrome, insulin-resistant diabetes, they result in hypertriglyceridemia, VLDL particles which are high in triglycerides, and ultimately through the mechanism I described in the previous slide, they result in atherogenic dyslipidemia, that is increase in small dense LDL particles and increase ApoB and decrease HDL. Now, if triglycerides are increased by more than 150, then we have more of small dense LDL particle. Why this is important is because small dense LDL particles, they have less affinity for LDL receptor, and hence more retention time in the circulation and more chance to get into the arterial wall. They get oxidized easily, trapped easily in the arterial wall, and thus are harbinger for atherosclerosis. So hypertriglyceridemia is associated not directly, triglycerides are not directly responsible, but it gives rise to such a atherogenic, state that it causes hypertriglyceridemia. And it has been shown in Framingham study that the higher the triglyceride levels, more is the cardiovascular risk. And in the other major trials like HPS care lipid studies, they showed in the statin arm that those who were in the statin arm but who had higher TG levels, as shown in dark brown bars, they had more events. And if somebody has triglyceride more than 150 and LDL also more than 70, they are the persons who have higher risk. This is recently published, our consensus statement. And it is important to note over here from therapeutic point that anybody who has TG of less than 500, there is no need to start fibrate or anything. All you need to do is introduce lifestyle changes, because of all the lipoproteins, lifestyle changes are most, they will cause marked decrease up to 50% in the triglyceride levels. And you have to achieve the LDL goals. This is again published, and one can go and have a look at it. So as I mentioned, less than 500, marked increase in cardiovascular risk, and more than 500, there is increased risk of pancreatitis. Now, remnant cholesterol, I mentioned it earlier, it is the cholesterol which gets deposited in the arterial, not the TGs. And remnant cholesterol is the cholesterol content of all triglyceride lipoproteins, chylomicrons, remnants, VLDL and VLDL remnants. And basically chylomicrons, because they are large, and chylomicrons, they are large, they are more than 70 nanometers. So they do not penetrate the arterial wall. It is only the VLDL and VLDL remnants, that is VLDL, which has been acted upon by lipoprotein lipase and results in VLDL remnants. They are responsible for, causing atherosclerosis. And it is an important line: elevated non-fasting plasma triglyceride is a marker of elevated non-fasting remnant cholesterol. So anybody who has a high plasma triglyceride will invariably have high remnant cholesterol levels also, and hence will indirectly tell about increased CV risk. In fact, a increase in non-fasting remnant cholesterol of 1 millimole per liter increases the CV risk by 3 times. And we know from various large studies they had failed actually overall, but we know that patients who had TGs more than 200 and had low HDL of less than 35 or so, the benefit was shown with fenofibrate. However, this is subgroup or analysis and later analysis, so this is just hypothesis generating. In the reduced trial, which was a remarkable trial, which showed that decreasing triglyceride levels by about 20% with icosapent ethyl 4 gram per day decreased practically all endpoints individually as well as in combination, including cardiovascular death. And this resulted in the approval of this drug. And Dr. Puri mentioned about non-HDL cholesterol. Basically, what we want to know beyond LDL is we want to calculate the risk of atherogenesis and cardiovascular risk imposed by other lipoproteins beyond LDL. And this is a good marker. Non-HDL is nothing but total cholesterol minus HDL cholesterol, and hence it encompasses all the everything. Now, 3-4 more slides regarding the lipoprotein structure. We know that lipoprotein inside contains triglyceride as well as cholesterol ester, and over here there is apolipoprotein, which gives structural stability and has other functions, including acting as ligand for various receptors. And each lipoprotein particle has only one ApoB. And it is important, now the weight of these stones is similar, however, there are lots of them. Similarly, measuring ApoB, particle number will give us the exact number of particles which can enter the arterial wall. Here, ApoB particle number in this large point LDL is same, and that's Dr. Sameer mentioned that LDL is normal. Here is also LDL is within average, LDL is there, but this fellow has much more atherogenic risk, and hence is important to measure the ApoB, and has been mentioned in our new LAI guidelines, which have been recently published. Now, in patients who have ranges, who have LDL and everything within range, their patients who have LDL within range will have similar number of ApoB, but 20 to 60% patients who have atherosclerotic cardiovascular disease established, they have discordant particle number, that is, there is high ApoB and low LDL, more so if there is associated things like diabetes, associated conditions like diabetes.
Could you go to the conclusion, Dr. Gummi?
Yeah. So LPA is another thing which is important, and it is statins do not decrease lipoprotein lipase, do not decrease lipoprotein A. Coming over to conclusions, adequate control of blood sugar, BP, lifestyle, etc., alcohol restriction is important because they will decrease triglycerides remarkably. LDL goal is very important to achieve less than 50 as proposed by LAI. High intensity statin estimab are the key PCSK inhibitors, and can be added because they decrease LPA, which is added advantage. Elevated non-fasting triglyceride is a marker of elevated remnant cholesterol, and ApoB measures number of all atherogenic particles. And statin therapy reduces the LDL more than ApoB by 15%. So on treatment, ApoB is a more reliable index of residual risk. Lipoprotein A, I have already mentioned. Newer agents are required because statin do not decrease LPA and may increase it by 10 to 11% or so. Thank you very much.
Very nice.
Thank you, Dr. Vimal. It was a wonderful talk. Now, may I request Dr. Tarun to introduce the next speaker and the next subject. We'll have questions in the end. So if there are any questions, please put that in the chat box so that we can discuss them in the end. Dr. Tarun, please. Tarun, you have to unmute it.
Let me introduce Dr. Anil Dhal.
Okay.
He's a very close friend.
Yes, Rajiv, please go ahead.
So Dr. Anil Dhal is a very close friend and a very big academician. I mean, he analyzes everything better than most of us. It will be very nice to hear him talk about this new group of drugs for lowering LDL cholesterol, PCSK9. Dr. Anil, please start.
Thank you very much, sir. I'll just share my screen. So I hope you can see my screen, please.
Yes, sir.
All right. So I really remarkable presentations by Raman, Vimal, fantastic data, and some food for thought. Not really food for thought, because we go back, just like the coronavirus took us back to 1918. I take you back to 1913, when Nikolai Nishkov actually fed a lot of cholesterol to rabbits, raising their cholesterol to 1,000 and then harvested them. And many years later, 1984, these guys elucidated, Goldstein and Brown were awarded the Nobel Prize for elucidating the structure of the LDL receptor. But basically, all of us want to act at the time that the vessels are patent, because later than that, it is only the hospitals and the device industry which kind of benefit. We don't know how much the patients benefit. Only 1/3 of your cholesterol comes from your diet. 2/3 is synthesized by the body. I mean, these are very simple facts. And cells acquire cholesterol from various sources, and the intracellular concentration of cholesterol is highly regulated and not truly dependent on plasma LDL, which comes from cholesterol synthesis. More than one enzyme system is at play. We have the LDL regulating proteins are regulated by the rate limiting step of HMG coenzyme A reductase. The intestinal brush border has the Niemann-Pick C1-like protein. And we have, of course, the degradation of the LDL receptor by the PCSK9. We also have some newer targets which we are thinking of as having potential, because we can now develop monoclonal antibodies to just about anything. So we have the angiopoietin-like 3 protein, we have ApoC3, and we have, of course, the apolipoprotein A, which is being developed. So just a quick review. One of the very important concepts which we have understood today is the futility of trying to prevent when the horse has already bolted the stable. And we must start prevention, because prevention and lowering of LDL will be cumulative over time. So this is part of the immortal timeline concept, which kind of has come through the back door with the SGLT2 inhibitor trials. Thereafter, we also realize the lower the LDL, the lower the risk. Although it's my personal view that 10 years from today, we will not be measuring LDL, HDL the way we are measuring today. We will probably be measuring only small dense lipoprotein, like Vimal said, but it's kind of difficult to do that on a mass basis. But if we look at just LDL numbers, this very nice graphic actually demonstrates that if at all there can be stopping progression of atherosclerosis, it needs an LDL cholesterol of less than 65. And the LDL, the cholesterol risk reduction is independent of the baseline LDL cholesterol level. So we need a percentage also. So we have genetic data, epidemiological data, Mendelian randomized data, and all this has led to ultra low LDL levels. And these are the concepts which have come without being associated with increase in hemorrhagic stroke. We all thought that there was a J-shaped curve, but we today realize that just like Goldstein's data was quoted about 25 milligram being required for neurological activity, lack of cognitive dysfunction if you lower it to 25, and also the fact that cord blood has 25, a cow probably has 25 without getting coronary artery disease or atherosclerotic heart disease. So we think that this curve may not be J-shaped, but it may be linear. But this is really because we do not know if there are any infraphysiological target values, unlike high blood pressure or high sugars where we have. So if we look at the risk strategy, we need to have an intervention for the untreated, and we look at adequate reduction for an adequate duration. And these are the fundamental principles. With lower is better. And we all realize that statins, although high intensity statins may be used, but there is a lot of unmet needs in achieving a target. I may challenge target, but still that is the only viable thing that medicine has to offer right now. So the current ESC/ES guidelines actually showed that an LDL reduction up to 55 and below, and an LDL goal of 50% of the initial levels are actually from baseline are appropriate to reach. You can't reach them with statins alone. So you need to combine other agents. An oral agent like ezetimibe can be combined. There could be some challenges about doing it for older people, because we know that we need to look at other organ systems as well. There is a rule of 6, and therefore you don't really need such a high dose of statins really, because every doubling of the dose of statins only increases the 6% lowering of LDL cholesterol. And now we have data from a wide amount of trials. So we still identify LDL as a primary target. Lower is better. We want 50% or more lowering, and we want maximum tolerated dose of statin and lifestyle to achieve this. If you use only moderate intensity, we get 30%, high intensity 50%, combine it with ezetimibe, maybe 65%, a PCSK inhibitor alone 60%, a PCSK inhibitor with high intensity statin about 75%, and a combination of all three maybe 85%. So let's just examine what Vimal has very brilliantly said. We have various places where we may act. The HMG coenzyme, we may act at the LDL receptor, we may at the PCSK9 synthesis or breakdown, we can act at the acetyl-CoA, and we can look at various agents which we can do. So let's start by the IMPROVE-IT study, very, very elegant study, and it showed that if you have efficacious LDL lowering, if you add ezetimibe to simvastatin, and even after ACS, it showed benefit. In the Utopia, it showed even benefit above 75, in SHARP, even with CKD patients. And we had a stroke trial also, which was reported. Then let's look at PCSK9. Now it is secreted by the liver into the plasma, binds the LDL receptor, and targets the LDL receptor for degradation. And we know that this happens by a process of endocytosis. And the LDL receptor itself, the PCSK9, is what permits it to be internalized. So the enzyme, which is the pro-protein convertase, acts at the endoplasmic reticulum, the Golgi bodies, and is secreted. And this enzyme is like a chaperone. It binds to the LDL receptor and to allow it to undergo endocytosis and lysosomal degradation. Now, when we inhibit this, if we have a loss of functional mutation of PCSK9, we find clinical benefit. And if we inhibit this by using a monoclonal antibody, then on top of standard therapy, we get an additional 60% reduction in LDL cholesterol. And unlike statins, it also reduces lipoprotein small a, point which was very well alluded to by Vimal. And this, we have enough trial data now to actually show that there is benefit. The absence of correlation between changes in LDL and a lipoprotein small a is something which also leads to changes in the ApoB100, because there are distinct molecular pathways for LDL and lipoprotein small a, and I don't want to go into the molecular biology of it, but in contrast to LDL, lipoprotein small a hepatic capture may be insensitive to PCSK9 inhibition. So PCSK9 is a naturally circulating inhibitor of LDL receptor, and this inhibition with monoclonal antibodies reduces LDL. Unlike statins, they also reduce lipoprotein small a, and this is something we now have Repatha available in the country, and there are a lot of different clinical trials which have looked at different aspects. We have peak volume reduction, which was there by the Glagovian study, and the famous Fourier study, which Vimal was one of the Indian PIs, and Dr. Sani was involved with about 28,000 patients, a 60% reduction, and reduction in cardiovascular death, MI, stroke by even as early as first month. And this is something which continues over 12 months. The EvoPax showed reduction in LDL-C over time, which continues. And this is a rapid suppression of PCSK9 and LDL levels. Now, unfortunately, these monoclonal antibodies are required dosing every 2 weeks, because this leads to effective, stable LDL reduction. We have all modified our own dose schedules, but that's not really what part of the recommendation. The higher risk reduction in MI less than 2 years, higher risk reduction in more than 2 prior MIs, higher risk reduction in multivessel disease, and higher risk reduction in patients with or without diabetes. I look at 2 or 3 special categories which are not mentioned here, because there's no trial data. We were trying to see if we could get support for a trial. Long diffuse disease, no revascularization option. We all know by Poiseuille's theorem that flow is inversely proportional to the 4th power of the radius, and we get a little benefit. We may have a benefit in this highest benefit strategy. Now, safety events, no safety concerns, even with LDL less than 20, the Ebbinghaus database showed no neurocognitive dysfunction. Similar results from Odyssey and the Odyssey outcomes. And so we have recommendations which have come from both sides of the Atlantic, and the LDLs have, the PCSK9 inhibitors have been adopted. But we understand that the cost effectiveness may be a challenge, and it has been the high cost has been a limiting factor for its widespread use, and the subcutaneous route of administration has really not prevented use, but is a little bit of deterrent. So the ESC 2019 recommends that for patients who are present with ACS, whose LDL goals are not at goal, despite already taking maximally tolerated statin and ezetimibe, adding a PCSK9 inhibitor early after the event, if possible during the hospitalization, should be considered. What about other agents? Well, we have looked at triglyceride lowering drugs. Very rightly pointed out, it is not the triglycerides itself, but it is actually the VLDL, which can be atherogenic. And we have to look at the angiopoietin-like 3 protein, which is, we know that the loss of function variants have a hypolipidemic phenotype. And this can be further reduced by a new monoclonal antibody, which is evenukimab, in patients with refractory hypercholesterolemia.
Dr. Dhal, could you wind up in next 30 seconds?
All right, then I'll wind up straight away. Where I just wanted to touch about the apolipoprotein C3 reduction, which can be done through by targeting ApoC3 mRNA, which can reduce the risk. But I will just, if you permit me 1 minute, I will come to a couple of slides which actually talk about our issue. I'm not going to discuss the issue with lipoprotein small a, but I will just come to a little bit about a few slides about the triglyceride-rich lipoproteins and atherosclerosis risk, because this is something which has been a matter of controversy. The Twitter traffic has been very heavy on the criticism of the REDUCE-IT and the subsequent studies like EVAPORATE, STRENGTH, etc. So we understand that statins may increase calcification, they decrease inflammation, but EPA has no effect on calcification and also contributes to improved endothelial function. But in India, we don't really have pure EPA forms or IPE forms, and we are by and large being used to prescribing murine omega-3 fatty acids. So the REDUCE-IT trial was a brilliant study which showed a very good benefit in patients who were receiving statins but had elevated fasting triglycerides, and this actually reduced the first and total cardiovascular events by 25 and 30%. But what has really come
Could you
as a
go to the
matter of
concluding slide? As the
okay,
next
then
section has to
I'll
be
show
started.
here that the strong evidence has emerged for EPA and IPE, but the same cannot be said about commercially available omega-3. And we understand that the DHA, which is another omega-3 fatty acid, may counter some of the EPA benefit. EPA may have extended conformation in cell membranes, while DHA integrates with a disordered manner. There could be a little increase in bleeding, and there could be a little increase in atrial fibrillation. I conclude. Thank you very much.
Thank you very much, Dr. Dhal. It was a wonderful talk. May I request Dr. Rajiv Bajaj to conclude the session? We are not going to have any questions because the time is over and the next session is waiting.
So the people who prepared the program, they had very nicely said that this is about the lipid saga, journey so far. The journey started in 1945 when the cholesterol programs were started. At that time, it looked more like a government issue rather than a scientific issue. But then we have statins, and we have come to recognize the role of cholesterol in plaques, especially in patients with familial cholesterolemia, on which we had a lecture by Dr. J.P. Sahani. The second talk, which was on lipid targets have been spoken about a lot. I mean, we are always seem to be discussing lipid targets, and I hope in future there will be more talks by people like Dr. Mehta, who is trying to understand the biology. Once we understand why the LDL is there, what is causing it to increase, what is causing it to decrease, what is causing it to cause atherosclerosis, then we'll be able to better do it then. And just saying so much level would be all right is very simplistic. I mean, what is the purpose of HDL? Why does the intestine make it? These questions have to be understood first before we say whether it is good or bad and what level we want. The talk by Dr. Dhal, of course, was highly technical. And I think he had a lot of other very complicated slides, which unfortunately the time didn't allow. We've had a good session. I hope further sessions on lipids will talk about the function of each of these lipoproteins. Thank you very much.
Thank you so much, sir, for conducting the session very well, the lipid saga, the journey so far. And we move on to the session 3 for the day. That is the division by the point and counterpoint. Revascularization in chronic coronary syndromes after the advent of ischemia trial. And we have the privilege of having chairpersons, Dr. Anil Gombar, Dr. Ranjit Nath, Dr. R.M. Chabra, and we have many senior people, Dr. Manchanda, Dr. Nitish Nayak, Dr. Rakesh Yadav, who are available. I would be very happy if the previous chairpersons and other speakers also join us with this session. And we have the two debaters, both authorities in their field. Both can speak on either topic, and it will be a jugglery that we are going to witness, that how we play around with the data to project which one is which. Professor V.K. Behel and Dr. Ashok Seth. So over to the chairpersons. I request Dr. Ranjit Nath and Dr. R.M. Chabra to please start the session.
Okay, thank you, Mohit. So this is the cardiologist treating coronary artery disease. The chronic stable angina or chronic coronary syndrome patient constitutes a major chunk of the patients. So whether to treat them with only, most of them with medical therapy, subsequently rarely angioplasty, or most of them to be treated with angioplasty along with medical therapy. These two topics needs to be discussed, and it has been extensively discussed earlier also. And we have the two stalwarts from our city, Professor V.K. Behel sir and Dr. Ashok Seth. So I request Professor V.K. Behel sir to start his proceedings.
Good morning, everyone. Chronic coronary syndrome, for decades we know that medical management should be the treatment of choice. But ischemia trial only put a stamp on it. We should learn from the history the lessons learned are helpful when we plan any for future trials. When it comes to acute coronary syndromes, there are no questions asked because it saves lives. But when it is chronic coronary syndrome, the lay press has been critical for last many decades. Even the scientific journal like JAMA said in 2012 that it is an expensive placebo for patients of stable angina. The readers of New England Journal of Medicine about a decade ago, they were asked how they like to treat a patient of stable angina, and the option, if you look at, quite divided. So this topic had attracted the debates for decades because the evidence was in the favor of medical treatment, but cardiologists wanted to do angioplasty for any patient presenting with stable angina as the initial choice. What is basically the role of revascularization in chronic coronary syndrome? It is to improve the quality of life by relieving the symptoms, and number two, relieving the future myocardial infarctions and death. That is the hard endpoint. Everyone wants to live longer and without any complications. And can angioplasty provide that over and above the medical treatment? Let's discuss the soft endpoints. There have been 3-4 major trials. The COURAGE trial showed, yes, if you do an angioplasty for 3 years or so, the symptoms will be better controlled. Then came the BARI. It's not a typically randomized trial, but it showed again that the freedom from angina and incidence of angina will be less if you do initial angioplasty. Similarly, in FAME2, after 1 year, the relief from angina severity was much more in angioplasty group than the medical treatment group. And the ischemia was no exception. If you look at the quality of life outcomes and angina frequency, you find that PCI scores over medical treatment. But what we should remember is that this is a trial, Orbita trial, 200 patients only. When they compared instead of placebo to a sham procedure, they found that the primary endpoint was not met by angioplasty. That means whatever the relief we were providing, was it only a placebo effect? May or may not be, but this trial at least raises that question that angioplasty alone is not answered. We have other anti-anginal drugs which are there to control the symptoms. But of course, if there are unacceptable angina, in spite of medically recommended treatments, which does not include the newer anti-anginas like trimetazidine or ranolazine, but if you give the conventional treatment and the patient still has significant angina, of course, you resort to revascularization. But now let's come to the hard endpoints. Can angioplasty prevent death and myocardial infarction? We can divide this into a pre-COURAGE era, because COURAGE was supposed to be the game-changing device. Before that, we knew that the death MI are not reduced if you do an angioplasty as compared to medical treatment. The COURAGE was supposed to answer or settle this question after 4.6 years in 2,000 patients. There was no difference at all between death and MI, whether the patient was subjected to angioplasty or if he was put on medical treatment. Of course, every trial has its limitation, and COURAGE had its. It was not a generalized trial. People said it recruited the patient for low-risk population. The PCI approach was not ischemia guided. The stents were not the first generation stents, and so on and so forth. But at least for the inclusion criteria of COURAGE, they did not accept that the angioplasty is non-inferior to medical treatment. Then came this 30-study meta-analysis, which is that if you have a smaller data, do combine them and do a meta-analysis. Again, no reduction in death in MI by angioplasty. BARI-2 not a randomized trial, but showed that the PCI stratagem versus the medical therapy, there is no difference between death, MI, and stroke rate, whether you subject even these high risk of patients with angina, with diabetes, medical treatment, or an angioplasty. over the decades, we find that there are several trials. That is the fortunate part of interventional cardiology, is that we have adequate data. 61 trials, 25,000 patients. The technology changed. The bones gave way to bare metal stents, to drug-eluting stents, and so on. But there was no improvement in death and MI rate compared to medical treatment. It has been kind of slowly as far as stable angina is concerned, or so-called chronic coronary syndrome is concerned. But they said that we have newer tests now. We know the concept of angioplasty better, as if they did not know how to do an angioplasty. This is the trial, 100 trials meta-analysis, 1 lakh patients, sufficiently good meta-analysis, but it's only hypothesis generation. They showed again no difference, significant difference in mortality, some reduction in myocardial infarction if you use a newer generation of eluting stents. But we must remember that all newer stents won't save lives. We have the example of BVS, which was withdrawn ultimately because the trials after trials have shown that this stent is not good. Then is the concept that we should completely revascularize the patient if you want to save the deaths and MI. This trial showed that you do incomplete revascularization or complete revascularization, MACE rates are not different. In fact, more the stents you put, if you chase every small branch and put a stent, the restenosis rate is going to be higher and patient will require more revascularization. Then they said that myocardial infarctions are not all same. The angioplasty produces a procedural myocardial infarction, while it saves the spontaneous myocardial infarction, and both types of myocardial infarctions have a different type of prognosis. Is it so? Look at the JCC 2019. It suggested that even if you have post PCI, so-called procedural myocardial infarction, prognosis is bad. The people will get more death and myocardial infarction. This is again showing that periprocedural myocardial infarction have more death rates. Then came that the patients who have ischemia only should be treated based on the current nuclear substudy. It again, if you look at the updated analysis, it suggested that that is not so. Death and MI rate was similar in all severities of ischemia. Then came the concept of FFR. They said that now we have a better tool to know about the ischemia. Look at the FAME2 trials. If you read the summary, it suggests that the primary endpoint was met. It was better than medical treatment. But if you look into the data, death MI rates were not different. What they did was, I am quoting from the original paper. When they corrected it, they found that the death and MI rates were not significantly different in PCI group as compared to medical treatment group. Then came this meta-analysis. Again, 5 trials, major trials, showed no difference in death and MI, whether you do angioplasty. Then meta-analysis after meta-analysis were done because the cardiologists wanted to do angioplasty. Evidence was against them. So they tried to find out all sorts of statistical jugglery. But meta-analysis after meta-analysis suggested that PCI is not better than medical treatment. Then came this mega trial, ischemia trial. Everyone was waiting for that they will change the cardiology scene. It was very good trial when it started. 8,000 patients was the aim. Only hard endpoints were to be studied. But before the trial was published, this is from Post magazine on 30th March. Even before its publication, it generated controversy because they changed the goalposts, because they knew that the hard endpoints will not change. So they changed the goalposts and they changed the major clinical endpoints. When the results were published after 3 years, there was no difference. It did not meet its expectation. The primary endpoint of cardiovascular death and MI in the 2 groups was different. Then they said that yes, initially a patient will have a more myocardial infarction. It doesn't matter. But spontaneous myocardial infarction will be reduced after 6 months. So initially, can you convince the patient that initially you may die or may have myocardial infarction, but if you survive, you'll have less chances of having a myocardial infarction, even if you believe the data. There are limitations of this trial. Every trial has, there was a crossover rate of 23%. And yes, indeed, there were two types of myocardial infarction which were studied. But look at the interpretation. This interpretation is based on the DAP was given more in patients of invasive arm. That's why they had a better, whatever the better myocardial infarction they had of spontaneous MI. 26% of the patients did not develop angioplasty but bypass surgery, which we know reduces spontaneous myocardial infarction. There's all sorts of controversy, which should be a prepared procedural MI, side definition or universal definition. If you reduce or change the definition of myocardial infarction, even in ischemia trial, you will find that there is a significant reduction in myocardial infarction rates as compared to conservative strategy rates. Now look at these two trials. I've just put it in perspective. Ischemia trial and Excel trial. When it comes to Excel, the same trial, they say that angioplasty is as good as bypass surgery. Bypass surgery is not better than angioplasty. But when the same curve, this crossover is at 6 months, this crossover is at 1 year. When this crossover happens, they say no, there is a crossover. So angioplasty is better than the conservative management. Now, then there is again a meta-analysis of 14 randomized trials, including ischemia, 14,000 patients, 5 years of follow-up, no change in death in MI. What else is required to convince us that initial medical treatment for all patients of chronic coronary syndrome should be the treatment of choice? Now they quote all sorts of imaging techniques, FFR, when it is not convenient to them, because this Illumine trial showed that yes, you will be able to pick up major edge dissections, monopositions, but do they matter? The small edge dissections which have been picked by the OCT, MACE rates are not different. Yes, not statistically significant. FFR, look at 1,000 patients trial, was stopped prematurely because if you guide your strategy based on FFR, there are more death rates. Yes, there are limitations of this trial. In the medical, we have all sorts of therapy now, PCSK9 inhibitors, we have rivaroxaban, the new concept of treating the pulse along with antiplatelets. We have the concept of anti-inflammatory drugs like canakinumab or recently colchicine. So they'll change the scenario more in favor of medical treatment rather than an angioplasty. Now, these are the words again of JAMA editorial, that percutaneous procedure may cause greater harm than the medical therapy, whether you believe it or not. Now, is angioplasty should be done if all revascularization is required? No, bypass surgery should be done if the patient has a multivessel disease or left knee disease even. Historically, there have been 3 BA, PASS, and European studies. All 3 of them have suggested that bypass surgery scores over the medical treatment. Now, if you look at the meta-analysis of comparison of angioplasty with surgery, of course, it was the era of balloons and bare metal stents. Still, at that time, we find there is no difference between survival or myocardial infarction. But if you look at repeat revascularization rate, it is significantly better in patients undergoing bypass surgery. Then this came a landmark syntax trial. By 7%, repeat revascularization by 12%. So why not subject all patients of multivessel disease to angioplasty rather than to bypass surgery rather than angioplasty? Yes, the stents were first generation stents. The 10-year data again suggested the syntaxis trial, death rate, bypass surgery scores over angioplasty, especially in patients with triple vessel disease and syntax score of more than 33. If you look at the high-risk group, diabetes, freedom trial, again suggested 5 years data, CAG superior to angioplasty. Even in diabetes, it should be end of story for angioplasty in stable angina as far as multivessel disease is concerned. Using the best variable stent, everolimus, best trial, again 5 years data, CAG superior to PCI. The trial after trial suggested that if you require angioplasty in multivessel disease in angina, go for bypass surgery rather than an angioplasty. Even for left main disease, this normal trial again suggested 1,200 patients, 5 years of follow-up, that PCI did not show non-inferiority. Rather, CIG was superior to PCI. In the same
Sir,
time,
request you to conclude in 30 seconds.
Yes. Excel trial, again, there is a lot of controversy. Now they are saying that Syntax 2 2020, this data should be followed. Who knows, they will not again change the goalpost. So the data after data, this is the editorial from Lancet 2012, which has suggested that PCI for stable angina should be class 3, and the risk clearly outweigh the benefits. I don't know why Dr. Ashok said will still prefer to do an angioplasty as a strategy of choice for chronic coronary syndrome. But I'm sure he will convince you, because he is a very eminent person. He is a very eloquent, he is very confident. He is the one of the smartest, the most skilled, most eminent, and most known interventional cardiologist. I'm sure the evidence or no evidence, he will try to convince you that the angioplasty should be the strategy of choice in chronic coronary syndrome. Thank you.
Thank you, sir. It was very nice lecture from your side. Now I request Dr. Ashok Seth sir to give his contrarian view. Rather, as you said already, he is an expert of angioplasty. Let us listen how he convinces us that angioplasty is going to be better for chronic coronary syndrome management. Over to you, Ashok Seth sir.
Let me share my slides. Can you see my slides?
Yes, sir. Yes, sir. Yes,
okay. Sir. And I could have my timer on. At the outset, let me just state that I think I have a huge respect for Dr. Bahel. I think he's a very ethical, evidence-based interventional cardiologist and a very high level of clinical cardiology. And by the way, he actually narrated to you 50 trials in the 15 minutes, and I have nothing to say against any of this. In fact, I actually accept what Dr. Bahel has said. I think it's phenomenal talk. And at the end of the day, I was rather confused because I thought it became a lecture at the end of revascularization versus surgery versus angioplasty, rather than medical therapy versus revascularization in chronic coronary artery disease. So I'm not going to tax your intelligence. You just heard the placebo. Now you're going to hear the active agent, as I say. So let us just move on to the study itself. And we were asked to talk about revascularization after this study, the ischemia, which is a perfect study, I must tell you, presented at the AHA in November and then published in the New England Journal of Medicine in April this year. I think it actually addressed a very important aspect. And you must understand what it addressed: initial invasive versus conservative strategy for stable coronary artery disease. It didn't differentiate between angioplasty versus surgery, though 75% of the revascularization in this study was performed by PCI. It also took coronary angiography into account as a part and parcel of the invasive strategy. So we are addressing a whole situation of how to handle patients rather than one therapy versus the other. I want to actually have to very clearly tell you that right up front. Dr. Bahel has actually outlined the correct aspects of a therapy versus another therapy, showing that there's no benefits. But the reason why we want to dwell on ischemia is that it actually addressed the critiques of the very studies which Dr. Bahel has presented from the era of 2000 to 2020, during which time both medical therapy improved, during which time there was a greater understanding of strategies, and during which time drug-eluting stents also improved, added surgery. So what did it address? It addressed that stable patients with moderate to severe ischemia on exercise-based evaluation. Is there a benefit of adding intervention, invasive therapy, which meant catheterization and if feasible revascularization, to optimal medical therapy? Therefore, let us try and understand and forget the critiques of the past. That's why this study was done. All this about every study had a critique. Let's not address those. Let's address this study. We therefore need to understand, with your wisdom and your analysis of this study, as to where we stand at the moment and we go with future with revascularization and with PCI in specific. Let us therefore understand the ischemia study thoroughly. Let us see which patient it addresses, and let us analyze its impact on our daily clinical practice as it happens in India. And then only we can put it into perspective and start understanding whether revascularization is useful for most of our patients with chronic stable coronary artery disease. Actually, you don't judge that from the paper itself. You judge it from the 124 pages of supplementary index, which are attached to the ischemia study. And I think that's very important so that you yourself can analyze and use your wisdom around this. I have 10 commandments around this study, which I'll convey to you. All the patients in this study had coronary anatomy delineated. We must remember that. So these are not the patients you say, he's come to me, he's got chronic stable angina, I should put him on medical therapy. These patients had 75% of these patients had a CT angiogram as a prior criteria for randomization. And the remaining 25% had already undergone an angiogram or CT angiogram in the previous 1 year. So anatomy was delineated and known. It was not blind medical treatment. I think that has to be understood very clearly. All the patients did have an assessment of ischemia on an exercise-based evaluation. And of course, they were subsequently randomized to medical therapy versus continued aggressive medical therapy versus the invasive strategy. Now, I did want to take you through this to understand that the primary endpoints were a combination of 5, and Dr. Behel rightly pointed out the controversy which arose around these endpoints, where the endpoints actually got changed from cardiovascular death to MI to include a few other, which were very vague actually. And I don't think it was at the context behest of the interventional cardiologist or invasive cardiologist. We must remember this was a cohort together who decided about it. And maybe it was trying to be in favor of medical therapy rather than PCI. So it's very difficult. In this study, the mortality for all patients was low, and I'll explain to you why. But the secondary endpoint of time to cardiovascular death and MI was also very important. I want to take you through this. This is one of the most important slides. It actually excluded and only included a very select subgroup of patients. It excluded anybody who had even a borderline left main disease. It excluded patients who had a recent or past ACS. It excluded patients with ejection fractions less than 35%, patients with previous PCI and bypass surgery, patients with previous MI. A lot of the spectrum of what we do daily, even in patients who had exercise tests and chronic stable coronary artery disease, these were excluded. And these are well known that these patients do very well, perhaps on the invasive strategy. And that is the reason they were excluded, to pick up low risk patients. So when you start understanding, and this is from the supplement, 26,000 patients were screened basis of chronic stable angina and positive exercise tests. 50% of them fitted into the exclusion criteria known to actually benefit from revascularization strategies. And finally, after exclusion of more, only 30 patients got enrolled actually into the study. That meant that from 26,000, 8,000 patients were taken up. Even after that, having had screen failures related again to non-obstructive coronary artery disease or left main, you actually are left with 5,179 patients. 20% select patients out of chronic stable angina of 26,000. That's why you said there are so many patients around. Well, in this study, it was select group of patients who we knew may not actually benefit from revascularization therapy at all. 320 sites in 37 countries over 78 months from July 2012 to January 2018 was the time frame of the study. 2.5 patients per site per year. Now you tell me, how select are these patients that only 2.5 patients per site can get enrolled over a spectrum of 6 years? That is very surprising, and that's why. Now, when we actually, the reason I say this represents a very small proportion of patients who are undergoing PCI in our own hands, in our own country, is that this is published data from the National Interventional Council, published in Indian Heart Journal. The last data, 2018. If you see the spectrum of patients undergoing PCI, 70% of these are either ACS, MI, primary, or recent MI cardiogenic shock. Only 18% of these, or 19%, represent chronic stable angina. This is our country's data. And if you actually apply the same exclusion criteria on those chronic stable coronary artery disease patients, as was applied in the ischemia study, you're actually down to 30% of those patients, which means practically 3.6% of the patients who actually go PCI are the ones which fall in the criteria of ischemia study. And that's the 3.6% we are dealing with. And these 3.6%, there was meticulous, supervised, goal-defined optimal medical therapy to the unrealistic levels. If you actually see those criteria, it had to be LDL less than 70, it had to be moderate level of exercise at 30 minutes, 5 times a week, smoking cessation had to be achieved, hemoglobin A1C less than 7, and had to be on a 4-drug regime. And for this, unrealistic supervision was carried out. Medicines were provided free, consults were had, interactions, devoted research teams were actually ringing these patients every day, pill count was being done, adherence to medication, regular blood tests was being done, target levels, and at follow-up visits, they would consult mandatorily a psychologist to give us smoking and a dietitian to measure their weight and a rehabilitation specialist who would check on the exercise protocols. Do we really treat our patients like this in our own clinical practice? But if we do, we can achieve this 81% adherence, 95% on high statins, 66% on high-dose statins, and we actually achieve the goals in this study. But this doesn't happen in real life. So actually, this was artificial context. And while Dr. Behel pointed this slide out, I want to tell you a median follow-up 3.2 years is nothing when you actually see that we have a loss of 2% absolute term in terms of a revascularization strategy, which starts gaining even at 6 months' time, and actually the curves are diverging. And 3.2 is nothing when you start looking at long-term. And while Dr. Behel mentioned the MI issue, I would want to say that while medical therapy was optimized, PCI or revascularization strategies weren't optimized, and there was uncertainty about the completeness of revascularization. So if I was to sum up really what happened, the curves did cross at the major secondary endpoint with a 2% loss in the first 6 months to a year, followed by a gain over the subsequent 3.2 median years of follow-up. And that is why it was neutral. And the procedural MIs were increased with the invasive strategies, but spontaneous MIs were reduced with invasive strategies. And 28, now come to this, I think it comes here. This is another sixth commandment. 28% of the conservative arm underwent an angiography, and 23%, a quarter of those patients underwent a revascularization by angioplasty strategy before the 5 years, before 4.4 years, for urgent. And by the way, that translates into urgent need for ACS. There was a high incidence of ACS, high incidence of hospital readmission, which we'll come to. And when we talk about the procedural MIs, the slides got interchanged. We actually, while Dr. Behel said that procedural MIs, which is CPK rises, are detrimental to the patient, they are detrimental compared to those who had no MIs at PCI. But it has been actually a point of debate for a long period of time. What is very clear and far beyond the procedural CPK rises is that spontaneous MIs are adverse prognosis for a patient. And that is what the right slide demonstrates. The diverging curves, take it another 2 or 3 years, you will actually see its effects on mortality. You will probably see its effect on survival and outcomes in a major manner if you continue to have spontaneous MIs, which are much worse than procedural MIs. I think it's important to remember that's been discussed repeatedly in the past and during this study. And as I told you, this very aspect of less hospitalizations from unstable angina and heart failure in the invasive arm is extremely important to understand. Of course, we discussed, and Dr. Behel lightly passed away, this improvement, which is very improvement, and again from the same group. This is not data dredging. This was meant to be an endpoint. Patients randomly advised to invasive strategy in these 5,700 patients had improvement in angina-related health status than those assigned to conservative arm, well proven by the ischemia research group. And again by ischemia research group, what they looked into is ejection fractions and found that those who had ejection fractions between 35 to 45% also had a lower primary outcomes compared to those who were in the normal ejection fraction. Again, favoring the fact that it is not just less than 35%, revascularization strategies benefit less than 45%. So what am I telling you? That this study, and I already pointed that out, does not apply to a majority of patients with stable coronary artery disease to whom invasive strategy in whom invasive strategy is superior, because it excluded those who had a past unstable angina, a previous MI, those who had even a mildly impaired left ventricular function, those who had left vein disease, severe symptomatic angina, previous PTCS, previous bypass surgery, those in whom coronary anatomy was not known, those who could not be compliant with drug therapy, and those who could not have supervised target-driven medical therapy. So it left with us in our clinical practice around those 3 to 4% patients. And if these are the 3 to 4% patients we're talking about, in which we can discuss between revascularization strategy and the choice of medical therapy versus revascularization strategy, we must. After all, what this tells us is that invasive strategy is superior to optimal medical therapy alone. If the patient has a better relief of symptoms, if I was a young person who continued to have angina and travel the world, I would actually vouch for invasive strategy and a PCI rather than have medical therapy and continue to take a 5-drug regime and have supervision daily and weekly from someone and have repeated blood tests for the rest of my life. We must remember that it is superior if it is performed safely and optimally in the first go by experts, and is straightforward for proximal lesions because it will lower spontaneous MI rates in the long run, which could be very detrimental for the patient's outcomes. And also, if 30% of the patients are going to need an urgent invasive strategy for failure of medical therapy, which could present as unstable angina and admission to the hospital, please understand that a patient could be anywhere in the world. Our patients don't have an access to 911. Our patients don't even live near a major hospital who can provide them adequate and optimal therapy at the time of an ACS. And if he fails medical therapy, he would be at risk. So how would you treat a younger patient who's more active patient, who's a frequent traveler, who actually wants the fact that he should have less angina, better quality of life, and does not end up with an MI or an ACS far away from his home, where he could be admitted in a vague center in a vague country? We must understand what is it meant for. We understand that it is meant for a small proportion of patients with coronary artery disease who do not fit into the ischemia, who only fit into the ischemia criteria, who can actually be supervised, who can be actually mandated to actually have therapy, and who can be told that you are going to actually have a 30% chance of having ACS being an admission for urgent procedures, and you have the option of having it now or at a later date. But clearly, invasive strategy proves superior to at least in those 97% cases that we actually meet and perform PCI or revascularization in our daily lives. Thank you very much for your attention.
Thank you very much, sir, for your very elucidated lecture. And you, as always, always convince people that angioplasty is going to stay in this part. But I request Professor Behl, sir, to rebuttal for 1 minute, sir.
Yeah, as I told you, Dr. Seth will convince you. But I think I won the game already, because looking at his practice, if he has conceded 3% of the patient to me as for medical treatment, it will be huge patient load for me. I can see those patients from morning till night. So I already have got 3% of patients. But what he said, in Indian context, we always say that, we are not providing the optimal medical care because of economic issue, because of overload of patients. But that should not be the answer for doing an angioplasty. We should improve our care. Every patient should be treated as it was treated in ischemia. Every patient should get the guideline mandated medical treatment, saying that the medicines are given free. In some centers, the angioplasty is done free. So that doesn't convince me much. Then he said that yes, in remote place, if you get an MI, what will happen? You may get acute coronary syndrome where facilities will be not available. The counter to that is, if that patient gets a stent thrombosis in Jumritalaya, what will he get? So that question will be open, that we should improve the medical care all over the country. We should strive to have a best medical possible care. But it's a strategy, as both of us have discussed, whether to initially put the patient on medical treatment, gain those 3, 4, 5, 6 years, and then subject to revascularization. The second part he has not dealt much is whether we should revascularize by bypass surgery or PCI. That may be a debate for another day, I think. So I think both of us are talking the same line. What I'm saying is that initially all patients, at least people used to feel that if you are putting the patient on medical treatment, you are doing a non-inferior job. That means the patient is poor, he can't afford angioplasty, so you have put him on medicine. At least now I can convince you based on evidence that what I'm doing is the best treatment which is available for that patient. Is not the poor man's choice of having a medical treatment and not the angioplasty.
Thank you, sir. And I request Dr. Ashok sir also for 1 minute of rebuttal if you want to say something, sir.
Yes, yes, I do. And I think, I hope my slides are here. Can I just get back to my slides? And I think I have a rebuttal slide, so please bear with me, okay?
Yeah.
And I think it's very important for my rebuttal slide to be here because it gives me the, let me just move it forward. Yeah. So I'm going to go for the rebuttal, and I actually say that I think Dr. Behel and I want the debate not to be oriented towards misconceiving people. For me, the ischemia study has been very good, and we actually will now convey the same message. I totally agree with what Dr. Behel has said. Forget his remarks on what I didn't or did, but his final statements are very important, and it's our responsibility to convey the right thing for everybody. And for me, exactly this ischemia study was a very vital study. It exactly told me the value of medical therapy, that it actually plays a very important role in management of our patients. And I always believe that, and I always do that. But as an alternative to intervention, it's so important that we need to be aggressive with the 4-drug regime. We need to be compliant, supervised. It's our job to look at lifestyle modification, be target-oriented. And we certainly, as interventional cardiologists, need to stop avoiding reflex angiograms and revascularization in patients who are uncomfortable with the OMT. And I may say that it actually was a small proportion of patients they excluded vast, but I actually believe that OMT could even help many of those patients who were excluded from the ischemia study, because OMT has improved tremendously to decrease plaque passivation as well as decreasing MIs. So when we talk to our patients and he's stable, and even if he has 2-vessel disease, we do not need to create a panic, and we don't need to rush him for an urgent revascularization. We can give him enough time for the patient to have considered opinion and information. And I think I want to convey that to everyone. Do not rush your patients with a small OM, with a 90% stenosis, saying that you will actually die because you don't have a PCI done. This guy is going to be fine even 10 years later on aggressive medical therapy. You have to understand that. I may not say that from a proximal LAD, but I want to point out that now it creates a greater responsibility on every clinically and interventional cardiologist, and that's what Dr. Bell said. Every time now we see a patient, it makes us think of ischemia study and the fact that the patient could actually have medical therapy, and there's no reason for him to say, please stay in and have this procedure done. I actually tell my patients, go home, come back after a month's time, come back after a 2-month time. Let's see how your drugs do. Let's see how you go in yourself. But yes, we have to fine tune its optimal use to our patients with stable coronary artery disease. And for a young guy who travels the world, who has a simple, discrete, proximal large vessel stenosis, I may advise him angioplasty. On the other hand, if he's got a diffuse, long LAD all the way or a right coronary artery in which I have to put 3 stents in, I would advise him medical therapy. We have a responsibility not to overuse or oversell one strategy as a reluctance for understanding other strategies. It is detrimental to the patient. I'm very for ischemia study and the medical therapy arm in the ischemia study. That's the way to give medical therapy. We have to tailor our strategies to the optimal time frame and for the appropriate patient. For example, the same patient who lives next door, who has access to a hospital, who says that anytime I get worse, I'll come to you. For the same lesion, I may be advising him aggressive medical therapy. For another lesion, for another patient who travels the world, I could be advising an angioplasty. So it's informed and transparent shared decision-making and consent, which will get most important. And finally, We keep repeating this again and again. It's the same patient we're talking about. It's good news. Your cholesterol has stayed the same, but the research findings keep changing. And that's how we keep changing our management, even though the patient remains the same. Thank you very much for your attention.
Thank you, sir. And I cannot agree more with both of you. But one problem, as I see, is that being senior, being your trainee, is that first angiography leads to all the coronopathy in India. Anybody comes to stable angina, we go for angiography, and that led to all this unnecessary revascularization.
Agreed.
Second is that most of the patients, even in constable angina, even LDL is never brought to the target level before intervening. Initially, when an anti-inflammatory process is going on, even then it was done. So maybe that leads to a lot of process. So anyway, I agree to some extent. And one most important point I want to say is the ischemia trial. We had 18% patients from India, and we also has included a lot of patients.
Correct.
So we have to respect this trial because we had the highest number of patients of chronic stable angina in this trial. So we have to respect this. So with these concluding remarks, I thank you both of my mentors for such an excellent discussion and debate. Thank you very much.
Thank you.
Dr. Mohit, can you pick up? Dr. Khalilullah sir, to take up for the next session, sir.
Mic on, Carlo.
Your mic is on, sir.
Yes. Good afternoon, ladies and gentlemen. This is to welcome you to a very important session this mid-morning. It is a power pack session on cutting-edge technologies and imaging in 2020, a world of opportunities. It is power pack because each of the speaker is a tower of excellence by himself, and it's a pleasure to listen to all of them. With me are Dr. C.P. Roy, Dr. H.K. Chopra, Dr. K.C. Goswami, Dr. K.K. Talwar to chair this session. I hope they're all there. May I now invite the first speaker, Dr. Balbir Singh, whom I call Master Cardiology. He's a versatile cardiologist, the president of Csi Delhi branch, and has a great job of this conference. I have to invite him to deliberate on newer imaging and technologies providing opportunities. Dr. Balbir Singh.
There's a request by Dr. Mohit Gupta that Dr. Praveen Chandra is to go to the second hall. Can he have the first talk, or should we go on like this? Mohit has just called me up.
Okay, if Balbir agrees, I have no problem. Balbir, can you be the second speaker?
Okay, no problem.
No problem. Then we invite Dr. Praveen Chandra, who is going to talk on structural heart interventions that have revolutionized the management. Dr. Praveen Chandra is the Director of Cardiology from the Vedanta Heart Institute and a very aggressive cardiologist in handling structural heart disease. Dr. Praveen Chandra, please.
Hello. Can you hear me?
Yes. Yes.
Okay.
Yes.
So thank you and good morning to all of you. And it is a wonderful CSI which is happening virtually today. And we just heard Dr. Seth and Dr. Behel, a very nice discussion on such an important topic of coronary artery disease. So moving on to structural heart therapies, I think this is a new arena which has really opened new vistas and new horizons for interventional cardiologists and also cardiologists in general. So let me share with you the data which is now emerging. I don't know why it is not moving. There is some problem. Let me just see. There's some problem in my slide. Can you see my slide now?
No, we were seeing it previously.
Can you see now? No?
Please share this.
Okay, just a minute. There is some problem. I have to share again, I think. Share my screen. Can you see now?
Yes, we can see now.
Okay.
Okay, fine. So basically, as I said, that structural heart intervention is a new field, and in the last many years, we started doing structural heart interventions. And as you can see in this slide, that we started from the, of course, the balloon mitral valvuloplasties to start with, and then balloon dilatation of all the valves were being done. That was the start, I must say, the start of structural interventions. And then we moved on to replacing the valves. And then the first therapy which came into the picture and which established itself is TAVR. And this is for the aortic valve. Severe aortic stenosis was being treated, started being treated in the last 10 years now very effectively. And it has almost become a standard of care for many, many patients of severe aortic stenosis. For those patients who had bioprosthetic heart valve failures, you can see aortic valve-in-valve intervention has become very commonplace now and is one of the preferred treatment strategies, especially for patients who are more than 60 or 65 years of age. Then for the mitral valve, the MitraClip started coming into the picture for severe mitral regurgitation. Some other devices are being tested at this time and are going to be here very soon, but MitraClip certainly has come, and here looks like that is going to be here to stay. Mitral valve and valve interventions for bioprosthetic heart failures of the bioprosthetic replaced valves has now also become very common and very, very effective ways of treating patients who already have a surgical valve which is kind of not functioning or degenerated. For tricuspid valves, also we have now options for severe tricuspid regurgitation, tricuspid valve-in-valve if the patient already has a valve inside, or now we have a bicable valve, which I'm going to show you very soon. For pulmonary valve, percutaneous pulmonary valve replacements is also being done very effectively, and primarily it is in the area of congenital heart disease interventions. Paravalvular leak closures for both mitral and aortic are very effective and are being done, and we have done quite a large number of cases now for these patients who already have either a bioprosthetic valve or a mechanical valve where there is a paravalvular leaks, and these can now be very effectively closed percutaneously. Then finally, the LA appendage closure is another structural heart intervention which has become very feasible and very, very safe, which can be done for prevention of stroke in patients of atrial fibrillation who cannot or do not tolerate oral anticoagulation therapy. So that is the complete spectrum of structural heart interventions which is being done today. And fortunately, we can say that now we have started doing almost all the interventions here on a very routine basis. So first of all, aortic valve stenosis, as we all know, that surgical intervention is required in those patients who become symptomatic, but a large number of patients were there. And also those patients who are undergoing intervention, surgical valve replacement above the age of 75 years, the mortality was high. So these patients were not being treated because the mortality and morbidity was high. So these patients have now started undergoing transcatheter valve interventions or percutaneous aortic valve interventions. And in these patients who are more than 70 years of age, where there is symptomatic severe aortic stenosis and has a high Euroscore or a STS score, these patients, if the femoral access size is good, now we are even doing non-femoral access sites from subclavian artery, from the carotid artery, and also the transcaval approach. So all these patients can be done, but certainly we need a team for this. And this is a multidisciplinary team which should take a decision to do the transcatheter aortic valve intervention. And the most common valve intervention is the transfemoral route. And I'm not going to show you the whole video because it will take too much time. So the transfemoral route is the commonest route, is the most effective route, which has been found to be effective in these patients where we have severe aortic stenosis. And this is a very common valve. Many of you must have seen this. And initially we used to do it with a T guidance. Now we do it without any T. And many times these patients are conscious sedation only, and they just can be quickly discharged in a few days' time. So the procedure has become very fast, very safe, and we do it in a cath lab. As you all know, from a femoral approach, we do a puncture, check the arteries. If they are the size is good, there is no severe tortuosity or calcification, then we take up these patients and do this. And you can see this is a balloon expandable valve. Earlier I showed you a self-expanding. So these are the two type of valves which we do these days. And this is a balloon expandable valve, which is the Sapien S3 valve. And also now we have the My valve, which is the Indian valve, which is almost similar to this Sapien S3 valve. So this is both these procedures, even the self-expanding or the balloon expandable can be done. And these are the kind of results we get once we do these procedures. The gradients are low to zero, and these patients maintain the rhythm many times. We check the coronaries at times if needed. And if everything is okay, the patients can be discharged in 2 to 3 days time. Usually it is about 3 days we discharge these patients if there is no conduction abnormality. And those patients who have a pacemaker already, these patients can even be discharged in the next day. So mostly the patients which we have done are above the age of 65 or 70 years, but some patients who also had severe non-surgical or maybe high risk of surgery, even younger patients were taken up. So moving quickly from the aortic valve to the mitral valve. Now for the mitral valve, we have the treatment for mitral regurgitation. And the mitral regurgitation treatment, as we all know, is very much required, especially in those patients who have low ejection fraction, which is the functional MR patients, and also those patients who are post-surgical patients, post-CABG, or those patients who are elderly patients who have high risk for surgery. These patients can be taken for a mitral clip procedure. Annuloplasty or valve replacement can also be done, but annuloplasty is still not fully into the usage in commercial usage, but mitral clip is now commercially available in India. We have been using this technology for the last 2 years. Dr. Seth, who did the first case, and so on the same day, we also did the mitral clip in 2018. And initially, we just started doing with the NTR, and now we have started using the new device, which is the XTR, which is the extended length device, very effectively. Even yesterday we did one, and the patient is being discharged today. So that is the effectivity of this procedure. It makes a double orifice mitral valve, as you can see here, and the clip is implanted. And generally, I must tell you that this procedure is a T-guided procedure, where we go transseptally, and T is the most important thing which we require, T imaging during the procedure, because there is no contrast given during the mitral clip implantation. No contrast, fluoro of much use here. It is mainly the transesophageal guidance that we decide to take these patients. So most of these patients they have to be moderate to severe or severe mitral regurgitation, as was the criteria for the COAPT trial, which is the most pivotal trial, I must say, to establish this therapy now, because after this trial, it was approved by FDA and also everywhere in the world. And soon after that, even India, it has been approved from DCGI. So symptomatic patients of severe mitral regurgitation and MR originating from P2 malcoaptation, patients who are not candidates for mitral valve surgery, these patients can be taken up, and also those patients who are low ejection fraction. So I won't go into the annuloplasty thing because it is still being developed. It's under clinical development, but the development of mitral clip has been quite a long development. Starting in 2003 was the first implant, and now in FDA approval came in 2013, and in 2020 we have approval in India. So the first case was done in 18, and now we have done the first XTR case also yesterday. So it is quite effective, and the patients can, and the most important part is that we do not give any harm to the patient. That is the most important part when we are doing mitral clip procedures. And it's only that, we will benefit both the degenerative MRs are the most benefited, and then there comes the number of the functional MRs, where the ejection fraction is above 20%, and they are high risk patients for surgery. These patients can be done effectively with a mitral clip implantation. So transcatheter mitral clip procedure is very effective. Generally, it takes about 1.5 to 2 hours. Then we move to another structural heart intervention, which is the mitral valve replacement. And here we are doing these replacements for, which is known as TMVR. is for mainly the best results are in valve and valve implantations. But and this is known as TMVI-VR. But in transcatheter valve and ring procedures are also found to be effective. If there is a previous ring which has been put, mitral annular ring failure can be done. And in native valves, if there is a severe mitral annular calcification of more than 270 degrees of calcium ring, these patients can respond better to a valve and valve percutaneous replacement if surgery cannot be done. So these are some of the data which is available with this. The VIVID registry and also data from some other registries show that it is a very effective procedure. Both valve and ring procedures have been found to be effective. And this is a procedure is again percutaneous, goes through the femoral vein, and the same valve as we use in the aortic position, the same Sapien 3 valve, or now even the My valve, which is the from Merrill, can be used. We have used both these kind of valves from the same from femoral venous approach. But in here, the only difference is that we have to keep the valve in the reverse direction. Otherwise, it will not function. So this is one of the first patients which we did. 82-year-old lady, mitral valve failure, had repeated hospitalizations for LVF, and then we brought her to the hospital with a very high risk. Surgical mortality was assessed, discussed with the surgeons, and they proposed that we do this procedure. So this is the chart which we use to size the valve. And this is available on the web, and we can use it online, and this app is available. So we can size whichever size of the valve has been used and which type of valve has been used. Based on that, we measure the true ID of the valve.
Dr. Chandra, you have 2 more minutes now.
Okay, I'm just finishing now. There is not much here. And this patient, we had an ECMO standby, and during with the TE procedure, it's also TE guided. So most of the interventions are TE guided. So here we did a valve in valve implantation. As you can see here, that this valve is going inside, and then we closed the septum through a atrial septal device. As you can see here, this is a valve in valve, and this is the ASD device closure. So this is the echo showing that there is no leakage across the mitral valve. And this is one of our first patients. For tricuspid valve regurgitations, also now we have therapies, and this is one of the patients and representative patient, 80-year-old, with a previous mitral regurgitation treated by valve replacement, now developing severe TR. So we treated this with a tricuspid valve replacement with a trick valve, which is a bicable valve, and again going from the femoral vein side. So this is one of them is the the SVC valve, the second is the IVC valve, and this has now been studied well. However, the long-term data is still not available, but this is a therapy which can be given to these no option patients where we did this procedure. So in this patient, first we did a PVL closure 2 years back, 3 years back, in fact, and then PVL was treated for the mitral valve. And then the patient also had a pacemaker, single chamber pacemaker, which he was not requiring that much. So it was removed, thinking that probably it will help the TR. Didn't do that much. So we used a trick valve after some time. And this is the trick valve implantation procedure, which you can see. The first valve is the superior vena cava valve, and the second valve was the inferior vena cava valve. You can see both these valves are in position. We check it with T again, that there is no leak. And then these patients, he's also doing very well. Paravalvular leak closures, again, has been very effective, and especially for both the mitral and the aortic. Again, this is a 3D TE guided procedure. You can see a severe leak, severe hole here on the side of a valve, and these are all kind of valves we have done, the Star Edwards, the bioprosthetic valves. You can see these devices. They sit quite elegantly and just keep the closure of these valves completed over a period of time. So these are many types, many patients. You can see these are 3D pictures, and you can see that the closure is done very effectively at the paravalvular sites. There is a mitral and aortic. All these positions can be closed. So many cases, we have done about 75 cases now, and the success rate has been quite high. LA exclusion, I think, again, another very effective interventional technique, such structural heart technique, where these left atrial appendages can be occluded using either the Watchman or the amulet device. Only thing we have to see that there is no LAA clot, and the size of the left atrial appendage has to be assessed before that. It's again a transseptal procedure. As you can see, T guided again, and here the role of T is also absolutely, to emphasize, very, very important. And these are the cases which we have done. And this is one of the cases where we did a TAVR and then they did a LA appendage closure in the same hospitalization. You can see the Watchman device after a TAVR which has been done. So now finally the BAV, the BMV and BPV is still there. Of course, we use it in young patients and is very effective. So finally take home, percutaneous aortic valve replacement for many cases of aortic stenosis. TMVIVR is feasible option for high surgical risk PHP failure patients. MitraClip, again, a very viable alternative to treat severe MR where surgery is high risk, and paravalvular leak closures, tricuspid valve replacement using bicaval valves and left atrial appendage have really changed the world of interventions in the field of structural heart interventions. Thank you very much.
Thank you, Dr. Praveen Chandra, for a very illustrative presentation of structural wall interventions. Without wasting the time, let me go on to the next speaker, Dr. Balbir Singh. I have to remind all the speakers that they stick to time because at 1:30 they start general body meeting. Dr. Balbir Singh, please.
So thank you, sirs, for being there today. And I'm going to share lot has been talked about it, a lot has been discussed, but we have not used it to the hilt. We have not used it to the numbers that it can be used to. Let's examine some of the aspects of this technology. So question is it the DRS for PCI? Can this be the final answer? Can this change the judgment? Can this change the future code of the patient's outcome over the next few years to come? So if we look at technologies of imaging, we saw CT angiography, we saw angiography, we saw intravascular ultrasound. So this is the image we get on intravascular ultrasound. But as you increase the resolution, as you increase the speed and accuracy, the image becomes brighter and more clear. So this is what the resolution change can bring about to the image. So from this kind of image to this kind of an image, and the resolution becomes 10 times more than IVUS. So the imaging resolution matters. You can see two images here. Here you can you have to do some guesswork that what kind of plaque is this. Here you know it is a fibrotic plaque all around. There's this is the vessel wall here, and there's a thick fibrotic plaque here. Here you have some guesswork to do. This is how a stent appears on IVUS, and this is how a stent appears on imaging with OCT. Clearly, a huge difference in resolution. And does this resolution really matter? This is IVUS showing calcium from hair to hair, but does not tell you the thickness of this calcium. Here you can see this calcium, same boundaries, but some extension here, and you can measure the thickness of this calcium, which also adds to values. So there are some advantages, as I already said. So there's been a lot of discussion of what one procedure over another procedure, but better resolution makes things better. But question comes, do we have the data? So do we have data to suggest that these imaging techniques are helping us in the patient outcome or in reducing the MACE? This was Illumine 1. So we have had Illumine 1, 2, and 3. So I'm being a part of Illumine 4, which was a very rigorous trial. Illumine 4 is one of the most rigorous trials in the history of imaging for the coronaries. Illumine 4 is in complex lesions like bifurcations, calcium, like left ostium, long lesions. So these are the kinds of lesions which have been recruited. And the criteria are rigid, very rigid. At every step of the procedure, an OCT is to be performed. And you have to optimize the stent to 90% of the mean area by OCT. So Illumine 1 taught us that OCT implanted PCI procedures, there was a change in strategies. Either the stent length, stent diameter in 57% of the patients, malopposition was missed, or edge dissections were missed. And all of this was associated with reduced rates of MI at 1 year. So this clearly good benefit with Element 1. So Element 2 told us, it compared against IVUS, that with IVUS, stent expansion parameters are same, but you look better with malposition, plaque protrusion, or edge dissection, much better than IVUS. For example, in this image, you see a dissection here, and you hardly can make out anything. I would not be very confident to say this is an edge dissection, while on this, I'm 100% sure that this is an edge dissection. Same is a tissue prolapse and same is malposition. You can't see any malposition here, but you clearly see malposition there. So this matters. So the Element 3 results also were similar, that stent expansion was same with IVUS and OCT, but there are some advantages in terms of other things with OCT. So OCT detected 2.5 times more dissections, 45% more malpositions, and 3 times more plaque protrusions. Has this changed with the guidelines? Yes, guidelines have been looking at what has been going on and have upgraded OCT for stent optimization. You can see it has become 2A. From 2B, it becomes so intravascular ultrasound and OCT. So why just 2A? Why not 1A? I guess they're waiting for trials like Element 4, which can actually tell you that they have an impact on long-term prognosis of patients. If it shows, which Element 4 is looking at 2 years results, then this will be a class 1A indication because you change the outcome in long-term with imaging modality. So this is how a stent expansion looks like. This is a image, a running image, and you want 95% or more MSA, which is very, very difficult to achieve. We have settled to 90%, and 90% is achieved only in 70% of the patients. So to expand stent that well is really takes effort. So this is how malposition looks like, not touching the wall. And this is how a dissection looks like. This is a plaque protrusion. And this is a patient who had a stent thrombosis. This is the thrombus within the stent. And you see when the OCT was performed, there was a distal edge dissection. This is a false lumen and this is a true lumen. And a proximal stent malposition. So two wrong things had happened in this patient, which resulted in stent thrombosis. So if all these factors are corrected, you may actually benefit these patients. This is a patient who had a everolimus stent hair from hair to hair. This was the lesion which was stented at that time. And at B, this is the part at B, you see a lipid-rich plaque here. So this is the vessel, which is little narrow, not completely narrow. So the operator would have felt that it's okay, but there was a lipid-rich plaque. He came back with restenosis within this lipid-rich plaque. So you can define the areas where you want to place a stent. So you would like to avoid, you would like to go here or maybe even here. You may choose a longer stent, but try to go from healthy to healthy area. That really helps. Let's look at another example. This is a patient, this is the result after an LAD angioplasty. This is the lumen area, which is 5.9 at the ostium of LAD. Now, 5.9 area is not too good at the ostium of LAD. One likes to get it around 7 or so. So this was where it is. Angiography looks perfect. So we went ahead, dilated again with a 3.5 millimeter balloon. At the same point, the area becomes 8 and the expansion becomes much better. The same point I have taken, same point. Just 5.9, 8. Now this transforms into, if somebody says this will not transform into long-term benefit or loss, I would not agree. This angiographically and this angiographically is same, and this areas are totally different. So it's a modality which has to be understood. This is a patient who has stent failure, stent restenosis here, and you see this part of the stent has not expanded at all. After the balloon dilatation, this stent becomes much bigger, and then another stent is placed. So underexpanded stent, leaving an underexpanded stent is a major predictor of restenosis and thrombosis. Now let's look at this lady, a young lady with a circumflex lesion, which was dilated. The point is here. This is image A looks very clean and good after the stent, but this is the OCT image. The MLA, minimal lumen area, is 3.28, and I'm not going to accept it because the expansion is just 52%. We dilate it further. The angiographically looks the same. This and this are the same, but the MLA increases to 3.7. Then we dilate further, not satisfied. The MLA goes to 5.05. Same patient, 3 angiographic pictures looking absolutely same, and look at the lumen areas totally different. So this illusion of angiography looking normal can always be very, very difficult. So calcium is another point which we know is very difficult, and treating calcium with rotablator or IVL or with very high pressure balloons can be change how we actually benefit these patients. So this is a calcium cuts after a rotablator, and then we achieve good stent expansion. So to predict expansion, stent and expansion, calcium is one of the biggest predictors. And how to track calcium, OCT cannot be anything better than OCT. Bifurcation lesions are very important, and 3D bifurcation view like this one tells you guide through the side of the problem. And many bifurcation patients, we have had problems, and OCT has guided us through. Like, for example, this is a bifurcation lesion, which we were intending to do a DK crush, but the balloon wouldn't go. Why would the balloon not go? Because this link of this strut is hitting against this stent. So we had to open this, and there's a crushed portion of the stent from here to here, which is causing problems. So this was what problems were, and we finally were able to open the link and open the stent on both sides, giving such a big opening. And you saw the previous opening. Now you see the opening on the side of the side branch. Last case, and then I would close it. Let's look at this case. This is the angiographic picture. Looks that the final stent is excellent, but this is the picture inside the stent. This is the angiographic picture at this point, and this is what it is. A huge thrombus within the stent. This is the thrombus. You see, this is white thrombus. So this was sucked out, and then more heparin was given, and the final picture was a clean stent with no thrombus. You can see it has expanded and there's no thrombus. So I would say that based on what I have shown you, should OCT replace all PCI decision making? Maybe imaging, IVUS and OCT can be combined, but OCT being better resolution can give you much more. Place all decision making. It is a matter of experience. It is a matter of thought process, and I guess it should, if a patient can afford and you have the time to do it, an inclination to do it, and do it well, I think there is no reason why it should not be used. Thank you very much for being there today.
Thank you, Balbir, for sticking to time. And the take-home message was very clear and loud that the OCT is the standard and the most current method of imaging in coronary artery disease, especially while doing interventions. I would now invite Dr. S.K. Chopra to introduce the next speaker. Dr. T.S. Kalir.
Dr. Clare, I think, needs no introduction to our audience. He's a very eminent electrophysiologist, and the topic is going to cover is choosing optimal and alternate sites of cardiac pacing. Dr. T.S. Clare, sir.
HK, good morning. Am I audible?
Yes.
Yeah, you're audible.
Yes, sir.
Okay, can you just see my enable editing?
Yes.
So my slides are visible?
Yes, sir. Yes.
Okay, first of all, thank you, Csi Delhi, for inviting me for this talk. And I'm going to talk about the pacing, conventional and alternative sites of cardiac pacing. Well, the history of cardiac pacing is 1952. Dr. Zoll first demonstrated transcutaneous methodology to pace the heart. And it was 1958 when Dr. Furman did the first endocardial pacing. And the implanted pacemaker was first in Sweden. Mr. Arne got the first pacemaker in 1958. It worked for only 3 hours. Next, it had to be re-implanted. From there, I think we have moved a long distance. And if you see dual chamber pacemakers becoming smaller and smaller, and the latest you see is a Micra, which is a leadless pacemaker, and 2 grams of weight and 0.8 ml of volume. So it's a great step forward. Now, basically, when we take the pacemaker therapy, it means conventional cardiac pacing is effective for preventing syncope due to ventricular bradycardia, death due to asystole. And this kind of ECGs we are very familiar with. This is a patient with conventional RV apical pacing with the very broad QRS complex left bundle branch block, but nonetheless, it does prevent syncope. And this is the ECG, which even if I'm not told that it is a paced ECG, I will say this is a normal ECG. So this is the latest technology. This can be achieved only by what is called as physiological pacing or conduction system pacing with a QRS complex, fantastic, something like 80 or 90 milliseconds. Now, we see the goals of new therapy are bradycardia indicated patients, for example, pacemaker or ICD patients to prevent bradycardia, provide chronotropic competence and normal ventricular activation sequence. This is important. This is a modern goal. Minimal ventricular pacing we want in non-bradycardia patients. We just want as far as possible avoid ventricular pacing, for example, in ICD patients. Well, basically, apical pacing started because it was very easy to position the lead, tined lead into the RB apex. Otherwise, it will not stick anywhere. But we also know that the ventricular apical pacing produces heart failure in around 8% of the patients, atrial fibrillation, and altered myocardial structure, which has been demonstrated even on histopathology in these patients. When we say there have been a number of trials to show the deleterious effects of the RV apical pacing, like there's the most David and Merit 2 trial. And this is a data from the Merit 2 trial to show that patients where the pacing was less than 50%, they had much less mortality. Patients where the pacing was more than 50%, this was almost like a non-ICD patients. So there's no doubt that RV apical pacing does increase the mortality in many of these patients. Well, there have been a lot of studies to compare the RV apical pacing versus the RV OT septal or mid-septal pacing with the kind of very mixed results. This is a data. 8 trials were positive, 1 trial was negative. There was no difference. And these studies have been criticized by various lacunae. For example, location of the RV septal and RV OT was not known. Non-physiological pacing was used, VVI, not DDD. And there were arbitrary AV delays kept. Many studies, the sites were not defined really. And comorbidities were not considered. So this data is very suspect and really didn't lead us to anywhere. But if we see one of the latest trials, the weight is not settled as yet. Protect pace study, which was published in 2015. Yeah, 2015. Again, it did not show much difference as compared to RV apical pacing and the RV high septal pacing as far as the ejection fraction is concerned after 2 years. Well, there is a data that this is another study published in the cardiovascular journal. 58 patients followed by 29 months. This trial did show that the septal mid-septal pacing was superior, and it preserved ejection fraction and LV systolic volume better as compared to RV apical pacing. So if we go to the beneficial effects of right ventricular non-apical versus apical pacing, this is another systemic review involving 14 randomized trials and around almost like 754 patients. And this also showed this data that there is higher ejection fraction in RV non-apical pacing groups. But this was proven only in randomized trials where the follow-up was 12 months follow-up. So when we go to RV septal versus RV apical pacing, The pros are narrow. You always get a narrow QRS complex if you do a septal pacing. This is, I think, the experience of all of us. The results of several short-term small studies have been positive. If you see the cons against the septal pacing, there is a conflicting data regarding the non-physiological heart depolarization by septal pacing, and results of several small and 5 big randomized trials were not very encouraging. The meta-analysis of 2 randomized studies in DDD and CRT patients were also not very favorable. And when we go to the recommendation of the ECE European Society in 2013, they didn't recommend that septal pacing is superior as compared to apical pacing. But I think as far as I'm concerned, I am very sure that people who cannot do physiological pacing, I think mid-septal pacing is certainly better than the apical pacing. This is at least my experience for the last 20 years. There's no harm at all of using mid-septum as a pacing modality. QRS is narrow, the perforation, the pericardial effusions are almost nil. So in case you are not able to do physiological pacing, mid-septal pacing certainly is better as compared to the apical pacing. Now coming to the most latest is the what is called as physiological pacing or conduction system pacing, his bundle and left bundle branch pacing. If you see the this is the initial cardiac activation normal QRS complex. Pacing solution is that you pace the RV apex, you get a very broad complex. Even if you give a biventricular pacing, you don't get the narrow complex. You do get narrower than the apical pacing, but certainly broader than the intrinsic QRS complex. If a patient has left bundle, if you do biventricular, yes, you do decrease the QRS complex, but it doesn't come back to normal. But if you do his bundle a pacing or a physiological pacing, you have the capability to become the QRS normal. If there is a patient with PR prolongation and narrow QRS complex, if you pace them with the traditional RV apical pacing or even a mid-septal pacing, or even if you do biventricular pacing, you don't get the narrow QRS complex. The only way to get the narrow QRS complex in these patients is to give a his bundle pacing. Well, we know that the anatomy of the his the conduction system, AV node, from AV node, this membrane is septum, and then you have branching into left and the right bundle. The thing which we have learned now is that there is a longitudinal dissociation. That means the fibers going to the left bundle and right bundle, they get separated from the beginning. And if you now, the only way to pace the normal conduction system is if you either go distal to the block here, for example, this is the lead here, then you will get a absolutely narrow QRS complex. If you pace even proximal to the block, but at a high threshold, you can still recruit the conduction system. But in case you want to achieve the capture at a low threshold, then you have to go distal to the area of the block. Well, this I think we know all. Now this slide is important. This is AV node, and this is the selective his bundle pacing site. And that means you are really going on to the his bundle. But if you are very close to the his bundle, this will be non-selective. Non-selective means that you will capture his bundle, you will also capture some myocardium. And similarly, the situation of the left bundle, like this is a selective left bundle pacing. This will be the septal pacing, left ventricular septal pacing, without any capture of the bundle. This will be non-selective left bundle pacing. That means you will capture some myocardium and at the same time left bundle. And similarly, the story of the right side. If your lead is on the right side of the septum, you will do the RV septal pacing on the right side. And if you have to go to this is the mid septal pacing here. If you have a lead, want to base the left bundle, and of course the anode will be on the right side, the anode can capture the right side of the septum. This is called anodal capture. I think this is important to understand. So if we go to the methodology of pacing, the best will be his bundle pacing. Selective and non-selective results will be equal. Then will be left bundle branch pacing, selective and non-selective. Then will be deep septal or mid-septal pacing. Then is the LV septal pacing. Then is the left bundle branch with anodal capture and RV septal pacing. This is the concept which I think all people who want to do a physiological pacing and conduction system pacing have to understand. Coming to the
Claire, you got 1 more minute.
Coming to the fluoroscopic picture, this is the his bundle position and this is the left bundle position. I think there is special equipment to be used, which is available from Medtronic. This sheath is very important and the lead is very special. This is the stilletless and the screw is naked. Even the sheath deflectable is going to be available very soon. And there is a lot of data to show that there is a definitely improvement in the end results by physiological pacing. On an average, there is 11% increase in the ejection fraction in CRT patients. And even in right bundle, typical right bundle, for example, there is no CRT which has been shown to be effective at all. But this study has shown 78% success rate in right bundle recruitment in right bundle branch patients and 10% improvement in ejection fraction. We have done a lot of these patients. See here, this was a pacing CRT failure. We did the his bundle pacing, got an excellent QRS complex, and the ejection fraction in 2 months' time increased to 50% from 30%. Another patient I want to show you, this patient was referred to us for CRT-D, his left bundle branch bomb, 210 millisecond, but we didn't put the left ventricular lead, we did just the his bundle pacing, and the post his bundle pacing, the QRS was 104 milliseconds. This kind of QRS we cannot achieve in any kind of even best possible LV lead position. This is just to show the same patient in the fluoroscopy, and very good clinical results. And there are many more patients, this is left bundle, you see excellent his bundle pace rhythm in these patients. Patients who are dependent, for example, and you need a pacing, there it is maybe a good idea to do a left bundle pacing, because the reliability of the left bundle pacing is much more, long-term results are better. You get very good R waves. So if a patient is really dependent, I think if you're not able to get a very reliable his bundle pacing, left bundle pacing is a very good alternative in these patients. This is the position to show the left bundle pacing, and if you can get the activation time of less than 75 milliseconds, these patients do very well. This is a patient with a complete heart block who had a right bundle branch block, escape rhythm, and this is after left bundle pacing. So fantastic QRS complex. So I think there are a lot of other cases, but the shortage of time, I will just conclude. This is our data. Now it is almost 80 patients. We get success in about 92-93% of the patients. We got only one patient who had a displacement of the left bundle pacing. The next day, the lead, the impedance decreased and lead had perforated into the LV. We had to reposition that. But otherwise, no other patient we had to reopen, and all the thresholds are standing very, very good. So we are really excited in this technology. And coming to the conclusion, what is the optimal site for ventricular pacing? To protect synchrony, we must give atrial-based pacemaker. To prevent desynchronization, selective site conduction system pacing. So we have to really focus on conduction system pacing to restore synchrony. CRT, late activation site pacing, conduction system pacing is the best. Now, as far as our philosophy is concerned, even for any CRT, our first option is to do his bundle pacing. If we are not happy with the QRS narrowing, then we go to the left bundle branch pacing. And if the left bundle branch pacing also does not satisfy narrowing of QRS complex, then only we go and put additional left ventricular lead. Because there are many patients who will have distal conduction system disease, and there you need to put a left ventricular lead, and that gives the maximal possible results in these patients. So my dear friends, I think with these remarks, I thank and I finish the talk. Thank you very much.
Thank you, Dr. Clare, for excellent presentation. We now go to the next speaker, Dr. Sanjay Tyagi, who is synonymous with the vascular interventions in the history of cardiology. and he's going to talk on vascular interventions, creating a ray of hope. Dr. Sanjay Tyagi, please. Over to Dr. Tyagi.
Yes. Good afternoon, sir.
Good afternoon.
I will like to share my slides.
Yes, go ahead.
The slides are opening. Just will take a few moments. I hope you can see the slides, sir.
Yes, sir.
Good afternoon, respected Professor Khairullah, Dr. Chopra, and dear colleagues. Talking on vascular interventions, creating a ray of hope in hopeless situations. This is the topic of my presentation today. Patients with severe cerebral ischemia have devastating neurological symptoms. Severe stenosis of arteries lead to present with mainly syncope, strokes, TIAs, seizures, or visual loss. They have a severe occlusion of arch vessels, so the cerebral perfusion is markedly affected. So at this stage, revascularization becomes essential to improve perfusion of the severely ischemic cerebrovascular circulation. Traditionally, bypass graft surgery has been used in such situations, but it has several challenges. In situations like this, as you can see here, there is total occlusion of all the arch vessels. The brachiocephalic artery is totally occluded. The left common carotid artery is totally occluded. Left subclavian artery also totally occluded. So all the arch vessels are totally occluded. Here it is, if we take up the patient for bypass surgery, then it will require thoracotomy, median sternotomy, hypothermic circulatory arrest, and need of cerebral perfusion. Also, multifocal arterial involvement would be required. And often there is fragile or calcified tissues, making surgery very difficult. So in such a situation, we have to resort to some other means to salvage patients in a more safe environment, which is very effective. Considering this young 42 years old female who presented to us with recurrent syncopal problems and recurrent seizures, she had total occlusion of most of the arch vessels. Only the left brachiocephalic was 99% stenosis, on which the patient was surviving. Here lies the challenge, how to approach this patient. Just think about it. In this situation, we have to the catheter, the guiding catheter has to be engaged into the brachiocephalic artery, which is occluded from the ostium, and the catheters that are available are usually that we use are the coronary catheters, which are not very stable in such a situation. Also, in such a tightly stenosed artery, which is atherosclerotic stenosis, if we pass O35 wire, then there will be dissections and you will have a brain dead patient. So this is the challenge of this situation. So here we have to resort to use of the coronary armamentarium, and we used a right coronary guiding catheter to engage the ostium of the left the brachiocephalic artery. But here another challenge is what type of stent to be used. The commonly used stent in such situation preferred should be a balloon expandable stent, and over a O14 wire, which with a moving aorta and unstable guiding catheter, this will be very difficult. So we have to approach this patient from the right brachial artery and pass a guide wire retrogradely from in the brachial artery, which is hardly palpable, and then pass the coronary guide, soft tip coronary guide wire in through the this innominate artery, so as to maintain the access to this more than a 99% stenosis of the left main situation, where even a little error can cause the patient to be in a brain dead situation. So we passed a 014 soft tip guide wire into the brachiocephalic artery, and then expanded it with the help of balloon. And after balloon expansion, we positioned a balloon expandable stent into the ostium of the brachiocephalic artery, and obtained the angiogram by the aortogram, and which showed the artery was fully expanded, and the flow to the brain through the carotid artery, vertebral artery could be restored, and the patient could be relieved of her problem of severe recurrent seizures and syncope, which the patient was suffering from last two months. Severe brain ischemia can cause a number of problems. This is another example of a patient who had total occlusion of all the arch vessels. As you can see here, the brachiocephalic, carotid, and vertebral artery all are totally occluded. Here it is very important to plan the procedure, what should be done. And what comes handy is a CT angiogram should be done in these patients before taking up the patient for further, so as to plan the procedure. We have to, in this patient, we engage the ostium of the innominate artery, and then with the help of catheter, and then a coronary wire was crossed into the carotid artery, and another wire was crossed into the subclavian artery, and dilated. Both the brachiocephalic artery was dilated, and the common carotid artery was dilated, and the subclavian artery was dilated, creating an excess. As you can see here, after balloon dilatation, there have been improvement in the lumen of these artery, and after balloon dilatation, we placed a stent in the ostium. As you can see here, initially we placed a stent, a balloon expandable stent into the subclavian artery, right from the ostium or at the origin of the carotid artery, and then self-expandable stent from the innominate to the common carotid artery, opening up the flow to the brain, and opening up the cerebral circulation, relieving this patient of her problem of recurrent syncope and seizures. Another type of rare problems that we have seen in this patient is loss of vision. When the cerebral circulation is markedly affected, the brain does not get the blood supply. These patients often present with dizziness and syncope and loss of vision. They can see when they are lying down, but when they stand up or sit down, they are not able to see anything. So this indicates that there is severe cerebral ischemia, and in this patient, like all the other arteries were totally occluded. Subclavian artery was totally, left subclavian was totally occluded. Left common carotid, the common carotid artery left was totally occluded, and only flowing artery was this innominate artery going into the vertebral artery. And here we were positioned the guiding catheter into the ostium of the brachiocephalic artery, passing a guide wire into the into the vertebral artery and into the subclavian artery, and doing balloon dilatation followed by stent implantation from the subclavian, brachiocephalic subclavian into the vertebral, opening up the flow into the through the vertebral artery, and also opening up the subclavian artery, thus restoring the flow and relieving the patient. And on follow-up also, we have done this study, and patient continues to do well on long-term follow-up. This is another young girl, 27-year-old female with blurring of vision for last 2 months and postural seizures. As soon as the patient used to sit up, she used to get blind. So she was afraid of sitting up and afraid of going into the cath lab also. After taking up the patient for angiogram, and digital subtraction angiogram showed total occlusion of all the arteries. So you can see the brachiocephalic is totally occluded. The common carotid is markedly stenosed, long segment totally stenosis, and there is a stenosis in the subclavian artery, vertebral artery, and the left subclavian artery. So here also we passed the guide wire into the subclavian artery ostium, and then dilated and passed a guide wire into the vertebral and into the subclavian, doing the bifurcation angioplasty in this situation. And after doing bifurcation angioplasty of the subclavian and the vertebral artery, we placed a stent into the subclavian artery, into the vertebral artery from the subclavian artery, and did only a balloon dilatation of the subclavian artery. This patient improved the flow into the subclavian artery and to the vertebral artery, and patient became asymptomatic. Even this minor restoration of the blood flow to the cerebral circulation is sufficient to relieve their symptoms. So this is a good palliation. And on follow-up, this patient developed restenosis and developed recurrence of the symptoms. The patient had recurrence of her blindness, and the patient came back again The angiogram showed the stenosis in the subclavian artery and the ostium of the vertebral artery. We did a cutting balloon dilatation. You can see here a cutting balloon, and did a cutting balloon dilatation of the subclavian artery and the vertebral artery, leaving the patient of her severe stenosis. And now the patient continues to do well on long-term follow-up. So these are some of the patients. Another example from patient who had long segment severe stenosis in the common carotid artery and the vertebral artery, opened up with the help of this balloon angioplasty technique, leaving the patient of her severe ischemic symptoms, and renal angioplasty was done along with this because the patient are having severe hypertension and patient had very poor ejection fraction. After angioplasty, renal angioplasty and this arch vessel angioplasty, patient's symptoms improved and her ejection fraction also showed good improvement. But patient developed restenosis in this carotid artery while the other artery continued to remain, and this was also opened up with the help of cutting balloon angioplasty.
Dr. Tyagi, you got 1 more minute now.
Yes, sir. So this is the last case that I want to show you, is a severe stenosis of the atherosclerotic artery, multiple occlusion, not only aortoarteritis, but atherosclerosis can also cause severe stenosis of the arch vessels. With these endovascular interventions, percutaneous endovascular impressions, interventions could replace the markedly these patients of their symptoms. As you can see here, the brachiocephalic artery and the common carotid artery flow has been restored in this patient. The perfusion, cerebral perfusion improves by these procedures. So in conclusion, I would like to say that it requires very careful preoperative planning. A CT angiogram is required in these patients, and meticulous technique is also required. And close monitoring of the patient after intervention is required in these patients. But this can improve the cerebral perfusion and provide symptomatic relief and otherwise the patient would have required an extensive operation, which often even the cardiovascular surgeons are afraid of doing. But restenosis is more commonly seen in patients with aortoarteritis as compared to atherosclerosis because of this active stage of the disease in these patients and dense fibrosis. Tachyceous arteritis also needs immunosuppressive treatment and often repeat angioplasty with the help of cutting balloon or drug-eluting balloons, but it has good long-term results. Thank you very much, sir, for your patient listening, and thank you very much, everybody.
Thank you, Dr. Tyagi. Dr. S.K. Chopra, to please introduce the next speaker.
Thank you very much, sir. I think we have the last presentation now by Dr. N.N. Khanna, and the topic is going to cover in vascular intervention, below the knee intervention in critical limb ischemia. Dr. N.N. Khanna, sir.
Thank you very much, Dr. Khaliullah, Dr. Chopra for inviting me, and Dr. Mohit and Dr. Tyagi for inviting me for this conference. I'm going to be speaking on in the next 10 minutes on below knee angioplasty tips and tricks. This is something new, and this is very common and a common problem, which is especially in diabetic foot. And India, as we know, the diabetic capital. And now with more atherosclerotic disease and longer longevity and also diabetes, this disease is becoming very common. And often, initially, people were referred for amputation, but now most of these limbs can be saved. So I'm just going to give you a brief idea of what it is and how it is done and what are the potential advantages and the newer directions in the treatment. Now, infrapopliteal disease normally presents with CLI, which is critical limb ischemia, and it is usually combined with iliac femoral and tibial disease in 8%. And it is combined as an isolated disease in about 32% of patients. And typically, this patient group is a group of complex below the knee lesions and represents increasing population due to increasing prevalence of diabetes and end-stage renal failure. And it is present in about 60 to 70% of all patients who have long-standing renal failure. So not all tibial lesions need to be treated. It is only tibial lesions which are causing critical. Often we treat multiple tibial arteries. Many a times we treat by, or sometimes even by seeing which area is ischemic. And our aim is to have at least one line straight flow from the iliacs down to the foot. But we must be treated. I'm not going to be going to the detail. We can have access, which would be ipsilateral femoral or could be contralateral femoral through a retrograde approach. or we can use transpedal, transcollateral, or direct graft punctures to treat these patients. Different wires are used. Normally, we combine both radiological and coronary techniques. We use wires from 014 to 018 to 035. Usually, smaller profile balloons are used. Smaller profile long balloons and non-compliant balloons are used. And drug-eluting technologies are the in thing now, and drug-eluting balloons actually reduce restenosis in these long calcified lesions. And stents are rarely indicated, but when they are indicated, they are usually for dissection or recall. And we have both drug-eluting stents and long self-expanding stents. If you look at the results, the technical results are very good, almost 90% success, about 90 to 95% success in limb salvage rate. The re-stenosis is high, but re-stenosis here is not of much value because the aim is to treat a non-healing ulcer or prevent a gangrene, and over a time, even if the re-stenosis happens, it can be retackled, or we have enough collaterals which are developed, and we convert a patient of critical limb ischemia to a claudican, and we can save the limb. Again, approaches I'm going to be skipping because of the paucity of time, but I'm going to give you some concepts. Many a times when we cannot enter the vessel and the true lumen of the vessel, we try CPO wires, and if we cannot, it is much better that we form this loop and go subintimally. We should know how to get into a subintimal space. And if you see here, you have a linear calcification that guides you to the vessel wall, and you can actually dissect it all the way down, and then use a micro catheter to go down and enter the true lumen, either with a stiff end of the thermo wire or a stiff end of the 014 or 018 wire. And once you are there, you reach the catheter, you take out the wire, confirm that you are in the true lumen, and then you can balloon or stent this entire false lumen and create a true lumen to false lumen to true lumen connection, and thereby revascularize the distal limb. 20% of these chronic CTOs of the limb below the knee actually are unsuccessful in wiring, and these can be alternatively tackled by subintimal angioplasty. Many a times we cannot go from the antegrade approach, so we take a retrograde approach. We either have a tibial puncture or a pedal puncture. Here we use a 3 or 4 French sheath and directly go with the wire. And once we have the wire, we can go up and actually snare this wire up from the femoral sheath on the ipsilateral side or contralateral side and do angioplasty like this. Or sometimes it is difficult, both wires go into a subintimal place, and then what we do a safari or a rendezvous technique. We get both the wires into the subintimal space. We take balloons from both sides and rupture this intima or the true membrane in between. So now we have a true false and a false lumen connection, and then entering into a true lumen. And then we get this wire either from above down or from down above, and then complete our angioplasty and stent. So this is known as a double balloon or a double approach rendezvous technique, and this is one of our patients which we did. And this is usually successful in about 75% of the patients who fail a direct luminal recanalization. Now, this is a series from Dr. Andrew Smits from Leipzig. They had 68 patients and a follow-up of 27 out of these 68 patients. A follow-up period was 3 to 24 months. And during a follow-up angiography or MR done by MR or duplex, there was no restenosis or occlusion of the former puncture site at the fetal lateral. So these actually remain well, unlike our coronary thinking. And what is also very important is that we must maintain this pedal plantar loop. This technique is very important. Suppose there is a here, integrately, what you do is you go in the other branch complete this pedal plant. So these are some of our results where we have completed the angioplasty with the pedal plantar loop going from the contralateral side. And sometimes we have these blockages all the way down from top to bottom. And in these sort of situations, what we do is we do an angioplasty right from the iliac to this place.
The organizers to please see that the audio is on.
Is my audio on or it's gone?
So it's on now. Go ahead, please. Go ahead, Dr.
Okay, fine. So sometimes we have these blockages right from the iliac down to the foot, and in those sort of situations, sometimes we have this blockages from iliac down to the foot, and many a times what we do is we do an angioplasty of the iliac, femorals, popliteal, and all the way down to below the knee lesions, and we put nitinol and self-expanding stents or covered stents in the popliteal and in the femoral artery, and paclitaxel drug-eluting balloon in the below the knee lesions. And this is the results which we get, and this is not uncommon to see. This is one of our, we also use drug-eluting stents now and bioabsorbable stents. This is one of our cases which we did in India Live in 2018. Severe below infrainguinal disease, and what we see here is the tibioperoneal trunk stenosis and total occlusion of the anterior tibial artery. We do a balloon angioplasty and put in a Credence BTK stent, which is a stent similar to the Miris 100, which is drug-eluting bioabsorbable stent, and this is the result which we got. And then similar lesion in the very diffuse lesion in the tibioperoneal trunk, total occlusion, both with peroneal and anterior tibial artery. This is the results which we got after putting in a Credence stent, which is a bioabsorbable stent, and doing angioplasty with a drug-eluting balloon. And once we have these sort of results, we have actually done an OCT and compared the lesions. We have completed 2 years of our the Credence BTK study, and this has been presented both in TCT and American College of Cardiology, and also in the EuroPCR, and now we are going to be writing about this with 30 patients with a 2-year follow-up. So just to sum up and cover for the loss of time, now at the end, at this as of today, we have different technologies, right from the drug-eluting balloon to cutting balloons to drug-eluting stents and bioabsorbable stents. We can treat this by antegrade punches, pedal and retrograde punches. We can employ techniques of CTO recanalization and the rendezvous technique, and prevent at least 80% of the amputations in patients where the life expectancy is less than 1 or 2 years, and also patients who are poor candidates for surgery and patients who have very diffuse distal disease and still bypass is not possible. And patients who cannot be treated like this now have another means of which we now are doing is a gene therapy or autologous implantation. And we had actually started a trial about 5 years ago, and we had results. Because of the government regulation, it was stopped, and again it started because of now enough data both at the national level and international level. And it's starting again for autologous.
Thank you, Dr. Khanna. I'll request Dr. C.P. Rai to please introduce Dr. D.S. Gambhir.
Before Dr. Roy introduces Dr. Gambhir, we are going to have the AGM shortly. So my request is that we finish this session in next 10 minutes so that we can join the AGM.
So Dr. Gambhir is the former professor of cardiology from the GB Pant, and presently he is working in Noida. In that hospital, he is heading cardiology and does a lot of intervention there. Dr. Gambhir, please.
So you're on mute.
Sorry. Dr. Gambhir is the former professor of cardiology from JB Pant Hospital, and he's done a lot of intervention, and particularly for the left main intervention, that is his specialty, and he presented many papers on that. I know I've been hearing him for last 15 years, and presently he's working in Noida and doing a lot of intervention work.
Thank you, Professor Khairullah, Dr. Chopra, CP Roy, and all the other persons on the chair, and my good afternoon to all the participants. Well, friends, as you know that until about late 70s, in patients who had drug refractory angina associated with left main coronary artery stenosis, the only modality of treatment for these patients was coronary artery bypass graft surgery. However, in late 70s, Andrea Grudzik performed the first coronary intervention in a patient with left anterior descending coronary artery stenosis. And this added a new armamentarium in the treatment of left main coronary artery disease as well. Unfortunately, in his first series of 50 patients, which was published in NEJM in way back 1979, 5 patients were treated for left main stenosis, and 2 of these died. So Andreas Grunzig made a comment that we have not been too successful in dilating left main coronary stents. Although the procedure is relatively simple, the potential complications are both serious and sudden. So he said that LMCA stenosis is a contraindication for balloon angioplasty. But since then, we have gone a long way, and several new things have been added, both in terms of the experience and expertise of the interventional cardiologists all over the world. A lot of data has emerged in early 2000s, and this data compared the role of PCI using various forms of stents, particularly the drug-eluting stents with coronary artery bypass graft surgery. These were not randomized studies, and the pooled data from 6 studies I put down over here showed that there was no significant difference in the incidence of death and MI between PCI and coronary artery bypass graft surgery. However, the data clearly showed that the incidence of revascularization or the need for revascularization was almost 3 times higher in patients who had undergone angioplasty with death compared to bypass graft surgery. So since then, again, new things got added, like I was guided stent implantation in the left main coronary artery stenosis using the newer generation of drug-eluting stents. And by the year 2009, this is what was being witnessed with patients with left main coronary artery stenosis. Between 2009 onwards to 2019, several prospective randomized studies have been published
And of these trials, there are trials which have used first generation of drug-eluting stents, and then there are two recent trials which have used the second and third generation of drug-eluting stents. And then there are 3 or 4 meta-analysis and pooled data. Now, using the first generation drug-eluting stents like Texas and Cypher, there have been 4 major studies, including 1,600 patients. But what is more important is to understand what is the inference drawn from the studies using the second generation drug-eluting stents. The Excel trial, which was published a year ago, included close to 1,900 patients, and the inclusion criteria was only for patients who had low to intermediate syntax score for left main stenosis. They excluded patients with a high syntax score, and the stent used was cobalt chromium everolimus eluting stent. Well, the Noble trial used the biolimus eluting stent in majority of the patients. However, this study included all categories of left main coronary artery stenosis, whether low, intermediate, and high risk source. The primary endpoint did not include target revascularization in the Excel trial, but all this was included in the Noble trial. Now let us look at the Excel trial. The Excel trial showed that the primary outcome at 5 years in terms of the all-cause mortality, stroke, and MI, there was no significant difference between the two modalities of treatment. However, the ischemia-driven revascularization was significantly higher after PCI compared to bypass graft surgery. Now, Noble trial showed a little difference in the data since they included repeat revascularization as well in the major adverse cardiac events. So the MACE at 5 years was higher with PCI as compared to bypass graft surgery. So therefore, they concluded that CABG was significantly better form of treatment for left main stenosis as compared to PCI. But there was no significant difference even in this trial as far as the overall mortality was concerned. And the data and the MACE were driven primarily by higher incidence of repeat revascularization following PCI compared to coronary artery bypass graft surgery. Then came the meta-analysis. The first of these meta-analysis was published in JAMA Cardiology in the year 2017, which included 4 randomized trials, including almost 4,400 patients, followed was 5 years in all. And this meta-analysis showed that the Kaplan-Meier survival curves, there was no significant difference in survival between the two modalities of treatment. Again, emphasizing that, as has been shown in the previous studies, that survival with the two modalities of treatment is almost equal. However, the incidence of repeat revascularization was again higher after PCI compared to bypass graft surgery. Very lately, a few months ago, another meta-analysis appeared in the Journal of Thoracic and Cardiovascular Surgery. And this also compared the role of PCI using drug-eluting stents versus bypass graft surgery. Now, this meta-analysis included 5 studies which were published between the year 2003 to 2015. Total number of patients enrolled were close to 4,500. The average syntax score was 24, and more than 2/3 of the patients had distal left main bifurcation stenosis. And when we look at the data, it showed that at 5 years, the all-cause mortality, there was no significant difference between the two forms of treatment. However, the myocardial infarction rate was now higher after PCI as compared to bypass graft surgery. Now, this was a little different from the earlier meta-analysis. There was no significant difference in the incidence of stroke. However, again, the repeat intervention was significantly greater for patients who had undergone a PCI using even drug-eluting stents. So this meta-analysis shows that whereas the all-cause mortality and the stroke were almost equal and at par with each other with the two modalities of treatment, the incidence of myocardial infarction was higher with PCI, and so also the need for repeat intervention was higher after PCI. Then we had a pooled analysis of at least 11 studies, which had included 11,500 patients. And out of these, almost 1/3 of the patients, close to 2,200 patients in each arm, PCI, and 2,200 patients in CABG arm, had left main coronary artery disease. And the follow-up was again 5 years in this. Now, this pool data brought out some very interesting features. This showed that there was no difference in mortality between PCI and CABG at 5 years, regardless of diabetic status. Until then, nobody had looked at differently in patients who had diabetes or patients who did not have diabetes. But this pooled analysis clearly showed that the two modalities of treatment were at par with each other, even in patients who are diabetic. This also showed that there was no significant difference between PCI and CABG, regardless of syntax score, whether the patient had low syntax score, intermediate syntax score, or a high syntax score. Now then comes the role of IVUS guided stent implantation in patients with left main stenosis. And again, a meta-analysis of nearly 4,500 patients who underwent angiographically guided versus intravascular ultrasound guided drug-eluting stent implantation for left main coronary artery disease. Now, this study or meta-analysis showed that there was a 31% relative risk reduction in the incidence of MACE in IVUS guided stent implantation compared to angiographic guided stent implantation, 45% reduction, relative risk reduction in all-cause mortality, 55% relative risk reduction in cardiac deaths, and 34% relative risk reduction in myocardial infarction with IVUS guided stent implantation as compared to angiography. So also the incidence of stent thrombosis were lower, and the need for repeat intervention was also lower.
Professor Gangir, please.
I'm just coming to that. So the last part is the follow-up. 10 years follow-up is now available because our surgeons have always been saying that you have a very short-term follow-up with PCI. So the 10 years follow-up of the syntax trials have now been published, and this included almost 840 patients in each arm. And the only primary endpoint was all-cause mortality. And this study had included almost 2/3 of the patients who had either left main with single vessel, 2-vessel, or 3-vessel disease. And once we look at the results and all-cause mortality at 10 years, there was no significant difference between the two modalities of treatment. So finally, as we look at the recommendations from various society, while in 2005, the recommendation for treatment of left main coronary artery disease using PCI was class 3, and it had risen to class 2A in 2011, particularly in patients who had a low syntax score or a isolated ostial or body of the left main stenosis, or a patient who had a higher risk of coronary artery bypass graft surgery. Now, we started doing left main stenosis way back in '96, but this is the data of 570 patients from 2004 to 2019, and we had a very high success rate of 98.3%. I'll not go into the graphics because of shortage of time. And so I think we have stopped sharing. So in conclusion, I think that the last slide was basically the conclusion slide, which showed that now we can do coronary intervention in a certain selected group of patients who do not have a very complex coronary anatomy, can be treated by PCI and CABG. PCI, so therefore PCI becomes an alternative modality of treatment in patients with left main coronary artery stenosis. Thank you very much.
Thank you, Professor Gambhir. It was an outstanding presentation of all the speakers. Because of shortage of time, we could not go into discussion and questions and answers. Please stand back for the general body meeting going to follow in a few seconds' time. Thank you very much for all the speakers. God bless you.
Thank you.
Doctor.
हेलो
Yeah, we can hear you.
मोहित ये अलग से करना पड़ेगा क्या? ओके मैं कर रहा हूँ। चल भेजा मैं कर लूंगा अभी देख व्हाट्सएप तो कर दे अगर नहीं हो तो मैं करता हूँ।
धूप में रखा था।
क्या करे, दे दे आपको खाना?
हाँ दे दो, खाना तो खाना ही है। घड़ी को भी ठीक है, बंद हो गई।
वहाँ तो हम लोग जा रहे हैं सीधे।
कहाँ?
बंद हो गया ना माता।
उसे जरा करवा लेना गाड़ी वाले से, टाइटन वाला नीचे ग्राउंड फ्लोर वही। अरे भाई ये जो दूसरा मॉल जो है, कौन सा मॉल है सबसे पुराना वाला जो हम लोग जाते हैं?
मॉल ऑफ इंडिया, वो तो बंद हो गया ना।
मॉल ऑफ इंडिया बंद हो गया?
नहीं,
हाँ।
मॉल ऑफ नहीं, GIP, वो नीचे का सब खत्म हो गया।
एक ग्राउंड फ्लोर में ही था उसका, वो जो टाइटन का तो टाइटन के शॉप सेशन चल रहा है।
Hello. Hello. So this meeting has been ended. Those who are AGM members, they can join on the AGM link.
Good afternoon, Mohit.
Yeah, sir. Good afternoon, sir. Good afternoon, sir. Thank you so much, sir. Sir, I'm just calling a couple of people, sir, so that we can join. Yes, sir. Please, sir.
Instructions? Any instructions?
Yes, sir. Sir, I'm just requesting Dr. KK City and Dr. Tyagi to join. I'll just give instructions to all the residents, sir, and how will be the protocol that will be followed, sir.
No, to the judges?
Yes, sir. To the sir. Basically, sir, we have nine presentations, sir, and they will be given 6 minutes and plus 2 minutes.
I know that. My idea was that judges should rank them 1 to 9, and then you can total the.
Yes, sir. Yes, sir. In the order of the numbers that they have been given, sir, and all the judges are supposed to give separate numbers, and the results can be compiled and given to us, and they will be ranked from 1 to 9, sir. Absolutely perfect.
Yeah. Okay.
Yes, sir. Yes, sir.
Because judges should rank. The judges should not give marks. That is my point.
I will definitely do that, sir. I will do that, sir. I will just instruct. I'm just waiting, and that will be much better, sir. Ranking will be much better.
But if the rankings are not same, then how do you decide? Because each judge may have a different ranking. So you need to give marks and average them out.
No, they will total the rank, like 1, 2, 3, 4, 5. The total rank will come better because marking is little subjective. Suppose I given 1, 2, 3, 4, you have given them 2, 3, 1 thing. So they will total 2 plus 1. Each candidate will be totaled. So it will come out to the same.
So
it
you're
will be better
basically
than marks.
marking. You're basically, so you are giving 9 marks to somebody who is the least one or the best one?
Yeah, 1, 2, 3, 4, 5, 6. The least, the lowest, the first is the first. So we rank according to their first, second, third, fourth, and then we total that. So minimum will be the best.
I think we need to tell, because we are in the habit of giving high marks to the person who does better.
No, you rank them at the end of the thing. You can rank it. It is same.
Dr. Kothari, I missed part of it. Can you please repeat it?
Sir, welcome, sir. Actually, we have 9 presentations, sir, for the first award, which is the Sujoy B. Roy Award, and the only thing is, sir, that it's amongst the judges to decide the protocol that is to be followed in ranking and deciding who is the winner for this particular session, sir.
Okay.
And the presentation pattern remains the same, sir. It will be 6 minutes plus 2 minutes for the same. Yes, sir.
Right.
So as
what is the marking like?
Sir?
Marking?
So that is your protocol, sir. You can decide because it's an online one. So we have not given any particular circulator, but it can be decided depending on the ideas, the methodologies, and the results, and the how they have, and the clinical utility of the same. It can be decided by the respected judges, sir.
I think in spite of dividing into various subsets, we give a total assessment.
That will be much better and much more comfortable and easier, sir.
Right.
Sir. And in the end, we can total and give the final rank, sir, that you can give, and we'll announce the result.
We give marks out of 100?
Yes, sir. That will be easier for everybody to compile, sir. Yes, sir.
Okay.
I think I will request Mohit, Dr. Khalilullah can call all of them so that there is uniformity. We don't, Dr. Khalilullah
that will be perfect, sir.
Call all of them.
All right.
Sir, do you have the list of all the presenters?
Yes, I have.
That will be great, sir. Only one more is added. I'll add that to you. That will be last, sir. So please, 1, 2, 3, 4 करके आप ही बुला लीजिएगा, sir.
All right.
Just we have 1 more minute to go. I hope Dr. Tyagi joins that time.
Questions, Mohit, are the judges supposed to ask questions?
Yes.
Yes, sir. 2 minutes of interactions is only
2
for
minutes.
that.
Okay. Right.
Yes, sir.
So how?
Yes, sir.
I hope all the judges are there.
Sir, we are waiting for Dr. Tyagi. Actually, he's not picking up. He was there. I don't know.
Dr. Sethi?
Dr. Sethi is...
Afternoon, sir. I'm here.
Oh, wonderful. Afternoon,
Sir, we are also trying to connect to Dr. Sethi, but unfortunately his number is not reachable.
So we are at the moment only 3. Dr. Tyagi is coming to come and join us.
I should be...
Okay, we still have a minute or so.
Yes, sir. Just a minute to go, sir.
Photo.
Dr. Khalilullah, sir, you are going to stop them after 6 minutes, I presume. The unpleasant task.
I will do that. I will do that.
There is a timekeeper.
Yes, Anurag. Yes, sir.
As soon as the talk will start, we will have a time of 6 minutes. So you can have. Yeah.
6 plus and the question with 2 minutes. Okay.
Is there a
Yes,
buzzer?
So timekeeper.
We'll have a side panel with the timer.
Buzzer at a timer is there after 6 minutes?
Let the timekeeper do that.
Some buzzer is there?
No, sir, the buzzer is not there, but you can see the time overall. In case you want, I can inform you as soon as the 6 minutes comes out.
No, the speaker should know that the time is over or 1 minute before left, something like that. Otherwise, how will we break?
Sir, you would be able to see from the panel itself. So the timer would already be there.
Okay.
Okay. We'll follow the timer and tell the speaker a minute before. फोटो लाओ फोटो फोटो थी ना आ गई माँ
Hello.
There are 30 seconds to go. We'll start it.
Yes, sir. We can start right on time, sir. At the moment. For all the presenters, this is the picture of Dr. Sujoy B. Roy, and I strongly recommend. There is a beautiful article in one of the journals about the achievements, lives, and times of Professor Sujoy B. Roy. It's a great source of inspiration, and I will share it in the residents and the fellows group, and you will be pleased and amazed to see the persona and the quality of the work and the commitment that sir had displayed.
Okay, so let me invite all the participants in the very important award paper session by in the name of Professor Sujoy B. Roy. Dr. Roy was the doyen of Indian cardiology. He was the first to systematically set up a cath lab and built up the entire academics of cardiology. The word DM did not exist before him. There was nothing like before MD. So he reversed the term and made a DM for DM cardiology. So that the historic event in which the DM was started, the first to start was in all these medical sciences. And I had the privilege to be the third batch of the DMs under Professor Sujoy B. Roy. I have great memories of his great traineeship, teachership, philosophy, and the kind of remarkable skill he had in performing cardiac cath and hemodynamic studies. A few things which possibly most of you do not know, I must highlight. Number one, he had done first 100 volunteers right and transseptal left heart studies to establish the norms for hemodynamics in India, which never existed before. That is number one. Number two, he was the first one to carry out high altitude sickness and high altitude pulmonary studies in Jawans who were in lay were brought down to the lower altitude. And as to part of those studies, those they're doing pulmonary blood volume and so on, it was published in Nature. The third was that he had an American wife, he had 2 dogs, he had no children. He could not afford a car. He used to travel by taxi. And lastly, I had the privilege of playing 3 games of competitive badminton with him every day. That was a rare privilege for me to be with him. And I must say, whatever we have in India today is all the fruit of his training and teaching. He taught some of us, we taught of hundreds of them, and hundreds of you taught the other hundreds of them, and thus spread the tsunami of Indian cardiology. I have the greatest pleasure I'm having with me Dr. Kothari, Dr. Anita Saxena, Dr. Sanjay Tyagi, and especially Dr. Anita Saxena. I must say that I had the pleasure to see her occupying the same chair as she is my student. When I'm a student, I occupied the same chair which occupied my teacher. This is the biggest honor, privilege for me, and also the tribute to Professor Csi Roy for his vision and his contributions to the field of cardiology. There are a total of 9 candidates who will present their paper. The time given to them is 6 minutes, and after 5 minutes, they will be given an indication, and the 2 minutes of discussion to be asked, the question to be asked by the judges. Any preamble to be given by Dr. Anita Saxena, Dr. Kothari, Dr. Tyagi before I start the session?
No, sir. Thank you. I think we just start.
Okay. Then I invite the first presentation by Faraz Ahmad Farooqi, efficacy and safety of oral flecainide in acute conversion of atrial fibrillation, followed by short-term maintenance therapy in patients who have undergone mitral valve replacement or repair. Dr. Faraz, please.
Good afternoon, everyone. I'll be presenting my DM dissertation titled Efficacy and Safety of Oral Flecainide in the Acute Conversion of Atrial Fibrillation, followed by short-term maintenance therapy in patients who have undergone mitral valve replacement or repair. Now, atrial fibrillation is present in a substantial number of patients who are referred for mitral valve surgery. And although it's long-standing atrial fibrillation in patients with rheumatic heart disease, it still carries a lot, and it's difficult to revert it to sinus rhythm, but it still carries a lot of disadvantages in the sense that it increases the risk of prosthetic heart valve thrombosis, predisposes to congestive heart failure, and leads to a worse quality of life in these patients. Now, post mitral valve surgery, there are certain changes in the left atrium, specifically a decrease in the left atrial pressure and also an improvement in the left ventricular deformation, which helps in reverse remodeling of the left atrium. So at this point, if there are attempts made to convert the atrial fibrillation to sinus rhythm, there may be a durable persistence of sinus rhythm in these patients. So just a brief slide about the drug that we used in our trial. Flecainide, it's a class 1C drug. It causes use-dependent blockage of the voltage-gated sodium channels, prolongs atrial refractoriness, decreases excitability, and also decreases the sarcoplasmic reticulum calcium release. So this study was performed in patients who are older than 18 years of age, who had undergone a mitral valve surgery 6 weeks to 6 months prior to their inclusion in the study. And these were patients with chronic atrial fibrillation more than 1 year, and they provided written informed consent. We had excluded patients who had a left atrial size of more than 60 millimeters, left ventricular ejection fraction of less than 40%, and a baseline heart rate of less than 60 beats per minute. This was a randomized controlled trial, and we achieved allocation concealment by sequentially numbered opaque envelopes. And I must elaborate that the study drugs were sponsored by a pharmaceutical company. Now, the study participants were divided into 2 arms. The first arm was the flecainide arm, in which patients were given a weight-based dose of flecainide. And in case they underwent successful conversion to sinus rhythm, they were given a maintenance dose of oral flecainide, which for 6 weeks. And in case patients failed to convert to sinus rhythm following the oral dose, they were given DC cardioversion to convert them to sinus rhythm. The other arm straight away went for DC cardioversion, and following successful conversion, these patients were placed on sustained delivery diltiazem. Patients were followed up at 1 week, 3 months, and 6 months, and our primary outcome was the maintenance of sinus rhythm at 6 months. The safety outcome was the occurrence of proarrhythmic events in these patients. So coming to the study flow, we assessed about 106 patients for eligibility. 83 patients were excluded due to various reasons. Finally, 23 patients were randomized, with 10 patients being randomized into the flecainide arm and 13 patients being randomized into the DC cardioversion arm. Coming to the baseline characteristics, the mean age of our patients was about 40, not significantly different between the two groups. They were predominantly female patients, and most of them had mitral stenosis. The mean LV ejection fraction was about more than 50% in both the groups, and the mean LA size was about 47 and 48 millimeters in both the groups. And these patients had atrial fibrillation. Both of these groups had atrial fibrillation lasting for more than a year, slightly longer in the DC cardioversion arm, but not statistically significant. Following the bolus dose of flecainide, the spontaneous conversion to AF occurred in only one patient. Most of these patients subsequently underwent DC cardioversion, and at discharge, we were able to achieve sinus rhythm in 90% of patients in the flecainide arm versus 69% patients in the DC cardioversion arm, although this figure was not significantly different. At 6 months, the primary outcome, sinus rhythm at 6 months, which was our primary outcome, was present in 80% of patients in the flecainide arm versus only 46% patients in the DC cardioversion arm. Again, this figure was not statistically significant. When we only followed patients who had achieved sinus rhythm at initial discharge, again, the number of patients at maintaining sinus rhythm at the end of 6 months were numerically more in the flecainide arm. Again, this number was not statistically significant. Coming to the safety outcomes, there were no episodes of ventricular proarrhythmia or atrial flutter in patients in the flecainide arm. The mean QRS duration in the flecainide arm at baseline was 72 milliseconds, and after the bolus was about 81 milliseconds. And none of the patients had an increase in QRS duration by more than 25% from the baseline value. On follow-up, one patient from the DC cardioversion arm presented with congestive heart failure due to prosthetic heart valve thrombosis, and the rhythm at presentation was atrial fibrillation with fast ventricular rate. There were a few limitations to our study. It was a single center study with a small number of patients with a short duration follow-up, and these results cannot necessarily be applied to older patients, particularly those with concomitant coronary artery disease, because flecainide has been shown to increase mortality in this group of patients in the CAST trial, which was published in the 90s. Coming to the conclusions of my study, ours was the first study to evaluate the role of oral flecainide in patients with chronic AF following mitral valve surgery. A single bolus dose of oral flecainide is rarely effective in cardioversion of chronic AF following mitral valve surgery. And following cardioversion, a short-term maintenance therapy with flecainide did not increase the persistence of sinus rhythm at 6 months in these patients. And flecainide was found to be safe in post-mitral valve surgery patients without significant ventricular dysfunction. Thank you.
The number of patients are only 23, and the two groups are 10 and 13 or something. It's very small number.
Yes,
to derive any conclusion from the study,
yes,
it's very difficult. It's only given a direction as to what can happen.
Yes, sir.
What the relationship with the size of the LA and conversion to sinus rhythm with flecainide or DC shock?
We did not compare the two groups in that way, but in the patients who had achieved sinus rhythm, they tended to have a lower left atrial size and a shorter duration of AF. So these two factors were associated with achievement of sinus rhythm.
Can you thus recommend that patients who have small left atrial size can be benefited better with flecainide than DC cardioversion? Can you conclude that?
Flecainide, no, we cannot conclude that because flecainide did not increase the persistence of sinus rhythm. But although there were numerically more patients who maintained sinus rhythm, maybe a larger study will help bring out the difference in a more clear fashion.
Thank you. Dr. Anita Saxena.
No, sir, thank you. He's been my student. Thank you.
Oh, it doesn't matter. You're a judge now.
No, I have no. Thank you.
Faraz,
yeah.
So Faraz, what was the commonest cause for exclusion? You have excluded very high numbers. What is the commonest reason for exclusion?
Sir, one of the most common cause of exclusion was the left atrial size, because most of my patients were patients with mitral stenosis, and a lot of them had left atrial sizes more than 60
So
millimeters.
do you think if you can titrate the results with the atrial, as Professor Khalilullah was telling, suppose you take that into consideration, you would reach some conclusion, because otherwise the numbers are very small.
Yes, sir. Maybe if you would have taken still smaller left atrial sizes, then maybe we could have brought out the difference more. The only attempt was to, although it's not difficult to achieve sinus rhythm.
So did you calculate your power of the study with these numbers? Have you any idea what is the power of the study
No,
could come to?
we did not calculate the power of the study because the sample size chosen was a sample size of convenience of 20 in each arm. But because of slow enrollment, it was a DM dissertation. By the time I had to submit, I was only able to recruit these many patients. And none of the previous studies had used flecainide. The only previous studies that in the literature review that we had come across were with amiodarone.
So do you now suggest that flecainide should be given?
So flecainide may be useful in patients who do not have a very long duration, because one disadvantage with amiodarone is that it has an interaction with warfarin, which is often used in these patients. So in that way, it has an advantage. Plus, pro-arrhythmic events, although there's been a shadow over flecainide because of the CAST trial, but this is a completely distinct group. And pro-arrhythmic events are very rare, less than 1%, and we did not come across any of them.
In fact, many of these patients with mitral valve replacement are continuously on anticoagulation.
Yes.
That's also a recommendation then.
Yes, anticoagulation was given. Attainment of sinus rhythm did not necessarily lead to discontinuation of anticoagulation, but it's just that they had a better quality of life if they would attain sinus rhythm.
No, with people with mitral valve replacement, you should continue anticoagulation lifelong, no?
Yes.
So such patients may be flecainide shade better than amiodarone.
Yes, correct.
Okay, thank you for us.
Thank you.
Give a big hand, please. The next paper is by Jitish Jain, Exercise Physiology in Isolated Diastolic Dysfunction. Jitish, please.
Sir, is my screen visible, sir?
Yes, yes.
Yeah, please go ahead.
Good afternoon, everyone. The topic of my presentation is exercise physiology in isolated diastolic dysfunction. Now, dyspnea on exertion is a dyspnea on exertion is a frequent presenting complaint in the clinical practice. Information from the tests which are performed in the resting state are not sufficient to assess symptoms which occur with exertion. The cardiopulmonary exercise testing provides the assessment of pulmonary cardiovascular, hematopoietic, neuropsychological, and skeletal muscle systems. Cardiopulmonary exercise testing enables accurate determination of the physiological reserves of the heart and the lungs during exercise. The LV diastolic dysfunction is associated with reduced exercise capacity. The peak oxygen consumption is achieved from cardiopulmonary exercise testing is helpful in making decisions regarding medical management and interventions. And anaerobic threshold is defined as the intensity of exercise at which the energy production shifts from aerobic metabolism to metabolism that combines anaerobic and aerobic patterns. The aim of our study was to compare peak oxygen consumption in dyspneic patients with and without isolated diastolic dysfunction, to compare anaerobic threshold in dyspneic patients with and without isolated diastolic dysfunction. In our study, the study was done from January 2018 to June 2019. It was a cross-sectional observational study. The patients with diastolic dysfunction were taken as cases, and those with normal diastolic function were taken as controls. We had included the patients who had normal echocardiographic findings. We had excluded those who had any cardiovascular abnormality like coronary disease, valvular disease, infiltrative, pericardial, pulmonary, or renal disease. We had taken patients who had normal baseline CBC, serum chemistries, and that did not provide any explanation for the complaints of the patients. We had initially selected 166 patients who had presented in the OPD with the dyspnea. We excluded patients who had anemia or any thyroid disorders, any chronic kidney disease, who had abnormal pulmonary function testing. After that, we divided the patients based on our echocardiographic study, based on 2D echocardiogram, into patients with diastolic dysfunction and without diastolic dysfunction. And we excluded patients who had indeterminate anaerobic threshold. And finally, after the patients, rest of the patients, after those with abnormal ECG who had been found to have normal ECG on exercise testing, we were left with 40 patients in each group. In our observation, we found that in the study, in the cases, 28 patients had grade 1 diastolic dysfunctions, 12 patients had grade 2 diastolic dysfunction. None of the patients fulfilled the Framingham criteria for heart failure. The dyspnea was characterized on the basis of MMRC classification, and our majority of the patients had grade 1, grade 0 or grade 1 dyspnea. None of the patients had higher grades of dyspnea. The average age group were around 46 years, 35 to 37% were female. The BMI was around 27. Only 8 patients and in the cases and 5 patients in the control had diabetes mellitus. The mean hemoglobin was around 14 and the creatinine clearance was of both the groups was within normal limits. The patients had all of the patients in the cases had a significantly lower early diastolic filling velocity values, because majority of our patients were grade 1 diastolic dysfunction, and there was most of the parameters of diastolic dysfunction were significant difference between the diastolic dysfunction parameters in the two groups. All of the patients had normal ejection fraction. There was no difference with regard to the pulmonary function test. As far as results are concerned, there was a significantly lower peak oxygen consumption value in the cases. That is, it was 23.72 ml per kg per minute, and there was significantly lower anaerobic threshold in the cases. The ventilatory efficacy was significantly higher in the cases group. The respiratory exchange ratio, there was no difference between the respiratory exchange ratio of the group, which justifies that the majority of the patients had been evaluated with sufficient exercise. Among our results, we found that we had also calculated the value of the peak oxygen consumption to determine the diastolic dysfunction. We had come up with a value of 27.35 ml per kg per minute, which had a sensitivity of 77% and specificity of 55%. The anaerobic threshold to determine the presence of diastolic dysfunction came out to be 22.65 ml per kg per minute. Similarly, for the determination of diastolic dysfunction, minute efficacy value came out to be 28.49 ml per kg per minute. As far as the Pearson correlation was determined, we found that E by E dash prime, whether it was septal of the septal region or the lateral region or average, it found to have a correlation with the diastolic dysfunction. Among the controls, there was no significant correlation of any of the echocardiographic values as far as the correlation between the correlation with the ventilatory efficacy was seen. So in conclusion, we found that the exercise parameters are significantly lower in patients with diastolic dysfunction in comparison to patients without diastolic dysfunction. Deconditioning was the primary reason of the dyspnea in our study. And because it was a single cross-section, it was a cross-sectional study, we need a long-term follow-up to determine whether these exercise parameters lead to the long-term development of heart failure in patients with diastolic dysfunction or not. The main study limitation was that we had strictly excluded even the patients with common comorbidities like hypertension and anemia, which may lead to difficulty in generalizability of our findings. The other important peripheral factors like the skeletal muscle mass, which also correlate with the exercise capacity, need to be investigated in future studies. And another important drawback was that we had included only 40 patients in each group, so the sample size was quite small.
Thank you, Jitesh, for an excellent presentation. I have a few questions to ask. Number one, you said you have not taken class 3 and class 4 patients in the study. That obviously is the ethical restriction, no? you could not subject them to the exercise and to continue the study. Number two, did you expect the result contrary to what you got? Any learning from the study? Any positive take-home message?
Sir, the most important point was that even in patients who had no other finding, like who come with unexplained dyspnea in our day-to-day practice, and those who come to have come to have diastolic dysfunction while doing echocardiography. So this may provide partial explanation for the symptoms, even in the absence of even in the absence of presence of heart failure.
Okay, in fact, there is a plethora of factors responsible for the fitness of the person on exercise, both with or without diastolic dysfunction.
Yes.
And those variants very difficult to compare in a small subset of patients as yours. No, I think it's a generalized study. Nothing very specific has come out of it. No.
Sir, but it may provide partially the explanation for the symptoms of our patients, which have no other explanation, like after excluding all the commonly found diseases.
It is any therapeutic directions?
Sir, therapeutic directions, because as we know that those who have patients with isolated diastolic dysfunction, there is no current therapy available. So this will require, if there are future.
It doesn't help. Okay, thank you. So Sanita Saxena, Dr.
Yeah, Jitesh, thank you very much. I wanted to know, from where did you recruit these patients? Are these patients coming to cardiology OPD or general medicine OPD?
No, ma'am, to our OPDs in the cardiology OPD.
Cardiology. So they're coming with dyspnea and you've not been able to find any obvious cause. I believe those are the patients.
Yes, ma'am.
So you recruited 40 and you also had 40 controls.
Yes.
But can you tell me the total number of cases where there was no diastolic dysfunction was found amongst the patients who presented with dyspnea?
Ma'am, in my patients, approximately 10 patients had no diastolic dysfunction. So in them, the cause was could not be determined.
Only 10.
Yes, ma'am.
Okay. So you think that because they did not have any diastolic dysfunction, so
Yes,
that was not the cause, some other cause which you have not been able to pinpoint?
Ma'am, majority of the patients in my studies which I came across who had come, they had an average, they were also had a higher BMI and they were in the age group of more than 45 years. And so I believe this may have been the reason to some extent.
Okay, thank you.
Yes.
Half of your patients are having grade 0 dyspnea. Grade 0 dyspnea is dyspnea on strenuous exertion.
Yes, sir. Yes, sir.
So everybody will get dyspnea on strenuous exertion. How do you think they are patients?
Sir, actually, it is quite right what you have just said, but majority of these patients just came with complaints of dyspnea only. So when they were evaluated and their history was taken in detail, and what level of exertion produced their dyspnea, so it was determined that they had a very low, they had dyspnea.
You have put them on grade 0. You see, grade 0 is almost normal. And the second conclusion you drew was that deconditioning was the cause. From your study, how can you assert that conclusion?
Sir, because like the various parameters which we have determined, peak oxygen consumption, anaerobic threshold, the rate, there is some studies have said that the rate of rise and their level of exertion which they are able to achieve was not sufficient to place them in the other categories of cardiovascular or cardiac disease or in the pulmonary disorders.
Which means the cutoffs that you found finally, how do they compare to normals? These
Sir,
both cutoffs are within the normal limits?
Yes,
still?
sir. Yes, sir. They are in the normal ranges in the majority of the patient. The average results are in the normal range.
So therefore, they are part of the normals. Even we have not been able to distinguish between normals and these.
Yes, sir.
Isn't it?
Yes, sir. Yes, sir. Because they come in the normal range. So to to label them as a disease state, it will not be a right thing to say. But
so within the normal scheme of things, we cannot make a cutout between with or without diastolic dysfunction. The parameters you have taken are 3 parameters. They may have early diastolic dysfunction by other parameters.
Yes, sir. Yes, sir. They may have because the classification, we did not use the latest classification of diastolic dysfunction in these patients, which came out in 2016. So if by that definition, they may not be exactly in, they may be not in the same level, in the same criteria. They may not fit in the same criteria.
Okay.
Yes.
Thank you, Jitesh. We go on to the third speaker now, Dr. Kaka Saheb Hemant Bhosle, role of re-hospitalization in 60 days of discharge and its determinants in patients with heart failure with a reduced ejection fraction, obviously. Dr. Bhosle, please.
Yes, sir. Am I audible, sir?
Yes.
Yes, sir. Good afternoon, all respected teacher and my colleagues. My research topic was rate and determinants of re-hospitalization in patients with heart failure and reduced ejection fraction in 60 days of discharge. I am thankful to Dr. Neeraj Pandit and Dr. Ranjit Kumar Nath to complete my study. So worldwide, there are 26 million patients has been affected by heart failure, out of which 5.4 million patients are present in India, according to the Inter-CHF study. So not only the prevalence is high, there is a very high morbidity and mortality associated with the heart failure. Around 23% patients expired within 1 year of diagnosis. So it has almost as equal as advanced cancer mortality. And they also have a very high rehospitalization rate, that is 20 to 30% within 60 days of discharge. So identifying these predictors of worse outcome will help to determine optimal post-discharge plan. So the previous study has been, most of the study has been conducted in the Western population, but the no Indian study has conducted in a comprehensive manner. So we planned this study. So we included the patients who are having age more than 18 years. Cardiomegaly, pleural effusion, and at least 2 of the following, that is dyspnea, signs of volume overload, jugular venous distension, LVS3 gallop, and heart rate more than 100 beats per minute. We have excluded the patients who are having acute myocardial infarction at presentation. So we defined re-hospitalization as any hospitalization or emergency department visit longer than 24 hours. All patients received guideline-directed medical treatment and followed up in heart failure clinic as per departmental protocol. So altogether, 103 patients were included in our study who are following this inclusion and exclusion criteria, out of which 7 patients got expired during index hospitalization only, and 3 patients were lost to follow. So all total 93 patients we have evaluated over a period of 60 days. And all these 93 patients we divided them into those who are re-hospitalized and those who are not re-hospitalized. So coming to the results, the mean age of our study population was 55.8 years. It's younger as compared to the Western population that we have found. And also there were 26% female. So majority of the populations were the male. In our study, 53% patients had a history of CAD, 46% had a history of diabetes, 38% were hypertensive, 19% were CKD, 7% were COPD, and 3% had a history of CVA. So we altogether we studied 23 clinical predictors and 9 biochemical predictors of rehospitalization. So over a period of 60 days, 34 patients got rehospitalized, that is around 37%. Then we have compared these all biochemical and clinical parameters between these 2 groups, those who are re-hospitalized and those who are not re-hospitalized. So among them, the re-hospitalized patients had a higher percentage of patients with higher NYHA class at discharge, that is NYHA class 3. Also, they had a higher length of index hospital stay, that is more than 7 days. They also have a higher proportion of patients with the chronic kidney disease status. Again, they also had a lower hemoglobin as compared to not hospitalized, that is 10.2 gram per deciliter compared to the 11.3. They also have a higher value of blood urea level, serum creatinine level. They also have a higher value of BNP level at admission, BNP level at discharge, troponin at admission, and troponin at discharge. Also, we compared on the chest X-ray as well the grading of pulmonary venous hypertension, in which we found that those who are re-hospitalized have a higher grade of pulmonary venous hypertension. They also have a lower EF, lower LV ejection fraction compared to those who are not re-hospitalized. That is 26.5% versus 30.4%. They also have a higher grade of MR. Regarding the post-discharge treatment status, those who are re-hospitalized has a lower use of aldosterone antagonist and angiotensin receptor and epilysine inhibitor, but they have a higher use of digoxin and implanted cardioverter defibrillator. So these were the baseline comparison of character between two groups. So to know whether they are associated with re-hospitalization independently, we performed an logistic regression analysis, in which we found 4 factors which were independently associated with the re-hospitalization. These were having a chronic kidney disease, having longer length of stay at index hospitalization, having a lower LV ejection fraction, and lower hemoglobin levels. So highest odds of getting re-hospitalized is of chronic kidney disease, followed by longer length of stay, followed by lower LV ejection fraction and lower hemoglobin level. So coming to the discussion, overall, we found a very high rate of re-hospitalization, that is 37% within 60 days of discharge, as compared to the Western studies like Chin et al. We found 32%. For the re-hospitalization, the first and foremost factor responsible was CKD. It may be due to the lack of effective therapeutic options available, or possible underutilization of current therapies due to apprehensions surrounding side effects. Second factor was longer length of index hospital stay, that is more than 7 days, which may be due to more decompensated status at admission, which took more time to recover. Third was the lower LV ejection fraction. It might be possible that it's a natural history of disease and it's a disease progression which is causing more re-hospitalization. The fourth one was lower hemoglobin level. Yes, it is likely related to the hemodilution, secondary to the volume overload, or maybe related to the malabsorption due to bowel congestion, and also maybe due to the higher number of associated chronic diseases. Using these 4 predictors, our model performed better for risk prediction for the re-hospitalization as compared to the clinical and complex model used by the Tung et al. With the C statistic value of 0.9 versus their C stat value of 0.78. So all patients hospitalized for heart failure should be re-stratified as high or low risk of re-hospitalization. And those patients who are at highest risk of re-hospitalization should be given highest intensity of multidisciplinary report. Yes, there were some limitations. Our study sample size was small. It was an observational study and this prone for the observer bias. All predictors were not included in the study, as there were some psychosocial and economic predictors were not included. Some of the biochemical predictors like cystatin C and galectin-3 was not included. So to conclude, yes, there is patients with heart failure and reduced ejection fraction continues to have a higher re-hospitalization rate and mortality at 60 days. By giving special attention to the patient with chronic kidney disease, those who are requiring longer index hospital stay, and those who has a lower ejection fraction might reduce re-hospitalization rate. Especially treating reversible predictors of re-hospitalization, like lower hemoglobin, can reduce re-hospitalization rate, as it has been seen in Optime CHF study that every reduction in every 1 gram per deciliter reduction in HB is associated with increase in re-hospitalization rate by 10%. And some of the recent studies like Confirm HF and Effect HF has been shown that by giving IV iron infusion, we can reduce the re-hospitalization, although not mortality, but we can reduce the re-hospitalization. So, and to say further research is needed to identify the targets to improve survival among patients with the heart failure. Thank you, sir.
Thank you, Dr. Bhonsle. I should appreciate your methodology, the method of analysis, and conclusion in the study. But did the study add anything to knowledge? Or we expected all this to happen in patients with reduced ejection fraction with CKD and low hemoglobin? Does it add to our knowledge? I appreciate your effort for research. I agree with that. But any addition to our knowledge, present knowledge?
First, like such a comprehensive study was not conducted before, and second thing, even we have knowledge, like there are still lot many patients which are undercorrected, like those who are having low HB, still like lot many prescriptions, and they are not corrected and not taken care. The study might give evidence that yes, we can look after it.
Okay. Dr. Rita Saxena.
Yeah, I just have two questions. You had analyzed so many variables to decide, which one is likely to predict the rehospitalization. Did you look for the underlying cause of heart failure as a predictor? And the second part is, did you check for the compliance of these patients, whether they were taking their medicines or not properly, especially those who got rehospitalized?
Yes, ma'am. For the rehospitalization, most common cause was cardiac only, and the first and foremost cause was like non-compliance to the treatment. And followed by there were some cases of like arrhythmias and ischemia, ma'am, for the rehospitalization. And the second causes were like respiratory and renal causes. Yes, ma'am. I have not included in this presentation, but yeah, we have seen the causes, like we have studied the causes of rehospitalization.
Because I think in normal routine admissions, non-compliance to medicine is a very strong reason for rehospitalization in our setup, which is probably not maybe the case in Western population. So that should have been studied.
Yes, ma'am. That factor we have not statistically evaluated, just calculated.
So Sanjay Tyagi. Any questions for Sanjay Tyagi?
I have a question, sir. Dr. Bhosle, is important question you raised, but your conclusion must be based on your study. In your conclusion, you say treating anemia, treating iron, giving iron may be useful. That is not based on your study. You cannot conclude that statement from this study. That is a very important point. And second is, if you read literature, the literature is replete with the idea of congestion. The commonest cause of rehospitalization is congestion. You did not check weight in your variables. One thing which is simple could have been done is the weight gain. See, in your clinical variables, I did not see any change in weight, which is one of the most important factor for congestion.
Sure, sir. Weight.
Right. And because your study cannot say that anemia we should treat by iron, because it may well be possible that even if you treat anemia, rehospitalization is not different.
Yeah, they were asked, yes, sir, like it require another study whether treating it will cause, but what we have evidence is like treating it might reduce the rehospitalization, but what we found that in population.
As Dr. Khalilullah says, we know sick patient will get rehospitalized, so we have not really learned other than the fact that 37% get readmitted within 2 months. Any mortality in these 2 months?
Yes, sir. 5 patients were expired. Like out of this 37%, that is out of 34 patients, 5 patients were expired. And in the index hospitalization, 7 were expired, sir. So there was 5.3% mortality as well.
Okay.
Within 60 days.
So Sanjay Tyagi? No. Okay. Thank you, Dr. Bhosle. Appreciate your work.
Thank you, sir.
I go on to the next paper by Dr. Arvind Balaji. Avibradine versus amiodarone for the treatment of postoperative junctional ectopic tachycardia following cardiac surgery in children, a randomized controlled non-inferiority trial. Dr. Arvind Balaji, please.
Good afternoon. My slides are visible?
Yes, sir, visual.
Good afternoon. I would be presenting the results of my DM thesis, which is ivabradine versus amiodarone in the management of postoperative junctional ectopic tachycardia following cardiac surgery. This was a randomized controlled non-inferiority trial carried out at All India Institute of Medical Sciences. JET is the most common postoperative arrhythmia occurring in children after cardiac surgery. The reported incidence varies between 0.01 to 10.2% across various cardiac units. Amiodarone has been the preferred drug in the management of JET, but it has some serious side effects. Recently, there were reports demonstrating the utility of ivabradine in these patients. So, we hypothesized that ivabradine is not inferior to amiodarone in converting postoperative JET to sinus rhythm in these patients. We included patients less than 18 years of age who developed JET after elective open heart surgeries. Jet was diagnosed as per the ECG criteria showing AV dissociation with a ventricular rate greater than atrial rate, and the ventricular rate should be more than 95th percentile for age. We excluded patients with postoperative arrhythmia, severe sepsis, multi-organ dysfunction, and those who underwent surgery as a part of single ventricle palliation and emergency surgeries. This was an open-label parallel design RCT with a non-inferiority trial design performed after appropriate ethics committee approval and CTRA registration. The participants were randomized to either amiodarone or ivabradine in a 1:1 ratio based on computer-generated block randomization sequences. We used variable block sizes. Allocation was concealed by the use of sequentially numbered opaque sealed envelopes. Sample size estimation was based on a previous study by Saul et al., who observed the efficacy of amiodarone for this indication to be around 83%. Assuming the same with ivabradine, we required 44 patients in each arm to show a non-inferiority margin of 20% with a power of 80% and two-sided alpha of 5%. We did not expect any attrition in the study. So those who were randomized to the amiodarone arm were started on IV infusion of amiodarone without any bolus at the doses as shown in the slide. Those in the ivabradine arm were started on oral ivabradine at 0.2 mg per kg per day in 2 divided doses. After 24 hours of the first dose, if sinus rhythm was not achieved, these patients either go on to receive an escalated dose of ivabradine, or they might be switched to amiodarone, or they would be continued at the same dose. This decision was left to the discretion of the primary treating cardiac intensivist, who decided based on the hemodynamic status and the clinical status of the patient. All patients were monitored in the cardiac ICU in a standard fashion. The primary outcome of interest in our study was conversion to normal sinus rhythm. We also were interested on other secondary outcomes such as time taken to achieve sinus rhythm, ventricular rate control, whether it is achieved or not, and time taken to achieve this ventricular rate control. Ventricular rate control where age-wise cutoffs were as shown in the table. So we had randomized 94 patients, 46 to the amiodarone arm and 48 to the ivabradine arm, and we analyzed all the patients who were randomized to the arm, thereby performing an intention to treat analysis. As you can see, many of the baseline characters such as age, height, weight, cardiopulmonary bypass time, aortic cross-clamp time, numbers in whom right ventriculotomy was performed, and maximum heart rate during arrhythmia were equally balanced between both the groups, showing the adequacy of randomization. And tetralogy of Fallot was the most common underlying cardiac defect in our patients who got operated, followed by VSD and double chambered right ventricle. The other cardiac diagnoses are as shown in the slide. So coming to the primary outcome, which was conversion to sinus rhythm, it was seen in 43 out of the 46 patients who received amiodarone, whereas in ivabradine arm, it was seen in 46 of the 48 patients who received ivabradine. So the mean difference was 2.3%. The point estimate was 2.3%, and the confidence interval was ranging between -6.7 to 11.5%. As you can see, the lower bound of confidence interval is very well within the assumed non-inferiority margin of 20%. We also performed a post-hoc protocol analysis, which also showed similar kind of result, thereby meaning that it has demonstrated that ivabradine is in fact non-inferior to amiodarone in the management of postoperative jet. Coming to the secondary outcomes, the first one, which was time taken to achieve the sinus rhythm, was not different between amiodarone or ivabradine arms. The secondary outcome, which was ventricular rate control, was achieved in all the patients in both the treatment arms, thereby having no difference. However, the time taken to achieve this ventricular rate control was faster with the use of amiodarone. The median duration was 1 hour lesser in the amiodarone arm. And we know that the inotrope dosages influence the outcome of the arrhythmia. So we try to quantify the inotrope requirement in all our patients. We did this by the use of a composite score called the vasoactive inotropic score. We calculated the score at 3 discrete time points during the study in all our patients. That is when the arrhythmia started, when heart rate was controlled, and when sinus rhythm was established. And these scores were comparable in both the treatment arms in all our patients. Also, we checked whether the trend of the scores were any different between the two groups, which was also not the case. Again, showing that this potential confounder has been equally distributed between both arms of this randomized control trial. Adverse events, we did not observe any significant adverse event which we could certainly attribute to the drug per se, except for this one patient in the amiodarone arm who developed significant transaminitis, following which the drug required to be stopped and was shifted to ivabradine arm, and hence subsequently he went into sinus rhythm. So as of now, the currently published literature, the largest series is a retrospective case series from a center in southern India, where only a report of 8 patients, their experience of 8 patients has been published. All these patients had achieved rate control followed by sinus rhythm, similar to all the patients in our study. They also did not observe any major adverse events. One patient in their study had a recurrence of arrhythmia. In our study, 6 patients had recurrences, but it did not result in any significant prolongation of duration of ICU stay or hospital stay. Thereby, this makes our study the largest and the first contemporary RCT in this subject. A novel indication for ivabradine has been systematically demonstrated by this study. There are limitations. The open label study design could have led to some amount of bias which could have crept in. And we had compared an oral drug with the IV formulation. That was because the IV ivabradine is currently not available in the country due to regulatory restrictions. So to conclude, ivabradine is not inferior to amiodarone in conversion of jet to sinus rhythm. Ivabradine, though it was associated with a slower ventricular rate control, it had no difference in time taken to sinus rhythm conversion. Doses up to 0.4 milligram per kg per day were tolerated without any major adverse effects. Hence, ivabradine may be considered as an alternative monotherapy to amiodarone in the management of postoperative jet.
Thank you, Dr. Arvind Balaji.
Thank you, sir.
I have some basic question to ask you. How could you demonstrate AV dissociation with this fast tachycardia? They are narrow QRS complex?
Yes, sir. It was a narrow QRS complex tachycardia.
You could demonstrate AV dissociation.
Yes, sir. AV dissociation, it could be demonstrated, or in case if there was a 1:1 retrograde AV conduction, you could also see a presence of retrograde P waves in this arrhythmia.
Why could it not be a re-entry tachycardia?
Sir,
PSVT, standard PSVT.
In a postoperative setting, the most common arrhythmia observed is the junctional ectopic tachycardia, and AV NRT would be associated with the AV association. In case, when in doubt, we also performed atrial lead electrograms using the temporary pacing wires, which would better delineate the P waves, and hence by which also we would be able to differentiate between these two arrhythmias.
Do you have any tracing to show it to us?
Sir?
Any tracing to show?
Sir, this was the tracing which was in our patient.
Can you show that?
Yes, sir. I will.
Okay. The other thing is that in post-operative arrhythmia,
yes, sir,
quite often pharmacological intervention can lead to hemodynamic derangement, especially with amiodarone. Some people take resort to rapid atrial pacing.
Yes, sir.
Terminate short-term atrial pacing to terminate the arrhythmia. Yes. And that's magic to these patients because the re-entry is broken or it is overdriven by the rapid atrial pacing. You are aware of that?
Yes, sir. Rapid. It is also one of the methods for managing junctional tachycardia events.
Right. Professor Tyagi, any questions from you? Is Dr. Tyagi here? No, he's not here.
Sir, he's there, but his mic is not working.
Oh, I'm sorry. He's not able to participate. Okay. Dr. Anita Saxena, please.
No, sir, I have no question. Thank you.
What about Dr. Kothari?
Biased my own study, so I have to excuse.
You see, this is the amazing quality of Dr. Roy, that he used to criticize his own students.
Yes.
You know, that was a big quality in him. So I think I was the biggest beneficiary of his approach. He used to criticize on everything which I did. So I polished myself so well to come to standard. So this is the quality of Dr. Roy. Just to criticize his own work, that was great.
Yes. So in that line, one question can be asked that why do you select 20% margin? This is an acute care setting, 20%.
In acute case setting, why did you have such a small floating margin?
20% margin is a reasonably wider margin for a non-inferiority trial, and it was done because of the sample size restrictions, purely because of the sample size restrictions. In order to demonstrate power for 10% inferiority margin, I should have had recruited around more than 200 patients. And since I had time restraints, I had to restrict to a 20% inferiority margin.
त्यागी ऐसा मुंह हल्ला
Yes, Dr.
जब
Tyagi.
खाली का मुंह दिखाना बहुत उसका शौक है.
Okay. Right, sir.
Okay. Thank you, Dr. Balaji.
Thank you.
We now go on to the next speaker, Dr. Abhimanyu. Assessment of LV dysfunction following catheter-guided PDA device closure. Dr. Abhimanyu.
Yes, just a second.
Dr. Abhimanyu, can I ask you one question before we start?
Yes, sir. Please, sir.
Who did the first PDA closure in the country?
Sorry,
Device
sir.
closure PDA, who did the first in the country?
Sorry, sir. I don't know.
You don't know. It was Dr. Khalilullah.
Oh, sorry.
Okay. So you know the history of PDA closure? 1988, we started PDA closure with the device. We began with the Reshkin device. Then all these came very easy to handle devices. Okay.
Yes,
Go ahead,
sir.
Abhimanyu.
Thank you.
Yes.
Okay. My screens are visible, sir? Yeah.
Yes, sir.
Okay. Good afternoon. The topic of my research is assessment of LV dysfunction and its predictors post PDA device closure. Now, we know that currently transcatheter therapy is the treatment of choice for significant PDA lesions and is expected to decrease the volume overload from left to right shunt and thus improve the LV function. But various studies have highlighted an acute deterioration in the LV function post PDA device closure, possibly because now the preload to the left heart is curtailed and also because the pulmonary circulation is removed from the systemic outflow, thereby increasing the afterload on the left ventricle. So because of this preload reduction and afterload augmentation, we find an acute deterioration in LV function. So why this LV dysfunction becomes very significant in a developing country like India? The reason is that here in our country, in our setup, the congenital heart disease presentation, diagnosis, as well as its treatment is usually at a later stage when we compare to the Western population. Therefore, the dysfunction that is expected to occur after PDA closure is likely to be more severe and more persistent. If the natural history of such post-op dysfunction is known, then we can better plan the post-operative care of these patients and also arrange more diligent follow-up for those expected to have persistent dysfunction. Previous studies from our country have mostly studies from our country have mostly studied parameters like ejection fraction, myocardial performance index, or fractional shortening to predict this phenomena. But we hypothesize that more sensitive tools like spectral imaging drive GLS can be of better aid in this area. Also, the follow-up of systolic and diastolic function after 1 month, especially in older age population, is less. And this deserves assessment because this population is not very scarce in our setting. So we conducted this study with primary objective to evaluate LV function post-closure and also to assess the predictors of myocardial dysfunction. Ours was an observational study conducted over 1 year in a tertiary care setting and included PDA patients more than 1 year of age with significant shunt provided they do not have other concomitant congenital heart disease or irreversible pulmonary vascular disease. The methodology was conducting an echo, tissue Doppler, and GLS at pre-procedure and then at 48 hours post-procedure and then again at 1 month. If a patient had EF less than 55% at 1 month, this was defined as residual LV dysfunction, and then a repeat scan was done at 6 months. Standardized statistical tools were used and p-value less than 0.5 was considered significant. Now coming to the results. In the baseline characteristics, we divided our patients in 3 subgroups according to age. We can see here that 63% of the patients belong to 1 to 10 years of age, with females exceeding males across all age groups. Patients have higher left ventricular and diastolic diameter and lower ejection fraction, fractional shortening, and GLS, and they belong to the higher age groups. However, young patients had higher PDA diameters. This is possibly explainable by earlier presentation of a larger PDA. Now, once the PDA device was closed, you can see that there was an acute fall in LV dimensions as well as systolic and diastolic function variables. These variables, as can be seen in the next graphs, demonstrate that there is an improvement in the systolic as well as the diastolic variables over 1 and 6 months. The LV and diastolic diameter continued to decrease after the PDA closure, suggestive of reverse remodeling. Next, to fulfill our second objective, we started the assessment of studying these variables to correlate them with the percentage change in ejection fraction that immediately occurred after PDA device closure. On multivariate analysis, we can see that GLS comes out to be the best predictor in this respect. 18 patients out of the total 35 patients from our study showed a residual dysfunction, that is EF less than 55% at 1 month. Now, compared to the patients who showed complete recovery by 1 month, these patients had higher age, larger PDA diameters, and also higher LVDT Z values. Now, next, we studied what were the variables that could predict the ejection fraction at 1 month after PDA device closure. So, after conducting a univariate followed by a multivariate analysis, we found out that the ejection fraction pre-procedure as well as the GLS were the best predictors of ejection fraction at 1 month. This is the regression equation to predict the ejection fraction at 1 month using pre-procedure ejection fraction and GLS. Next, an ROC plot was constructed that suggested that a cutoff GLS value of less than 18.5 predicted ejection fraction less than 55% with 85.7% sensitivity and 73% specificity. At 6 months, only 2 patients from our study had incomplete ejection fraction recovery, and both belong to the adult age group. Now, to the discussion part, summarizing our findings, acute and long-term hemodynamic effects of the PDA closure were highlighted by our study. The percentage fall in the immediate post-procedure period was best predicted by GLS, whereas the state of ejection fraction recovery at 1 month was best predicted by ejection fraction and GLS both. Now, why GLS fares better than EF in this aspect? The reason might be that there is less operator dependence of GLS, and the GLS as an entity is more sensitive to changes in subendocardial longitudinal contraction and interstitial properties, whereas ejection fraction quantifies more of radial contraction better than the longitudinal contraction. The cutoff value of less than 18.5 that was derived from our study suggests that PDA closure, once done before the GLS has fallen below this value, would culminate in incomplete recovery at 1 month, and thus it will warrant longer follow-up of the patients. The limitations of our study was firstly that there was no normative data of GLS and TDI available for a pediatric population. So if we had a control group, that would have been better to define the grade of dysfunction that was pre-existing in these patients. But since we were studying the trend of changes in these values, hence in the ultimate results of our study, the absolute values were not much relevant. Then the adult age group sample size was small, and this can make the generalization of the results to this subgroup difficult. Concluding my study, the PDA closure beyond infancy almost always results in acute deterioration in LV function, and sometimes this dysfunction can be persistent. Newer parameters which are more sensitive, for example GLS, add to the better prediction of severity and long-term persistence of LV dysfunction. The patients, with the help of these tools, can be better triaged before conducting the procedure, and thus close monitoring can be done empirically. Empirically. That's it, sir. Thank you.
Madam Dr. Anita Saxena, ma'am, and Kothari sir, Dr. Khairullah has logged off because of some network issues. He's rejoining. If you can carry on with the discussion.
Okay. So, Abhimanyu, my question is that you said that higher age and a larger PDA were more often associated with incomplete recovery of LV function.
Yes.
But when you showed the data of the PDA size was much bigger. It was to the tune of 7 millimeter or so in those under 10 years of age, compared to those more than 20 years where it was more like a 3 millimeter PDA.
Yes.
So how do you explain that contradiction?
Ma'am, actually, it is not a contradiction. When I commented on the overall results, I compared the patients who had a complete recovery of AF versus the patients who did not have recovery of AF at 1 month. And in this analysis, I took all the patients together, not as separate subgroups. So possibly because of this, there is some discrepancy here that we can see. The older age and the LVDD, they were actually, ma'am, independent predictors. So patients who had like older age only, they were more likely to have dysfunction, and the patients who had more LV diameter independently were more likely to have persistent dysfunction.
So this LV diameter that you are saying, have you corrected it to the body surface area? Because you have children of 1 and 2 years also.
Ma'am, I have taken the Z values that I derived from a calculator from parameters.com. So the Z values I have used. I have not corrected it to body surface area. I have used the Z values that takes into account the weight of the patient as well as the height of the patient.
That we know. So which Z value are you talking of? Plus 2Z, plus 3Z, plus 4Z? Which one are predictive? At what Z value are they predictive?
Yes, ma'am. Actually, ma'am, when I constructed the ROC plot, I used two variables. I have shown here only one, GLS. The LVDD Z value of more than 4.5 in my case was more predictive of a persistent dysfunction.
Okay. And the second question is that you said that in many of these patients, it did not normalize at 1 month, and you did follow them up to 6 months also.
Yes, ma'am.
What happened at 6 months? Did everybody normalize, or still there were some abnormal?
Yeah, I showed it, ma'am, in my slides, that two patients were only left who did not normalize completely. One was 42 years age and one was 35 years of age. In these patients, the ejection fraction even at 6 months was less than 55%. Rest of the patients had completely recovered.
And you don't have a further follow-up of those patients?
No, I did a follow-up after that also. Since my thesis has completed, so I did not incorporate the results. I have followed those patients. Their dysfunction is still persistent, ma'am.
Okay, all right. Thank you.
Abhimanyu, this is a topic which is often discussed. So is it a clinical LV dysfunction? Why do you call it LV dysfunction? This is no LV dysfunction, just that EF measured is low.
Yes, sir.
Is the cardiac output low?
Sir, I'll just add two comments to this, sir. Firstly, in one of our patients, sir, we did have a clinical dysfunction, and the patient, she was a female patient of 18 years of age, and we had to treat her with Lasix and some drugs like Metaxel and all for few months. So this is one of the things, sir, that this dysfunction can be clinical, and it has been shown in some studies in a very small percentage of patients it can be clinical. Second, sir, what I want to emphasize here is that since when we conduct PDA closure in older age patients, now suppose we have a male who is 40, 45 or 50-year-old male, if suppose device closure is being done in that age group, and if that leads to some kind of an LV dysfunction, it can become clinical at a later stage of life when the person suppose develops an ischemic heart disease or any other concomitant.
No, that you cannot say from your study. This is an artifact of measurement because there was a large preload. Now you reduce the preload, the same amount of LV looks like contracting less because now it doesn't have to pump 2 liters. Now it pumps only 1 liter. So this EF low is an artifact. It is not actual LV dysfunction.
Okay.
If I were to argue that, what is your response? Because previously this LV was putting 2 liters of blood. Now if it was 2:1 shunt, now it just has to pump 1 liter. So it looks like as if contracting less. There is no actual ventricular dysfunction because the outputs are not low.
Sir, actually, because ejection fraction is definitely, sir, a preload dependent variable, so that will definitely come down when we close the shunt. But then the other variables, like for example, I'll comment, sir, that once the ejection fraction had decreased, then the loading conditions are still remaining the same. Once we have closed the shunt, now the preload of the ventricle has become a constant. After this, the LV function starts improving. So by 1 month, in most of the patients, LV function had improved. But in some amount of patients, this LV dysfunction had not improved. So, sir, I studied these patients, that why the dysfunction did not improve in them. That is the reason.
So those two have a long-term shunts. If you leave them alone, they will have. So if you leave 100 PDAs, after 10, 20 years, some of them will have LV dysfunction. That is not to do much to do with the closure. Anyhow, the second thing you said, GLS cutoffs. You have written some cutoffs. Now GLS cutoffs are all vendor dependent also.
Yes, sir. There are no normative data, and one vendor has a different value than the other vendor. Yes, sir. So if you say a number, you have to say which machine, what vendor.
Yeah,
so that is a difficulty in showing cutoffs.
Yeah, I mentioned it my methodology because I skipped the slide very quickly, so I think nobody could see it properly. It was by QF software conducted on a Philips Epic 7 machine. So that was the machine that we used, sir.
So these numbers are dependent on particular machine.
Yes, definitely, sir. That is why a generalization cannot be made for sir all the interventionists who are doing it, because it will definitely depend on the machine.
The one patient that you had LV dysfunction clinical, what happened to that patient? After closure, she developed pulmonary edema?
Yes, sir. Pulmonary edema developed actually, sir, after I think 3 hours of the procedure, when we had shifted the patient to the ward. Then at that time she developed tachypnea and pulmonary edema. So she had to be treated with IV diuretics for I think 2 days.
I must confess, I have not seen a situation like that, but it may happen.
This
Some
also
cases are
occurred
there.
only in one patient, sir, it occurred. Otherwise, it didn't happen in any other patient.
Okay.
In my life of doing almost 3-4 PDAs, I've never seen this one happening. This surprising. Number two, Bhimanyu, could be an alteration in the peripheral vascular resistance. I've not heard your presentation completely, but is there alteration in the peripheral vascular resistance before or after PDA closure, which led to alteration in the LVDP?
Sir, the afterload will definitely increase, but the peripheral vascular resistance, sir, if the cardiac output suddenly falls after PDA closure, then that can lead to an increase in the peripheral vascular resistance to maintain the blood flow to the vital organs. But that is again going to be transient. If the LV function stays normal, then that increase will again be transient only, sir. Although I didn't study it, sir, particularly in this study.
Because patient's PDA has a lower PVR, peripheral vascular resistance, and after you close, suddenly the volume changes take place, and the vessels have to constrict to accommodate to give the same blood pressure. No,
Yes.
Otherwise they'll have fall of blood pressure.
Definitely.
Abhimanyu,
Okay.
I have just one more. Sorry, Dr. Kharula, please go ahead.
I'm sorry, I could not hear the whole presentation, so please mark him, both of you. Thank you.
I just wanted to ask you, did you come across while you were doing the review of literature, any study where surgery, earlier like PDA ligation, have they also reported similar results, or it is only reported with devices?
I came across, I think, 2 or 3 studies which were done in patients who had surgical closure of PDA. They also reported the same results, ma'am. That there was a bimodal pattern of derangement in function.
Okay. Okay, thank you.
Oh, thank you.
Okay, thank you, Bhimanyu. We now go on to the next speaker, Venkat Krishnan. The effect of yogic exercise on clinical outcome in patients with vasovagal syncope, a randomized controlled trial. Dr. Venkat Krishnan, please.
Yeah, good afternoon, everyone. Is my screen visible? My PPT visible?
Go ahead.
Yeah. So good afternoon to everyone. I'll be presenting my randomized controlled trial thesis for the effect of yogic exercises on clinical outcomes and quality of life in patients with vasovagal syncope. And we'll be starting with a little bit of background. The VVS or vasovagal syncope is a common condition worldwide. We know that 40% of the world experiences one episode, and up to 30% of those experience second episode. It leads to significant loss of quality of life, and we know that multiple treatments have been tried through multiple RCTs over the years, and very few effective treatment strategies exist, with most treatments offering at best modest benefit. And with this background, we like to bring in yoga as a potential treatment option. Of late, yoga has created quite a splash in cardiovascular diseases where autonomic imbalances have been implicated. For example, atrial fibrillation or post-myocardial infarction rehabilitation. So the hypothesis that we tested was in patients with recurrent vasovagal syncope, 6 months of regular yogic exercises from a specially designed yoga module as an adjunct to standard therapy is superior to standard therapy alone in reducing syncope or pre-syncope burden. The primary objective was to test the impact of yogic exercises as an adjunct to standard therapy alone over symptomatic burden for a duration of 6 months. The secondary objective was to test the same hypothesis on quality of life and autonomic balance. So this is the currently accepted mechanistic basis of a vasovagal syncope episode. We know that decreased preload leads to exaggerated sympathetic activation, leading to a recruitment of the ventricular efferent, leading to activation of the rostral ventral lateral nucleus of the medulla. This leads to a paradoxical sympathetic withdrawal and increased sympathetic tone in bradycardia, leading to a syncopal event. So we postulated that yoga being an agent where it can reset the autonomic balance towards a more better parasympathetic flow, would truncate and interrupt this exaggerated sympathetic activation component, leading to no or less recruitment of ventricular efferent. Also, improve muscle tone would improve the vasodilatory phase, and mindfulness would improve any stress-related anxiety in these patients. So this was a single center randomized control trial. It was an open label randomized control trial. We formed an intention to treat analysis. The primary outcomes were number of episodes of syncope or pre-syncope at 6 months. The secondary outcomes are quality of life scores by means of the syncope functional status questionnaire and the WHO breast scores at 6 months. And we also tested HUT positivity at the end of 6 weeks. Sample size calculation was done by a pilot study, a non-randomized pilot study by Gunda et al. But sample size obtained by that was very small, only 6 patients. So we took 80% of the effect size from that study and arrived at a sample size of 50 with 20% dropout rate to 20% attrition. We came to a sample size of 60. We included patients between 50 and 70, and they need to have a HUT positive within the last 3 months. And they should have had 2 or more episodes of syncope or pre-syncope in the last 6 months. So recurrent vasovagal syncope, basically. Exclusion criteria was structural heart disease, arrhythmic heart disease, neurological disease, conditions precluding yoga practice, and VBS patients requiring pacemakers. So we designed a specially programmed yoga module for these patients, including breathing practices, relaxation techniques, postures, and meditation. And they had to practice this for 5 times a day, at least 80% of the weeks during the study, to be deemed as compliant. And this total module would last 40 minutes a day. And these patients obviously had to be trained in yoga in these practices. So they were given training to an initial training phase where initial 2 weeks they'd be given 8 classes. At the end of the 2 weeks, they would be asked to start practicing yoga from home, and they would also be observed clinical events from that. So we deliberately given a 2-week blanking period. Apart from that, they would have a supervision phase of 1 month of 2 classes and 1 class each per month for the next 4 months. And they'd be given a yoga booklet wherein they'd be filling the number of episodes of syncope, pre-syncope they had, and also the frequency of yoga practice that they had performed. The control group would receive standard care alone. The standard care was deemed as physical counterpressure maneuvers, salt and water intake augmentation, and if required, drug therapy and pacing would be initiated by the treating physician at his discretion. So this is the primary schema of the study. So we see that, sorry, I beg your pardon. So of the 125 patients screened, 31 were recruited, out of which 17 were in the intervention arm and 14 were in standard therapy arm. At the outset, all patients would get history and physical examination. They would get a HUT, they would get a Holter, and they would get their quality of life questionnaires would be filled. At 6 weeks, they would not get a Holter, but they would get a history physical exam quality of life score booklet, and they would be given a HUT. And at 3 months, only history physical exam and booklet. The same with 6 months, and at 6 months, data analysis would be performed. So baseline characteristics, both arms were evenly matched with respect to vital statistics, with respect to clinical events, with respect to functional status scores, and none of the patients were on any pharmacological therapy at the outset of the trial. The primary outcome, here I'd like to draw your attention to 6 months here. At 6 months, in between the 2 groups, within the intervention group, a total of 6 events occurred amongst all the patients, whereas in the control group, 15 events occurred out of 14 patients. And this difference was deemed statistically significant with a p-value of 0.02. And the curve separated pretty early, starting from 6 weeks itself, to achieve a total relative risk reduction of 60% at the end of 6 months. And we also like to say that all 17 patients fortunately had completed 5 weeks or more, five sessions or more per week for more than 80% of duration. So we had achieved 100% compliance. Due to the nature of events, that vasovagal syncope follows a Poisson distribution. So we also present the data as an event-free patient percentage. I'd like to draw attention to 3 months and 6 months here, when the difference between both was statistically significant. At 6 months, 13 out of 17 patients remain completely clinical event-free, whereas in the control arm, only 5 out of 14 patients remain completely clinical event-free. And also, we present the data in the form of median, minimum, maximum to say that there was no particular outlier. The difference at 3 months and 6 months are again statistically significant. At 6 months, if I can draw your attention to this block here, the maximum in the intervention arm was one patient had 2 events, whereas in control arm, one patient had 3 events. So there was no one particular outlier as well. And with respect to secondary outcomes, there was a trend towards improvement with a numerical improvement in most scores. And one score had shown a strong trend towards improvement, and 2 scores had shown a statistically significant trend towards improvement. Heart positivity again showed a numerical trend towards improvement between the 2 arms with respect to the intervention. So discussion, this study represents the first RCT studying vasovagal syncope outcomes in yogic exercises. The study had shown that there was a significant reduction in clinical events over and above standard therapy, and the effect size had begun early. Yoga demonstrated a sizable effect, a rate of risk reduction of 60% in the study, and we calculated a number needed to treat of only 3 patients. Only 3 patients had to practice yoga for 6 months to reduce 1 clinical event. There was only a trend towards improvement in the quality of life. We speculated that it was probably due to a heterogeneity of the response, the subjective nature of the parameters itself, or perhaps it was premature assessment. The intervention represented a specialized yoga program that we'd like to stress on, and the program was sustainable and safe. All patients were able to perform consistently without any adverse events. Limitation of the study, the obvious limitation was that we enrolled only 52% of the estimated sample size. Even if we counted 20% attrition rate, it would still be only 62%. The open label design lends itself to bias. We acknowledge that we could not blind a study of this nature, and also we had tested 2 treatments above 1. The small period of observation again was a limitation, and it was a single center study, which made it difficult to generalize. So in conclusion, in patients with recurrent vasovagal syncope, 6 months of regular yogic exercises from a specially designed yoga module and adjunct to standard therapy significantly reduced syncope or pre-syncope burden over and above standard therapy alone. The effect on quality of life domains showed a partially positive effect. Yoga did not demonstrate a reduction in heart positivity at 6 weeks. That was statistically significant. And this study may not produce a sea change in the armamentarium of treatment, but it should herald a beginning where larger studies can be performed to test the benefit of yoga and vasovagal syncope.
Thank you, Dr. Venkat Krishnan.
Yes,
this kind of study, hello, can you hear me?
Yes, sir, I can hear you.
Yes, yes. This kind of study should require a very large sample, no? It's a very, very small sample. And how did you quantify the kind of yoga exercises, objectivity, subjectivity, what was the technique? If you see the results on objective evaluation, there was no change at all in the 2 group of patients. Symptomatically, they may or may not be better off.
Yes, sir.
Actually, there is no change in the situation for the patients, no? Yes.
Sir, to address the first point, sir, we humbly sample size was much shorter than what we had expected to enroll, but due to slow enrollment, we had to prematurely terminate the thesis. Although just small caveat there, I'd like to address that we were able to still demonstrate a good enough effect size to demonstrate a difference in clinical outcomes. Secondly, sir, that just segues into the next question. Actually, I'd like to say that the patients had reported a significantly reduced number of arm compared to the control arm. And we had actually calculated the sample size and the predicted events based on the Poisson distribution, which is what is accepted in the world today based on a paper by Sheldon et al. So they had reported reduced number of events. And secondly, with respect to the secondary outcomes, yes, it does seem a little discordant with the primary outcomes. Usually, we expect that yoga would have actually not shown benefit of clinical events, but would have improved quality of life. But this came out to be the other way around. But due to the subjective nature of the parameters itself, so we realize that quality of life is a very subjective thing, and which is why we had actually put in heart clinic as well, at least as hard as possible, those clinical events as the primary outcome.
What kind of yogic exercises you had advised?
Yes, sir. So the yogic program had comprised of meditation, of relaxation techniques, of breathing, salabhasana, and of asanas themselves, postures themselves, like sitting when like standing asanas like Ardha Kati Chakrasana, Ardha Chakrasana, Padhastasana, and with lying down asanas like Viparita Karani Asana. So due to want of time, I couldn't go into the details of how and the why of yoga module, but it was specially designed after consultation with our yoga therapist and was ratified by 5 yogic experts of national repute independently. They were explained and appraised about the pathophysiology of the illness and the kind of patients we'll be dealing with, and it was designed based on that.
Thank you. Thank you. I think
The question is, did you check for any parasympathetic sympathetic imbalance? I mean, you hypothesize that it will happen, but did you have an objective assessment on any terms to say that sympathetic parasympathetic imbalance has changed after yoga?
Sir, no, sir. We had actually we had considered including heart rate variability as a parameter, but that is also shown to be quite subjective. So it was decided that perhaps it may confirm the results a lot more.
And how many of these patients are continuing to do so? Because once you stop it, they will probably also stop. Are they continuing to do the therapy?
Yes, sir. Patients are continuing to do the therapy out of their own volition. We are offering on humanitarian basis. We are offering supervision classes and further follow-up because they still are our patients.
So you think 40 minutes every day for a vasovagal syncope, which happens once in a year or once in 6 months, they will continue?
Sir, to the best of our knowledge, they are continuing. There are also other benefits to yoga. It's not just that they are trying to prevent one. Also,
that is not part of the study.
Several other. Sorry, sir.
That is not part of the study.
No, sir. I'm not saying that's part of my study. I'm saying we are out of by virtue of being the physicians, we are continuing the follow-up and providing them care.
Okay.
The study is terminated at 6 months. It does not mean that I will be stopping.
Venkat, why did you not repeat a heart test at the end of 6 months, at the end of the study?
Yes, ma'am. That was a limitation that we later on had considered. That point is very well taken, ma'am. We should have repeated the heart at the end of 6 months. The thing was due to like the patients were few and far in between. So by the time we started to see the results, it was too late to call back the initial patient. So it was a practical issue actually. So we should have we didn't decide upfront that we should be doing heart a lot later. We thought 6 weeks was the appropriate time because based on previous literature, we thought 6 weeks would have been the appropriate time to see a repeat. At the time we realized that perhaps these patients are the heart is being done too early. We couldn't.
Yes, time is up, Venkat. That's okay.
Yes. Thank you, Venkat. We now go to the next speaker, Dr. Shravan. Acute and short-term effects of successful mitral valvuloplasty on left atrial compliance and its correlation with the clinical outcome. Dr. Shravan, please. We have to stick to time. We have already overrun the time now. Please, is Dr. Shravan in the gathering? Hello?
Am I audible, sir? Hello?
Yes.
Okay.
Yes. Start. Please go ahead.
Okay. So today I'm going to present our study that is acute and short-term effects of successful mitral valvuloplasty on net atrioventricular compliance and its correlation with the clinical outcome. Now we all know that successful BMV is an increase in the MVA to greater than 1.5 centimeter square or greater than 50% increase from the baseline without development of significant mitral regurgitation. But despite similar increase in the mitral valve area after successful BMV, significant variation has been observed in NIHA functional class and exercise capacity in patients with MS. The variation in the extent of regression of pulmonary arterial hypertension has been one of the principal factors despite comparable valve area and transmitral gradient. Failure of improvement in the LA compliance post-BMV is a major contributor to the persistence of high systolic pulmonary arterial pressure. So the aim of our study was to assess the change in compliance and to correlate this change in compliance with the clinical outcome. So it was an observational prospective pilot study from January 2018 to July 2019, which enrolled 50 patients. Now, all the patients aged 18 to 40 years with isolated rheumatic MS in sinus rhythm were included, and we excluded the patients with moderate to severe mitral regurgitation, moderate to severe aortic stenosis or regurgitation, associate comorbidities like coronary artery disease, ejection fraction less than 50%, stroke, transient ischemic attack and peripheral vascular disease, diabetes, systemic hypertension, CKD, and infections. Even the patients who had low quality echo image and technically unsuccessful BMV were excluded. The patients who had left ventricular end diastolic pressure of greater than 12 mm Hg assessed on table pre-BMV were also excluded. So 2D echo was done at baseline, post-BMV mainly for technical success, and was followed up at 2, 12 and 24 weeks. Clinical assessment for NIHA functional class and 6-minute walk test was done at baseline and then at 2 weeks, 12 weeks and 24 weeks following BMV. Now left atrial compliance is defined as a change in left atrial volume divided by the pressure. So stiffer the left atrium, lower is the compliance. We can easily calculate it from the echocardiographic parameter, that is mitral E-wave deceleration time and mitral valve area by the continuity equation as described by Flanscap in JAC 1992. Now we did all the statistical analysis as per the protocol. Now coming to the results. Sorry, what is happening? Coming to the results, 70% of the patients were female with a mean age of 30 years. Most of the patients were highly symptomatic with NIHA class 3 in almost 86% of the patients, with a mean valve area of 0.73 and mean transmitral gradient of 15. Now we assessed the variables in our patients at baseline, 2 weeks, 12 weeks and 24 weeks with respect to NIHA functional class, 6-minute walk test, compliance, mitral valve area, mean transmitral gradient and systemic pulmonary artery pressure. Now as we can see that mitral valve area and mean transmitral gradient improved at post BMB at 2 weeks but did not have a significant improvement at 12 weeks or 24 weeks. Whereas in case of compliance, it improved post BMV at 2 weeks and kept on improving at 12 weeks. Along with compliance, NIHA functional class also improved at 2 and 12 weeks along with the 6-minute walk test, and it also corroborated with the regression in pulmonary artery pressure at 2 weeks and 12 weeks. We further see that the patients who had regression in the improvement in the compliance and this regression in the systemic pulmonary artery pressure did not have a significant improvement from 12 week to 24 week. So NIHA functional class, 6-minute walk test and the compliance were equivalent in both 12 weeks and 24 weeks in these patients. Now, we correlated the change in compliance with the clinical and echocardiographic parameters, and we saw that NIHA functional class, 6-minute walk test and systolic pulmonary artery pressure were significantly associated at 2 weeks, 12 weeks and 24 weeks and showed a good correlation. Whereas a mitral valve area and mean transmitral gradient showed a poor correlation with the change in compliance. And this was the scatter plot showing the change in compliance and 6-minute walk test showing positive correlation. And this was the scatter plot with change in compliance and systolic pulmonary artery pressure showing a positive. Now, with respect to the change in mitral valve area, we saw that NIHA functional class, 6-minute walk test and systolic pulmonary artery pressure did not show good correlation with change in mitral valve area. Now, we compared the patients of pre versus post. So we compared the patients at pre-BMB and post-BMB at 12 weeks between the groups who had a good clinical outcome and the patients who had a poor clinical outcome defined by the improvement in the NIHA functional class. So group A had good clinical outcome where the mean age, number of females, Wilkins score, 6-minute walk test and mitral valve area were almost equal in both the groups. We can see that the compliance was significantly different and it was lower in group B as compared to group A. Whereas in post BMV group, we can see that compliance, systolic pulmonary artery pressure and 6-minute walk test were significantly different in group B as compared to group A, and the percent change in compliance was significantly higher in the patients with good clinical outcome as compared to the poor clinical outcome. Now we try to find out the cutoff value for the percent change in compliance which could predict good clinical outcome, and our best cutoff was 36.87% with a sensitivity of 91% and a specificity of 70%. So this was the first study correlating a change in compliance post BMV with a clinical outcome over 6 months and determining a cutoff value for the percent change in compliance to predict good clinical outcome. Two earlier studies have assessed only the acute effect of BMV on compliance, which was in agreement to our study. Systolic pulmonary artery pressure is a major determinant of NIHA functional class and exercise ability in the patients, and change in LA compliance apart from the mitral valve area is a major predictor of pulmonary artery pressure regression following BMV and is a major predictor of clinical outcome. Limitations: our study sample size was small and we analyzed the pressure gradient and the flow data only at rest. So to conclude, left atrial compliance following BMV had a significant correlation with clinical improvement. Increase in the mitral valve area or reduction in the mean transmitral gradient, which are the indicator of procedural success, did not correlate with clinical improvement. Hence, a change in compliance should be assessed along with mitral valve area to predict better clinical outcome following technically successful BMV. Thank you.
Yes, sir.
Thank you, Dr. Shravan. That's a very good study. A few things to ask you. Number one is, in patients who had this valvuloplasty,
yes, sir.
In post-op MR correlated with the change in compliance of the left atrium?
So, sir, this is not indicated acutely because the by continuity equation, it can lead to.
Cannot hear you.
Hello, sir.
Yeah.
Yes, good. Again.
Say it again, please.
Sir, you want to say that the degree of MR did have an influence on, so we did not included the patients we did not included the echo findings just post BMV, and we followed up with that patient at 2 weeks, 12 weeks and 24 weeks.
So they didn't have any MR?
No, sir, no significant MR.
Patients with MR were excluded, right?
Patients with MR were excluded, right, sir?
Okay.
So what is the correlation between mitral valve area and compliance, LA compliance?
Mitral valve area, we did not do a separate correlation between area and the compliance, sir.
So my assertion is that if the valve area becomes better, compliance will also become better. So see, correlation is not causation. You are ascribing causation to the correlation. Correlation will be there. That does not automatically mean that it is causing the
that did not
change in
turn out to the case, sir.
Okay, I think time is up, so we have to.
Yes. Thank you, Dr. Shravan. The last but one, we have Dr. Sudhanshu.
Hello, sorry, sir, I could not hear your question.
No, thank you, sir. Dr. Shravan, the time is up. We will go to the next speaker now. That is Dr. Sudhanshu. Effect of percutaneous valvular mitroplasty on the right and left vertical deformation in patients with isolated fever mitral stenosis, speckle breaking strain echocardiographic study. Dr. Sudhanshu, please.
My topic for today is left and right ventricular deformation in patients with severe mitral stenosis undergoing BMV, a two-dimensional speckle tracking echocardiographic study. Just a bit of introduction. Mitral stenosis is the most common valve lesion in rheumatic heart disease. Long-standing mitral stenosis leads to pulmonary hypertension, which further leads to right heart failure. This right heart failures is usually overlooked because of difficulties in quantitative assessment of RV function. In isolated MS, LV is underfilled. There is no significant hemodynamic overload on LV, but because of decreased preload, there is adverse remodeling which occurs in the LV. Mechanism postulated to explain LV systolic dysfunction includes chronically reduced preload that contributes to hemodynamic factor and extension of the inflammation from the mitral valve into adjacent myocardium, that is the second factor, myocardial factor. Why we have used a speckle tracking echocardiography in this study? Because it assesses the subclinical biventricular dysfunction as it permits more comprehensive evaluation of myocardial contractile function than the conventional EF. Allow regional as well as global biventricular function assessment in contrast to standard echo, which only assesses global ventricular function. Now, what are the lacunae in the literature? There are only a few studies that have reported LV systolic dysfunction, which may be uncommon in patients with rheumatic MS. Long-term improvement in RV function has already been shown in patients with MS post-BMV. However, immediate effects of BMV on RV function, especially via the speckle tracking echocardiographies, was examined in only a few studies. None of the studies till date have correlated the invasive hemodynamic data obtained in the cath lab during the BMV with echocardiographic derived strain parameters. So aim of our study is to assess the biventricular deformation in patients with isolated severe MS. Secondary aims are to assess the effects of BMV on biventricular deformation and to find the correlation between the various echocardiographic and invasive hemodynamic parameters with the strain parameters pre and post BMV. Now, materials and methods. R is a prospective study conducted from January 2018 to July 2019, and we enrolled 75 patients in our studies. The inclusion criteria was age between 18 to 40 years with isolated severe MS in sinus rhythm. The indication for BMV was NYHA functional class 2 to 4, mitral valve area by planimetry less than 1.5 centimeter, and obviously with a suitable valve morphology just according to Wilkins score. We excluded patients with significant MR or significant aortic valve involvement with coronary artery disease, previous mitral or aortic valve surgery or intervention, acute rheumatic fever, overt LV and RV systolic dysfunction, and patients in atrial fibrillation. Now, methodology. 2D echo images were obtained from the apical 2-chamber, apical 3-chamber, and 4-chamber views for LV and modified apical view for RV in 3 consecutive beats via the Philips EPIC 7C echo machine. LV myocardium was divided into 6 walls: anterior, anteroseptal, anterolateral, inferior, inferoseptal, and inferolateral. And RV myocardium was divided into 2 walls, septum and free wall. All walls were then subdivided into 3 segments: apical, mid, and basal. The peak strain was calculated for each segment individually, and then the global strain was generated automatically for both the ventricles by the software. So this is a figure which show how did we assess the global longitudinal strain. This was a strain recorded pre-BMV, and this was the strain recorded post-BMV in apical 4-chamber view, 3-chamber view, and 2-chamber view. Then final bullseye was generated at the end. The appropriate statistical analysis was applied for a study, and we obtained the following results. These were the baseline parameters which were seen in our patient population. The mitral valve area mean value pre-BMV was 1.6 plus minus 0.15 centimeters square, which increased to 1.56 plus minus 0.4. The mean gradient across the mitral valve was 14.89 plus minus 2.3, which decreased to 8.79 plus minus 1.84, being significant. The ejection fraction studied by Simpsons was almost non-significant. The ejection fraction was almost same. Now, what was the severity of pulmonary hypertension in patients pre and post BMV? In pre-BMV, only 2 patients had no pulmonary hypertension, 15 had mild, and 58 had moderate to severe. But when we compare the result post BMV, 47 had no pulmonary hypertension, 18 had mild, and only 10 remained with severe pulmonary hypertension. Now, this was the strain analysis pre and post BMV. This was the global longitudinal strain which was calculated pre BMV. It was minus 16.35 plus minus 1.67. Post BMV, it rose to minus 19.98 plus minus 2.7 with a mean difference of 3.63, which was significant. If we compare the individual segmental strain, there was significant increase in the individual segmental strain as seen in this p-value. Now, if we compare the strain in the apical segment when compared to mid segment and basal segment, we see that the strain in the basal segment increases more as compared to mid and apical segment. Now, then we studied the correlation between the change in LV-GLS with the change in mitral valve area, with the change in the mean gradient and the change in the RVSP. As we know, post BMB, the mitral valve area increased, mean gradient decreased, and RBSP also decreased. Now, this difference was correlated with the change in LVGLS. All of these came out to be statistically significant. Now, similarly, the RV strain was studied pre and post BMB. We see here the RV strain, the global longitudinal strain improved significantly post BMB. But one thing important to note here is that right ventricular septal wall strain improved significantly post BMB, but not that of right ventricular free wall. Although it increased, but it does not reach a statistical significant value. Then again, we studied the correlation between the improvement in RVGLS with decrease in RBSP and decrease in mitral valve gradient, which came out to be statistically significant with p-value less than 0.01. Now, we also studied the invasive hemodynamic data obtained during the BMB. We studied the mean LA pressure, heart rate, and mean aortic pressure, and we found out that the LA pressure decreased significantly post BMB. And whether this mean LA pressure, which has decreased, it is significantly correlated with the change in the LV and RV global strain, and we found out that yes, it significantly correlates with the difference in the LV and RV global strain, which is obtained post BMB. Now coming to discussion. Now what we have seen in LVGLS, when we compared LVGLS pre and post BMB, we see that pre BMB LVGLS is impaired in MS patient despite the ejection fraction being normal. Basal LV segment strain was low when compared to the mid and apical segment strain pre BMB. Post BMB, what we see is the strain increased significantly in all the segments and globally. In absolute term, the increase was maximum in the basal segment and least in the apical segment. Why was there a LV dysfunction? This was because of two factors: chronically underfilled LV, which leads to adverse LV remodeling, which improves post BMB when we increase the mitral valve area. And second reason could be that rheumatic endocarditis and scarring, which extend from mitral annulus to the surrounding basal LV segments, an effect that fades away as we go towards the apical segments. This may explain why the strain improvement in strain was less in apical segment when compared to the basal segments. Now coming to the RV strain, which we have seen pre and post BMB. In pre BMB, there was impaired segmental RV GLS at baseline. Post BMB, we see that global RV strain and segmental RV strain of only the septum increased significantly post BMB, but RV free wall strain did not increase significantly. But could be a reason for that is that rheumatic endocarditis and scarring extend from mitral annulus to surrounding LV segments, and thus it reflects the changes actually occurring in the LV segment and affects the only RV septal sites. Hence, RV free wall may remain unaffected due to this spread of rheumatic endocarditis. Now, what was the correlation of change in echo parameters with improvement in strain parameters? We see that improvement in LVGLS correlated significantly with increase in mitral valve area, with decrease in mean gradient and decrease in RVSP. Similarly, the improvement in RVGLS post BMB correlated significantly with decrease in mean gradient and decrease in RVSP. But about the invasive hemodynamic data, we saw that invasive LA pressure, there was a positive correlation between the invasive mean LA pressure pre-BMB with LV and RVGLS, suggesting the role of underfilled LV in LV dysfunction. Secondly, there was a significant correlation between the decrease in LA pressure and improvement in LVGLS post-BMB. Now, what were the limitations of our study? We included only isolated severe MS patients. Hence, results are not applicable in patients with multivalvular or aortic valve involvement. We excluded AF patients in the study as it interferes with the speckle tracking strain assessments. So our results cannot be corroborated to patients with AF. Third, a large study is needed to corroborate our findings further. Now, what are the conclusions that we draw from a study? We draw following conclusions. In severe MS, subclinical LV systolic dysfunction is unrecognized. PMB resulted in marked improvement in LVGLS, though through improvement in LV diastolic filling. Similarly, regarding RVGLS, it is impaired in patients with severe MS. The decrease in RV afterload as a result of decrease in LA pressure post-BMB probably led to improvement in RV strain. Above results should have an impact on the current guidelines of BMB. In future, we may consider BMB in patients with impaired RV and LVGLS in order to prevent development of progressive systolic dysfunction.
Thank you. Can you tell us how valid is GLS for right ventricular function, whichever equipment you might have used?
Ma'am, it is quite valid. Various studies have come even in mitral stenosis comparing the RV-GLS pre and post BMB. But most of the studies had compared the chronic improvement in RV-GLS. In my study, I have compared the acute outcomes of RV-GLS.
I think, Sudhanshu, you have overrun the time because there is little time for discussion. But just one question, is the GLS load dependent or load independent?
Sir, GLS is load independent, sir.
Not quite true, because you are changing loading conditions and therefore GLS is showing some sort of change. And strain is also as much dependent as EF. So it is not altogether surprising, and it is not actually adding to, because the conclusions that you draw are not dependent on, are not drawn by your studies. Yeah, they are just thinking, because strain is load dependent.
Okay.
Okay, thank you so much, sir. I think we come to the end of the first session. It was a marathon, the Sujoy B. Roy Award. I request the respected judges, Professor Sanjay Tyagi, Professor Kothari, Professor Anita Saxena ma'am, and Dr. Fulla sir, to please share the marks together and give us the combined result. In the meantime, till this is being compiled, it would be appropriate that we move on with the next session, which is the KL Chopra Award, and we have 3 presenters for the KL Chopra Award. I would like to invite on panel the judges, Professor S.C. Manchanda sir, Professor Harshvardhan, Professor Sandeep Bansal, Professor Rakesh Yadav, and Professor Neeraj Pandit. So I would request them to start the proceedings, and if we have the result now, so that will be fine, sir. Sir, it will take some time for the results to make. So we go on with the session, or should we wait for the results of this one?
I think you go on with the session. We'll take 5 minutes to do that, sir.
Okay, sir. So we have only 3 presentations. I would request that all the students also just bear with us, stay with us for another 20-30 minutes, and we'll announce the results of both these sessions. So over to the respected judges for conducting the next session, sir. Please.
Good evening, colleagues. This is Dr. Manchanda. Welcome to this session, Colonel KL Chopra Award Paper Session. Colonel Chopra, as you know, was one of the leading clinical physicians of the city, and he introduced many new things in coronary artery disease, especially thrombolytic therapy. And he also brought what I like called spirituality in medicine and all. We have, I think, 3 presentations, and I would like to welcome the other judges. Are they all here? Dr. Harshvardhan, Dr. Sandeep Bansal, Dr. Rakesh Yadav, and Dr. Neeraj Pandit.
Thank you, sir.
They are all there. Yes, Sandeep, I can see. Yadav, I can see. Yes, yes. I think we are already running behind time, so we can start with the first presentation. This is on primary percutaneous coronary intervention in elderly population, immediate and short-term results. This is by Dr. Ankur. So Ankur, you can start the presentation. We like you to be in time, just 6 minutes and 2 minutes for presentation. Is Dr. Ankur here? No. Well, Dr. Ankur is not here. We can go to the second one. I can't.
Here, I think he's. I'm just calling, sir. You can, in the meantime, take up the second student, sir.
He's here, Mohit.
We can see him in the panelist section, sir.
Dr. Ankur, please unmute yourself and start your presentation share screen, please, quickly.
He's there.
Good afternoon, everyone. My thesis topic was primary percutaneous coronary intervention in elderly patients.
Are you sharing the screen, Dr. Ankur, or not?
I will share the screen, sir.
Please go ahead. You have to. Okay. Otherwise, we'll have to project your slides from here.
Slides are not coming.
Dr. Ankar, you can see the share screen option from the bottom center. From there, you can share your screen.
Yes, sir, I have seen share screen, but
Okay, go ahead. Actually, he didn't have the rights. He had mailed us the presentation to the head office. So this is your presentation. Go ahead, Ankur.
good afternoon, everyone. My thesis topic was primary percutaneous coronary intervention in elderly patient more than 75 years, immediate and short-term results. Although effectiveness and safety of primary PCI among patients less than 75 years old age has been proven, but current guidelines showed no specific recommendation of elderly patients in regard to best reperfusion strategy. In the existing literature, there is a positive data of patients more than 75 years, and there is no prospective or even retrospective study in our country till date. So we plan to evaluate the in-hospital acute and short-term outcomes of primary PCI in patients more than 75 years. Our primary endpoint was composite of death, MI, TBR, and stroke during index hospitalization and at the 6 months of follow-up. And secondary endpoints were separate analysis of each component of primary endpoint. It was an observational prospective pilot study, and it was done over a period of 1.5 years from January 2018 to June 19, and we have enrolled 50 patients in our study. We included patients more than 75 years presenting with STEMI within the 12 hours of symptom onset, and patients who were in cardiogenic shock, history of coronary artery bypass grafting, mechanical complication of myocardial infarction requiring intervention, history of rheumatic heart disease, and patients who were not able to take DABT, history of malignancy, and life expectancy less than 1 year were excluded from the study. A loading dose of aspirin 150 mg and clopidogrel 600 mg was given in emergency room, as elderly patients are more prone to bleeding risk, so we avoided more potent antiplatelet like prasugrel and ticagrelor. Unfractionated heparin was given. NSCT goal was maintained 250 to 350 seconds during the procedure. As advanced as is a risk factor of contrast-induced nephropathy, so we selectively use isosmotic non-ionic contrast agent iodixanol in every patient. 2D-co was done at baseline and at 6 months of follow-up. Aesthetic analysis was done according to standard methods. Now coming to results, patient who presented after more than 12 hours, we excluded them, and further patient who met our exclusion criteria, 13% who met our exclusion criteria are further excluded. So finally, we included 50% in our study. Out of these 50%, 4% expired during the index hospitalization, and 46% were discharged successfully. Out of these 46%, 1% expired during the follow-up period. So finally, 45% completed their 6 months of follow-up. Mean age of the patient was 78 minus 3, age range between 75 to 90 years. 62% patient were male, and mean BMI was 23.32 plus minus 3.14. Mean EGFR was 56 plus minus 15, and none of the patients had less than 30. Most common risk factors were hypertension and diabetes, or hypertension and smoking in our study, which were seen in 38% of the patients. 60% patient present within the 6 hours of symptom onset, and 40% present more than 6 hours, but within the 12 hours of symptom onset. Most of the patients present in CLIP class 1, and most common presentation was anterior MI, which was seen in 52%, followed by inferior MI. Complete heart block was seen in 12% of patients. Most of the procedure was done in femoral route. In our setup, we usually do primary PCI by femoral access, and almost half of the patient had triple vessel disease. Most common infarct-related artery was LAD, which was seen in 52% of patients, followed by RCA, which was seen in 40% of patients. Baseline syntax score was 16 plus minus 7, and residual syntax was 7 plus minus 3.7. Thrombosuction was done in 22% of patients, and post-procedure TB3 flow was achieved in 78% of patients, and the slow flow was seen in 12%, and no reflow was seen in 10% of patients. None of the patients were required IABP and use of continuous inotropic infusion during the procedure, as we have excluded the patient of cardiogenic shock at the time of presentation. State PCI of non-culprit lesion was done in 20% of patients who had angina during the follow-up period. This graph showing the primary endpoint which was achieved during index hospitalization, which was achieved in 5 patients. Out of 5 patients, 4 patients expired within the 48 hours of admission. And out of these 4 patients, 1 patient had major bleeding in form of hemorrhagic stroke, and other 3 patients had no reflow after the procedure. Later on, they developed refractory cardiogenic shock, and later on they expired. And 1 patient developed myocardial infarction due to stent thrombosis, which was immediately taken for revascularization by thrombosuction. And 2 patients had minor bleeding in form of groin site hematoma, which was managed medically. This is the primary endpoint achieved during the follow-up period in 2 patients. 1 patient expired at the end of 3 months. He had persisting severe LV dysfunction. And other patient developed myocardial infarction due to stent thrombosis in LCX territory, which was immediately taken for revascularization and discharged successfully. 2 patients developed minor bleeding. One had epistaxis, one had hematuria, which subsided on its own. This is the Kaplan-Meier estimate of survival rate at the end of 6 months. 8% of patients expired during the index hospitalization, and 2% patients expired during the follow-up period. So survival rate at the end of 6 months was 90%. Mean ejection fraction was improved from 39.48 to 44+6.2 at the end of 6 months, which was statistically significant. To the best of our knowledge, this is the first prospective study from Indian subcontinent showing in-hospital and 6-month clinical outcomes of primary PCI in elderly patients. Angiographic success was achieved in 78% patients, and it is defined as attainment of TIMI3 flow with residual diameter less than 20%. And poor TIMI flow was associated with diabetes and delayed presentation. These are the predictors of in-hospital mortality in our study. One is complete heart block, CLIP class 3, delayed presentation, moderate to severe LV dysfunction, slow flow or no reflow, and history of diabetes. In Noor et al. In an Iranian study, they showed angiography success was achieved in 73% of patients, and in-hospital mortality was 2.4%, and mortality during follow-up period was 2%. And also Bromez et al. Shown in their UK study, in-hospital mortality was 7.7%, and our study result was concordant with these above retrospective studies. ARF, acute renal failure, had developed in 5% during hospital stay, and this was transient and it recovered on its own. None of the patients required hemodialysis. We observed there is a frequent delay in presentation of these patients to hospital after onset of symptom, and efforts should be undertaken to shorten this period for better outcome. A small sample was one of the limitation. To conclude, primary PCI can be safely and successfully performed in this elderly population with the acceptable rate of complication, and further prospective studies involving a larger number of elderly patients may help to better define the risk and benefit ratio. Thank you, sir.
For the presentation, just wanted to ask you one thing. You see, you said this is in the elderly. Have you compared with the non-elderly population? Because what is the message you want to get?
In our study, there is no control group. Only 50 elderly more than 35 years were included.
Even if you have no control, otherwise case control less than 70, did you try to compare that? So message you want to say is what? Is it
yes, sir.
safe as compared to youngsters? Is it same or different?
Sir, elderly and younger patient comparison already done in various studies, and it is already established that outcomes of primary PCI in younger patient is better than elderly patient. And most of the time, elderly patients are neglected. They present with atypical presentation, and they have more complex comorbidity, so they are excluded from the various clinical trials. That's why we did this.
You have shown excellent results, 92% sort of
92%
survival.
Yes, sir, 92% at hospital discharge and 90% at 6 months. Yes.
And you said most 50% of patients had triple vessel disease.
Yes, sir.
You didn't do the angioplasty of the other 2 arteries right in the same hospital setting or no?
Sir, we address only
that is what the recommendations are.
Yes, sir. In the new recommendation, non-culprit lesions should be addressed at the time of during hospital, before the hospital discharge.
Yes. Maybe other people like to ask, Doctor.
Sir, can I ask one question?
Yes, please.
First thing, you have selected a patient who underwent PCI, or they are consecutive patient, because many of the patient you must have given thrombolysis many of the patients you have excluded. So they are consecutive patient or no? They are random 50 patient who underwent primary PCI. Then the result will be entirely different because you have chosen the stable patient, good patient. So what is this? Or
we have included consecutive 50 patients.
Consecutive 50, but you are not thrombolized any patients of MI more than 75. All patient underwent.
No. If patient is thrombolized, we have excluded thrombolized patient. We included only patient went for primary PCI.
And what is your door to balloon time?
Sir, in 60% of patient, door to balloon time was less than 6 hours, and in 40% of patient, door to
balloon time is 6 hours. Okay.
You had the choice of choosing ticagrelor, which is the in thing, and it's fairly independent of age. So why did you choose clopidogrel, or why did you choose clopidogrel over ticagrelor? Why not
ticagrelor? First thing is, age is the risk factor of higher bleeding tendency, and decreased creatinine clearance is add up in bleeding tendency. So this is a pilot study, so we only use clopidogrel in spite of ticagrelor. Although in recent trial ticagrelor is safer, and even prasugrel 5 mg is also safer, but we only use clopidogrel.
None of your patients had more than grade 3 CKD. 48% had EGFRs between 30 and 60. So the creatinine clearance was not really a great concern.
Yes,
did you measure? Did you calculate what was the average dye load that you used in patients with a stage 3 CKD?
Sir, we use a simple formula, 5 ml per kg, maximum limit of the dye, and we only used non-ionic isoosmolar dye, less than total 300 ml or less than 5 ml per kg.
Okay.
I want to ask you that out of all the patients that you took, how were there some patients taken by the radial route?
Sir, in most of the patient, we use femoral access in our study. In our hospital protocol, we generally do primary PCI by femoral access.
No, in this study, I'm asking in this particular study, were there some radial access?
Yes, sir. In our study, only 12% were used radial, and 88% we did by femoral access.
And any local complications and other things observed?
Yes, sir. In 2% there is a local groin site hematoma, but it was managed medically.
Because elderly patients are prone to have calcific and tortuous vessels and more chances of having a local site complication with femoral excess.
Yes, sir.
Okay, thank you.
Thank you very much. Thank you for your presentation.
Thank you, sir.
We move on to the second presentation. This is on clinical and angiographic profile in patients with severe left ventricular systolic dysfunction without established coronary artery disease. And to address this is Dr. Lokesh.
Sir, is my screen visible?
Yes, sir. Yes.
Yes. Good evening, everyone. The topic of my research is clinical and angiographic profile of patient with severe left ventricular systolic dysfunction without established coronary artery disease. It was done under the guidance of Dr. Trehan and Dr. Grease in GB Pant Institute of Postgraduate Medical Education and Research. Actually, the screen is not moving. Yeah. The prevalence of ischemic cardiomyopathy is increasing, and it is currently the most prevalent cause of heart failure. And the ischemic cardiomyopathy patients have worse prognosis compared to non-ischemic etiologies. And angiography should be done in patients with left ventricular systolic dysfunction to know underlying cause of what is the cause of LV systolic dysfunction. Is it related to coronary artery disease or non-coronary artery disease etiologies? Revascularization in patient with severe left ventricular systolic dysfunction is beneficial, but it comes at the cost of increased peri-procedural risks. The aim of my study was to study the clinical and angiographic profile of patient with severe left ventricular systolic dysfunction, which was defined by ejection fraction less than equal to 35%. It was a prospective observational study, and 100 consecutive adult patients more than equal to 18 years with severe left ventricular systolic dysfunction were included, and they were taken for coronary angiography. And the exclusion criteria were history of angina or past history of ACS, past history of coronary revascularization. And we also excluded patients who have NYHA class 4 symptoms. Coming on to the baseline characteristics, there was 56 male in the study out of 100 patients, and mean age of the study population was 54 years. Most of the patient presented with NYHA class 2 symptoms, 65% of patient. And coming on to the risk factors of CAD in the study population, around 1/3 patient have had diabetes and 41% patient had hypertension. The mean ejection fraction of the population was 28.6%. This bar diagram is showing that most of the patient, around 2/3 of our study patient presented in NYHA class 2. And these are the risk factors of our study population, which included diabetes in around 1/3, hypertension in around 40%, and smoking in around 35%. Most of the patients belong to subgroup of 21 to 30% ejection fraction, or around 40% of study population belong to that subgroup. So coming on to the angiographic findings, the CAD coronary artery disease was present in 36 of 100 patient. It was defined as major epicardial coronary artery stenosis more than 50%. And significant CAD was present in 34% of patients, which was defined as major epicardial coronary artery stenosis more than 70%. And coming on to the artery disease, the left anterior descending artery was the most common artery to be involved in these patients. Around 97% patient had involvement of LAD, followed by RCA and LCX. Left main coronary artery was involved in 5 patients, 5 out of 34 patients. And majority of patient had double vessel disease, 41.7% of patient. And there was significant presence of total occlusions in 41% patient. There was presence of total occlusion, and majority of patient belong to low syntax score group, subgroup. These are the pie chart and bar diagram showing majority of patient had double vessel disease, and LAD was the most common artery disease. These are some of the angiographic pictures taken from the study patient, which showing involvement of left main, RCA, LAD, and LCX. All the arteries are. So when we compare the factors associated with significant CAD in the study population, we found that the males had significantly more CAD, and older age was associated with CAD. And in the age-based gender prevalence of CAD, which was defined as males more than equal to 55 years and female more than equal to 65 years, if the patient is having this characteristic, then there was presence of significant association, and NYHA class was not associated with the presence of CAD, and risk factor of CAD, diabetes mellitus, smoking, and dyslipidemia were associated significantly with prevalence of CAD in this population. Coming on to the limitation of study, it was a single center study from North India, and the long-term follow-up of the population was not done. To conclude, there is presence of occult CAD in high proportion of patients with severe left ventricular systolic dysfunction, even when they do not have any other indicators of CAD. Significant proportion of these patients have double vessel and triple vessel disease, and there is from the study we can deduct that the significant risk factors were associated were males more than equal to 55 year and female more than equal to 65 year, presence of diabetes mellitus and dyslipidemia. And coronary angiography is safe and should be considered strongly in patient having one or more of these risk factors, and it should be done by experienced operators. Thank you.
Thank you very much for your presentation. I just wanted to ask you, you think it is quite frequent? It's only 34 out of 100 who had coronary artery disease. Did they have any echo, regional wall motion abnormalities?
Yes, sir. In echo, we excluded the patient having presence of scar, and if the patient is having LVBB and associated regional wall motion abnormality, then they were not excluded. But if there was definite presence of scar, so we excluded those patients.
So you mean none of these patients had scar or akinesia in spite of the fact they had 100% obstruction in most of them?
Yes, sir.
The second thing I wanted to ask you is this, is there something new in this that you are saying? This is already written that any patient who is elderly above the age of 40 has left ventricular systolic dysfunction should have angiography. What is new from your data?
Yes, sir. Sir, the gender-based prevalence of CAD in such patient, because if the patient is if the patient is male and having age more than equal to 55, or female having age more than equal to 65, if we do angiography in those patients, then there are significant association of CAD in those patients. So doing a high risk procedure in high risk patient, so we have to choose the good population for that.
You also concluded that it is safe.
Yes, sir.
Did any patient had any complications?
Yes, sir. Sir, 3 patients have local site complication. 4 patients had contrast injury, and but none of the patient had mortality during the hospital stay.
No, we expect left ventricular dysfunction or pulmonary edema. How many of them had it?
No,
or
sir.
Arrhythmias. You see, these are the complications we expect in a patient who is
Yes,
having
sir.
very low ejection fraction. How
Sir,
much was the dye you used? Did you
sir,
measure the dye?
Yes, sir. Because, sir, most of the patients we used less than 15 ml of contrast to delineate the coronary anatomy. So pulmonary edema was not seen in any patient.
Yes, other judges can ask, please.
I would like to ask you that in your introduction, you said that it is an established fact that these patients who come with severe LV dysfunction should undergo an angiography. It is an equipoise. It is not really recommended that everybody who comes with no history of CAD in the past should undergo an angiography to diagnose. Now, what does your study say? Does it tell us that who are the patients that we can pick up to do an angiogram?
Yes, sir. Sir, if the patient is diabetic, or if the patient is male with an age of more than 55 and female with age more than 65, and patient is dyslipidemic, these are the significant risk factor associated with presence of CAD in these patients. So if the patient is having any of these risk factors, then we can consider them for invasive coronary angiogram.
And after finding that the patient has single vessel or double vessel disease or triple vessel, then how does it help you in further management of the patient? Does it?
Yes, sir. Sir, because, sir, majority of our patient had low syntax score, so they can be managed with PCI, and some and some patient had high, intermediate or high syntax score, they can be referred for CABG for
You did
improvement.
not include ECG findings like Q
Yes, sir.
waves and LBBB in your evaluation.
Sir, we excluded patient having QS complexes in ECG or having previous evidence of myocardial infarction, but we included patient having LBBB in our study.
So that is also one indicator to pick up patients who have got obstructive coronary artery disease on the ECG. Thank you.
See, don't you think your conclusions regarding revascularization are a bit far-fetched? Because the only study which has been done and which is again very questionable is the Stitch trial.
Yes, sir.
It says revascularize them without any further testing. So you did not feel the need of any reversibility/viability testing in any of your patients prior to revascularization? Because there is no study to my knowledge in the world which says that you can do an angioplasty in the patient without doing a viability or reversibility. As I said, only Stitch is there, but that is also fraught with a lot of its own problems.
Yes, sir. Sir, ideally viability testing should be done in these patients prior to revascularization, but we did not have viability testing facility at our institution, so we did not do it.
Dr. Lokesh, what do you think was the cause of LV dysfunction in another 66% of the patients? Number one, and any of the patient had undergone stress test before the patients were taken for coronary angiography, or they were straightway taken for coronary angiography without any stress test?
Sir, stress test was not done prior to coronary angiogram, and it was only 2D. It was only Simpson method which was taken to evaluate the ejection fraction, and so second question I didn't hear.
What was the likely cause of LV dysfunction in the remaining 66% of patients who did not have obstructive coronary artery disease?
Sir, actually the 41 patient were hypertensive also, so it can also predispose to LV dysfunction, but a specific cause we could not find out a specific cause in those patients, sir. Because sir, those patients were treated as the lines of dilated cardiomyopathy. All the 100 patients were treated at the lines of dilated cardiomyopathy. So we took the patient and found the prevalence of CAD in those patients.
Okay. Go on to the next one.
Okay, I think we can go to the last one. Thank you very much for your presentation. The last presentation is on mean platelet volume in patients with acute coronary syndrome and its correlation with angiographic severity, an observation study. This is by Dr. Varsha Kaul.
Good evening, everyone. The topic of my dissertation is mean platelet volume in patients of acute coronary syndrome and correlation with angiographic severity. It was an observation study conducted at Batra Hospital and Medical Research Center. ACS has a significant morbidity and mortality. Coronary atherosclerosis progression is an active process involving complex interactions between inflammation, thrombosis, endothelial damage, and dysfunction, with an important role attributed to platelets. The normal value of mean platelet volume is 7.5 to 10.5 femtoliters. Increased MPV may be a predictor of increased platelet activation and turnover, and hence increased platelet reactivity. These observations have led to the hypothesis that increased MPV may be a potentially useful marker in cardiovascular risk stratification. The objectives of this study were to study mean platelet volume in patients of acute coronary syndrome versus controls, and to correlate the mean platelet volume with the angiographic severity of coronary artery disease, which was determined by the Gensini score. The period of study was 1 year, and it was a prospective observational comparative study. Inclusion criteria was age more than 18 years, patients with first episode of acute coronary syndrome, which included ST elevation MI, non-ST elevation MI, and unstable angina, who presented to the Department of Cardiology within 6 hours of symptoms and underwent CAG. Age and sex match controls were selected from people visiting the Health Check Services Department of Batra Hospital for a general health checkup with no past history suggestive of coronary artery disease, a normal ECG, and no wall motion abnormality on the echocardiography. We excluded patients with past history of coronary artery disease, whether they were on medical management, they had undergone PCI or CABG. We excluded patients with hematological disorders such as ITP, aplastic anemia, leukemias. We excluded end-stage renal disease, severe hepatic impairment, clinical evidence of cancer, active or chronic inflammatory or autoimmune diseases, active infections, especially viral hemorrhagic fevers. We also excluded patients with a recent blood transfusion or those on antiplatelets, anticoagulants, or NSAIDs, and patients who did not give consent or were unwilling for coronary angiography in case of acute coronary syndrome. We measured the demographic and clinical variables and recorded them. All relevant investigations like complete blood count, the kidney function test, X-ray chest, ECG, troponin, echocardiography and angiography was done, and wherever relevant, LFT, HbA1c and other tests were carried out. A 5 ml blood sample collection was done in EDTA vials for complete blood count, which included platelet indices within 1 hour of presentation to the hospital in case of ACS patients. The blood sample was analyzed in the Beckman-Coulter LH780 automated blood analyzer within 1 hour and again rechecked manually by peripheral blood smear. Angiographic evaluation of cases were done by 2 experienced cardiologists who were blinded to the study. The severity of coronary artery disease was assessed by the Gensini score, and patients were divided into 2 groups, either as mild disease with score less than 20 and severe disease with score more than 20. We analyzed the data with the help of statistical software IBM PASW version 22. Frequency tables were constructed. We calculated mean with standard deviation for continuous variables, student t-test, chi-square Fisher test, and ANOVA, as well as the Tuckey's HSD was used. The correlation was calculated between quantitative variables by Pearson's method, and a two-sided p-value less than 0.05 was considered as statistically significant. We took a total of 76 cases and age and sex match controls. The mean age of patients was 57.67 plus minus 12.11, out of which 76.3% patients were males. Most cases, that is 60.6%, were in the age group of 55 to 75 years in both sexes. Female patients with ACS were found to be significantly older than males. Among patients with ACS, about 60.6% had ST elevation MI, 19.7% each had non-ST MI and unstable angina. Out of patients of ST elevation MI, 34.2% had anterior wall MI, 25% had inferior wall MI, and 1 patient had true posterior wall MI. The most common risk factors for coronary artery disease in this study were smoking in 59.2% patients, followed by a positive family history in 50%, hypertension in 40.8%, and diabetes in 39.5%. The mean LV ejection fraction of ACS patients was 46.55 plus minus 8.71%. All patients were given guideline-based medical therapy. The most common modality of treatment in ACS patients was PCI in 56 patients. 1 patient underwent CABG and 6 patients received thrombolytic treatment, out of which 3 had to undergo rescue PCI. 17 patients were put on medical treatment, which included 7 patients who had refused revascularization. 3 patients succumbed to death, 2 in the non-STEMI group, out of which 1 had undergone PCI, and 1 in the STEMI group who had also undergone PCI. The mean platelet value of cases was 11.25 plus minus 1.42 femtoliters, which was significantly more than that of controls, that was 9.27 plus minus 1.12 femtoliters, with a highly significant p-value of 0.000. As we can see in this, the MPV of STEMI group was 11.54, of non-STMI was 11.03, unstable angina was 10.54, and that of controls was 9.27. There was significant difference between the MPV between STEMI and control, and also between NSTEMI and control, and also unstable angina and controls. But there was no significant difference between the MPV between STEMI and non-STEMI group, and also between non-STMI and unstable angina group. However, there was a significant difference in MPV between STEMI and unstable angina. In this study, most patients had single vessel disease in 61.8%, followed by double vessel in 19.7%, triple vessel in 11.8%, and non-critical coronary artery disease in 6.6%. There was a statistically significant difference in MPV between the 4 groups. The mean Gensini score of ACS patients was 45.58 plus minus 33.82. 19.7% cases had a Gensini score less than 20 and were characterized as mild CAD with a mean score of 11.43. 80.3% had a Gensini score more than 20 and were characterized as severe CAD with a mean of 53.98. Severe CAD was seen in 68.9% patients with STEMI, 80% patients with non-STMI, and 46.7% patients with unstable angina. The difference between the three groups with respect to the Gensini score was statistically significant. MPV was significantly higher in patients whose Gensini score indicated severe CAD as compared to those with mild CAD. There was significant correlation between mean platelet volume and Gensini score, with a correlation coefficient of 0.497 indicating a positive modest correlation between the two. This is the scatter plot showing a relationship between the MPV and the Gensini score. Then this is the baseline demographic and clinical features between the cases and the controls. The mean age was 57.6 of cases and controls was 57.4. There was no significant difference. Males were 58 in both the groups. Hypertension was prevalent in 40.8% cases and 34.2% controls, which was not significantly different. Diabetes was prevalent in 39.5% cases and 21% controls, which was again insignificant. Smoking was present in 59% cases and 30% of controls, which was highly significant. Family history of CAD was seen in 50% of cases and 32% of controls, which was again statistically significant. The mean platelet volume of cases was statistically more than that of controls. Then coming to the length of stay in hospital, it was 4.6 in case of STEMI, 4.53 in case of non-STEMI, 4.13 in case of unstable angina, which was statistically insignificant. Duration of symptom was 4.2 hours in case of STEMI, 4 hours in case of non-STEMI, and 3.5 hours in case of unstable angina, with no significant difference, statistically significant difference. The mean LV ejection fraction was 44.89 in case of STEMI, non-STMI was 45%, and unstable angina was 52%, which was statistically significant. The mean platelet volume was 11.54 in STEMI, 11.03 in non-STEMI, 10.54 in unstable angina, which was again statistically significant. The mean Gensini score was 49.9 in case of STEMI patients, 54.23 in case of non-STEMI patients, 23.4 in case of unstable angina patient, which was statistically different between the three groups. So to conclude, mean platelet volume is an indicator of hemostatically active larger platelets, which play a pivotal role in accelerating the formation and propagation of thrombus, leading to the occurrence of acute thrombotic events. In this study, we found mean platelet volume to be strongly associated with acute coronary syndrome, as well as with the severity of coronary atherosclerosis. The limitation of this study was that it was a single center study, and larger studies need to be conducted before these results can be generalized to the entire population. Also, the normal range of MPV varies with different instruments in different laboratories, hence its cutoff value will need standardization. The take-home message is that MPV is an indicator of acute thrombotic events and is a simple, non-invasive, inexpensive, and readily available laboratory measurement. Since MPV is easily provided by automated equipment when a CBC is requested, patients with elevated MPV could benefit from early screening and preventive treatment. MPV can be considered as a useful rollout test along with other conventional cardiac biomarkers for risk stratification of patients with acute chest pain admitted to the emergency department, especially in the smaller centers, and help to lower hospitalization, misdiagnosis, as well as the complication rates. As MPV has been shown to be associated with the angiographic severity of CAD, it might be helpful in prognostication of patients with acute coronary syndrome. Thank you.
Thank you very much for this interesting paper. I just like to, I don't know much about this MPV. I just want to know what is the reproducibility of this method. Suppose we do it reproducible in the same patient twice or at different labs it is done. As you said, it is not at different labs, it may be different. So what is reproducible in the same lab?
In the same lab, it's highly reproducible because we are using the same instrument and we are calculating it by the same method. Like we are using
Have you done it twice at least in these patients? So these patients are unstable.
In the patients who had a prolonged duration of stay more than like 2 or 3 days, the CBC was repeated. So it was almost.
But if it is repeated, then these people are taking drugs. You know, these aspirin, etc.
Yes.
And you have a large number of patients who had ST elevation MI.
Yes.
Many of these patients must have received, you see, aspirin.
Aspirin and all.
Does the aspirin change this MPV or not?
Definitely, sir. It must be changing because it has a role on the platelet function.
Then
And
did you analyze it separately, those
no,
who were
sir.
taking drugs or not?
No,
Because
sir,
the drugs
because
will change it. Finally, you see, your control group, the smokers are much less, half of them.
yes,
60% are smokers. So
This is correct.
smoking will also change it, isn't it?
Yes, sir.
There are many variables which are there. So before one can say that this is useful, one has to clarify all these things, because as a layperson, reproducibility especially, if you have done the same thing twice or thrice. Yes, maybe the other judges would like to.
Yeah, I would like to ask you that what was the reason to exclude patients of ACS who are coming beyond 6 hours? And secondly, you have also excluded patients like, was it ethically correct of patients who are STEMI and coming for angiography and followed by primary PCI, not to give DAPT, clopidogrel and aspirin? You said the patients who were on DAPT were excluded.
Yes, sir.
And when did you take the sample? Before taking the patients for an angiography or after that?
Before taking the sample. Whenever a patient comes to our casualty and when we are preparing for the angio or shifting the patient to the cath lab, at that time only we draw the samples for all the tests, including troponin. So this was also collected before the angiography, and we tried to process it within 1 hour of collection as far as possible.
Secondly, you have in your conclusion, and you have said that it is highly correlated with the Gensini score. And in your observation also, you have mentioned that it was highly significant, but you haven't shown any
correlation.
Correlation has not been shown. No slide to tell us how much was it in mild, how much was it in severe Gensini score to say that it was highly significant.
Sir, I have the table. If you will allow me, I'll show you.
No, now there is not much time. We can't.
Anyway, that's all.
Other people can ask, yes.
Yeah,
Dr.
thank
Varsha, you must have reviewed the literature.
Yes,
Is
sir.
there any correlation with the troponin levels and CPK levels of platelet volume? Because it is more raised in acute coronary syndrome. And we always know that the degree of elevation of troponin levels or CPK levels is also correlated with the damage that is occurring. So is there any correlation between the two in the literature? Although you have not studied, but you must have gone through the literature.
In the previous studies that I've reviewed, there was a relation between the MPV and the level of troponin. And there was a positive correlation between the two. The higher the level of MPV correlated with the higher level of troponin.
Dr. Varsha, there are a lot of studies currently going on in the country on this particular topic. There are many. I can offhand recall at least two people whose thesis I corrected, and they used the similar, parameters within the country. Is there anything new that your study presents? Over what is going on currently in the country?
Sir, this is because it is easily available, and I was trying to find out a biomarker which we can study within the 6 hours. First 6 hours when the troponin and other markers may not be elevated. So I took this test. Plus, MPV is easily available when we do a CBC, and almost every patient we admit for whatever reason, and also in patients who come for a routine health checkup. So we do a CBC, and in that we can get the value of MPV. So in patients who have an elevated MPV, even though they are not patients of ACS, we can screen them for risk factors and other things which can help in prevention of CAD, or we can diagnose them early. And CBC is available across all centers, even in smaller centers where troponin and other tests may not be available. So we can screen patients for coronary artery disease using this test.
Thank you.
Is there any cutoff value above which you will say, yes, this could be a patient of acute coronary syndrome? Only then you could have a clinical implication. That if there was a cutoff value and you can say, yes, above this level, it could be acute coronary syndrome in a small hospital.
But in our study, the mean value was 11.7. So it was relatively higher than the usual maximum level, which is 10.3, 10.5 that we take in most labs. So
do you think any value above 10.5 would be significant to consider acute coronary syndrome?
Yes, not 10.5, but maybe 11.5. the way we had in our study.
Dr. Varsha, my question is that MVP depends upon a lot of other factors like smoking, diabetes. So you have not done a multivariate analysis because everything you have shown in a univariate analysis.
Yes, sir.
The univariate analysis is always fallacious until you do a multivariate analysis in this situation. So you have done a multivariate analysis or not? And second, you have done a platelet dysfunction test or not, function test or not in these patients?
No functional testing was done in this study.
Because it is proven that majority of these patients who are diabetic smoker, they have platelet dysfunction. So whatever the level of mean platelet volume, if there is a platelet dysfunction, it will have an entirely different finding.
Yes, sir. There was no functional testing done, but patients with other disorders which could lead to platelet dysfunction, like the hematological disorders and all, cancers, the autoimmune disorders, and those who were already taking antiplatelets, anticoagulants, they were excluded from this study. But yes, no functional testing was done.
Okay, thank you.
Thank you.
You're welcome, sir.
Thank you so much, all the judges. Thank you, all the three presenters. You have done a great job. And this brings us to the end of the Cardiological Society of India Delhi branch symposias also, and the final KL Chopra Award. And I request all the judges, we have the results of the first presentation. I request all the judges to please quickly chat me, send me the results of 1, 2, 3 on the chat numbers. I'll total them and project the result of this session. In the meantime, let me just mention the results of the first one. According to the judges, as the results have been given to us, the winner of the, okay, let me project the results of both. I'm just getting, just a minute. Rakesh sir has already sent me. Kindly, all the judges, please quickly send the numbers so that I can total them.
How do we send it?
Yeah.
Ashwin.
On the chat or on the personally, I will total it. It's been a great virtual journey for 1.5 days. It was an academic extravaganza, great new experience for all the members and EC and all our seniors. And this is a new avatar that CSI Delhi branch has taken. And we really hope to meet live next year if we are able to conquer this COVID times very soon. So, okay, thank you. I've got another one. Dr. Pandit sir. Okay. 60. Results from Manchanda, sir.
Yeah.
Yeah, please send me, sir. All the three, sir.
How do I send?
Sir, on the chat, sir, or you can send me on the WhatsApp.
On the WhatsApp will be better.
Manchanda, sir, have you sent it to me, sir?
Yeah, I'm sending it.
Yeah, please, sir.
You want all the three?
1, 2, 3, sir. I'll just total. I have the results of other people. So.
Okay. You got it?
Yes, sir. Sir, have you sent the numbers? I need the numbers, sir. I have to total, like everybody has sent the numbers, sir.
Oh, numbers. This is out
Yes,
of
sir.
how much percentage?
Yeah, out of 100. Yes.
Okay, okay.
Numbers, sir.
Yeah, I'm sending it. Yeah, this percentage.
Anything, sir. Out of 100, just mark the numbers. X, Y, Z, and I'll just total. I have the numbers of other 3 judges.
You bought it?
Yes, sir. Just a minute. 16. Okay, sir. I'm projecting the results now. Okay, according to the judges, we have the pleasure of announcing the result for this year's Sujoy B Roy Award, and the Sujoy B Roy Award for this year goes to Dr. Arvind Balaji. Dr. Arvind Balaji, he presented a great research paper, and scored the hat. Arvind, congratulations to you. And on behalf of the Cardiological Society of India, Delhi branch, and all the judges, respected Kharula sir, Dr. Sanjay Tyagi sir, Professor Anita Saxena ma'am, and Professor Kothari, and all the members, we congratulate you for a great presentation. And it's not about just winning. I believe that participation is more important, and all of you have presented your work, and that itself is an achievement. So congratulations, and we'll be mailing you the trophy as well as the certificate very soon from the society. And the second award for the KL Chopra, according to the judges, when I total, it goes to Dr. Ankur Gautam. So Ankur, if you are available, can you please come? Dr. Ankur Gautam?
Yes, sir, I'm here.
Yeah. So, Dr. Ankur Gautam, congratulations to you for achieving the Colonel KL Chopra Award. And as per the results given by all the 4 judges, thank you so much. And this trophy and the certificate will be mailed to you soon. On the behalf of, again, the EC committee, I really extend my heartfelt thanks for the successful completion of this year's Delhi CSI conference. It's been a great journey. We have been waiting for this moment for almost many months now. And thank you so much for wonderful participation for our seniors. And we really look forward for the next edition, 35th edition of the Cardiological Society of India Delhi Branch Conference early next year. And thank you. And all these sessions will be available online, and separately links will be also sent to you. Thank you, and have a very good day and a good weekend.
Thank you.
Thank you so much. Thank you so much.
Congratulations for a very successful conference, right? Very well conducted. Thank you. Right.
Thank you so much.